വിരിപ്പിൽ ചന്ദനക്കട്ടിലിൽ പാതിരാ വിരിച്ചിട്ട ചെമ്പക വെൺമലർത്തൂവിരിപ്പിൽ മധുവിതുരാവിന് ചുണ്ടുകളിൽ പ്രേമ മകരന്ദ മഞ്ജരിയേന്തി മധുവിതുരാവിന് ചുണ്ടുകളിൽ പ്രേമ മകരന്ദ മഞ്ജരിയേന്തി താനേ തിരിഞ്ഞും മറിഞ്ഞും തൻ താമരമെത്തയിലുരുണ്ടും മയക്കം വരാതെ മാനത്ത് കിടക്കുന്ന മധുമാസ സുന്ദര ചന്ദ്രലേ.
Thank you, Dr. Sunit, for your mesmerizing performance. Let's move forward to yet another scintillating semi-classical dance from Dr. Deepa Binod, consultant pediatrician from Trivandrum, Kerala.
Ta jum rum ta rum ta dhalam ku tak de ku da de tang gid gid ta jum ta ka jum jum ta takita ta da ta jum gid jum ta ta tanum ta ta rum ta takita ta de tang gid ta tarita ta dhanata ta runata ta dimita ta da jum ta tanum ta rum ta gadim ta gid ta dim ta tarigid ta jum dim da ta jum nam da ta jum tam ta kita dana ta tangir tarigid dim ta tarigid ta jum dim da ta kita jum jum da kita da jum ta jum da kita ta jum kita tarigid ta jum tarita ta dana tarita ta tarigid ta dhanata jum tarita dhanata de tangir ta tarigid ta jum dim da ta jum nam da ta kita jum ta dim tum nam ta de tangir ta di ta dhanata ta tarigid dhanata ta dim ta tarita ta dhanata ta di ta dhanata de tangir ta dim tarigid ta dim tarigid ta dim tarigid ta jum tarigid ta tangir tarigid dingir tarigid ta
Thank you, Dr. Deepa, for this wonderful performance. Dr. Benno is a consultant neonatologist from Trivandrum, Kerala. Let's listen to his song and sing into the depth of his voice.
कुछ सोच के बोला होगा तुमने, ये प्यार भी तोला होगा तुमने। अब ना है तो फिर ना सही दिलबर, इस दिल को ये समझा लिया हमने। इसमें तेरा घाटा मेरा कुछ नहीं जाता, ज्यादा प्यार हो जाता तो मैं सह नहीं पाता। इसमें तेरा घाटा मेरा कुछ नहीं जाता, ज्यादा प्यार हो जाता तो मैं सह नहीं पाता। कुछ खासता ये जान लेती जो मेरी नजर से देखा होता तुमने, इस बात का बस गम हुआ मुझको। थोड़ी सी भी कोशिश न की तुमने, इसमें तेरा घाटा मेरा कुछ नहीं जाता, ज्यादा प्यार हो जाता तो मैं सह नहीं पाता। इसमें तेरा घाटा मेरा कुछ नहीं जाता, ज्यादा प्यार हो जाता तो मैं सह नहीं पाता। सोचा नहीं था जिंदगी में यूं मिलोगी, मिलके भी तुम ना मेरी हो सकोगी। याद आएगी जब भी तुम्हारी शिकायतें ना होगी, बस दुआ रहेगी। अब और क्या कहना होगा हमने, करना था जो कर लिया तुमने। शायद रहूं या ना रहूं दिलबर, बदला कभी ये फैसला तुमने। इसमें तेरा घाटा मेरा कुछ नहीं जाता, ज्यादा प्यार हो जाता तो मैं सह नहीं पाता। इसमें तेरा घाटा मेरा कुछ नहीं जाता, ज्यादा प्यार हो जाता तो मैं सह नहीं पाता।
Thank you, Dr. Benno. Dr. Bijoy Thomas is not only a consultant neurologist, but also a great artist. Let us go through his canvas and see what wonders has he done with his brushes and colors. Thank you, sir, for that visual treat. After all these fabulous performances from our doctors, we will start our first official session of the day at sharp 9 a.m. Thank you. Hello, everyone. Let's move on to the first official session of the day. Past 2 days have witnessed a continuous flow of knowledge and information, which was indeed a golden opportunity for every doctors related to pediatric neurology to get updated and sharpen the tools in their armor. With immense pleasure, I invite Dr. Minnie S., Organizing Secretary, to deliver the welcome address. Over to you, ma'am.
Good day and warm welcome to all the distinguished faculty and delegates. Today is the third and the final day of the Child NEUROCON 2021, the 11th AOCN Annual International Conference. We will just have an overview of the sessions on the previous 2 days. We had a very lucid and informative presentations by eminent national and international faculty who are experts in the topic they discussed. We had sessions covering almost all areas of child neurology. The sessions included interactive sessions on neuroimmunological disorders, neurodevelopmental disorders, neuroinfections, neuromuscular disorders, neurointensive care, pediatric stroke, perinatal neurology, neuroradiology, neurogenetics, epilepsy, and the common disorders which we face in our daily practice, like headache and febrile seizures in children. We also had two debates, one on neuromuscular disorders and the other on febrile seizures, which added flavor to the scientific feast. Another highlight was the hotly contested platform paper presentations by the residents and the consultants and colleagues from allied specialties. Today, we will continue with a scientific session on epilepsy and the rescheduled talk on dyskinetic cerebral palsy by Dr. Biju Hamid. Dr. P.A. Mohammed Kunyu, our organizing chairman, will be delivering the keynote address today. We will also have an official inaugural function by our AOCN official team. The prizes for the paper presentations and e-posters will be announced by Dr. Biju Hamid during the valedictory function. So stay connected till that time. Thank you from the Conference Secretariat.
Today's academic sessions are special because all the speakers are office bearers of AOCN and stalwarts in their respective fields. We have dedicated this day to epilepsy. The first session is on vitamin responsive epilepsies and recent advances on the dreaded neurological emergency, status epilepticus. This session will be in two parts and will be chaired by Dr. Meena Krishnan, Consultant Pediatrician, SK Hospital, Trivandrum, and moderated by Dr. Rose Perry, Consultant Pediatric Neurologist and Critical Care Specialist, Cosmo Hospital, Trivandrum. Over to you, ma'am.
Thank you. Today, the first topic will be vitamin responsive epilepsies. I invite Dr. Kavita Srivastava, who is the president-elect of AOCN for the next term, to deliver the topic. She is the professor and specialist in pediatric epilepsy and neurology at Bharati Vidyapeeth Medical College, Pune. She is a faculty and coordinator of the IAP Fellowship Program in Pediatric Neurology. She is also a member of the Task Force on Seizures and Epilepsy in the Tropics of the ILAE. She is a principal investigator for several research projects and several publications. She is also chief editor of the Pediatric EEG Basics for Pediatricians. Over to you, Kavita Madam, to present the topic.
A very good morning to all of you. And at the outset, I want to thank AOCN and ICNA for giving me this opportunity to present vitamin responsive epilepsies in children. So what we'll be going through is a case-based approach to identify the different phenotypes of vitamin responsive epilepsies, how to plan investigations, and how to manage empirically and then definitive therapies according to the final diagnosis. I have no disclosures to make. So we'll start with the first case. Now this is a 10 months old baby and brought with these kind of continuous abnormal movements which were misdiagnosed as seizures because they were continuously present. The baby was a little encephalopathic, and for that he was loaded with injection phenobarbital, levetiracetam, and even intubated and put on midazolam drip. So the initial development was normal, but in the last 1 month, he had started having decreased interest in surroundings and even stopped babbling. The birth and family history were otherwise normal. So when we looked at the investigations, the initial electrolyte sugar calcium profile was normal. The bedside EEG showed only excessive delta activity. So there was no correlate of these movements, and that's how we came to diagnose that these are not seizures. The skin showed this particular reticular pigmentation as well as knuckle hyperpigmentation. The CBC showed a macrocytic anemia. Serum B12 levels were not detectable and homocysteine levels were borderline high. So this child was started on injection B12 and he improved rapidly. All the antiepileptics could be stopped. So nutritional B12 deficiency in infancy happens to exclusively breastfed babies who are born to mothers who do not consume animal products because that is the only source of B12 like meat, egg, fish and milk. And although lots of vitamin supplements are given during pregnancy, most of them do not have adequate B12. And it is said that a normal baby with adequate stores, even 25 micrograms of B12, is sufficient to last for 6 months. So this syndrome is known as infantile tremor syndrome. And you can see even after recovery, there are few tremulous movements. Even the tongue and even the laryngeal muscles may have a tremor, which can give rise to a goat-like bleating cry. So this is a tetrad of skin changes, tremors, and developmental delay or regression. And it is a treatable condition with B12. Initially, we give IV till the encephalopathy improves. Then this weekly intramuscular, then monthly intramuscular, and of course, dietary changes have to be made. The prognosis is fairly okay, but some of these children, if they are having this long-standing deficiency, may land up with cognitive sequelae like poor scholastic performance. So this is also reiterated by one of the other papers where they found that involuntary movements were misdiagnosed as seizures during B12 treatment. So what is B12 doing in our body? So if you see from the diet, when we get the B12 from the non-vegetarian sources, in the stomach, it is combined with the intrinsic factor, which carries till the terminal ileum, where it is absorbed into the circulation and is attached to a protein called transcobalamin. Now, this transcobalamin is also important for the entry of cobalamin into the cells. And once it is cleaved from transcobalamin, this cobalamin enters into two pathways, either the methylcobalamin or the adenosylcobalamin. Now, this methylcobalamin plays a very important role as a cofactor for methylation of homocysteine, which is generated during the methionine degradation. Now, methionine is readily available from the diet and is a major source of the methyl groups, which take part in methylation reactions and is like DNA synthesis. And once the methyl group comes out of the methionine, it is degraded to homocysteine. This homocysteine has to be then again regenerated into methionine by methylation, and this methylation is helped by this B12, which is the methylcobalamin form, and it has to be kept in a reduced state by another enzyme. And the enzyme which facilitates the conversion of homocysteine to methionine is the methionine transferase, which is encoded by MTR gene. So B12 is actually acting as a conduit between two pathways. The methyl group is donated by the folate cycle, which is again, folate is abundant in the diet, and through a series of reactions, this 5-methyl tetrahydrofolate donates its methyl group to the final conversion of homocysteine to methionine. Here also we require the cofactors of B6 and riboflavin. So you can see that these 4 key vitamins are involved in the methionine cycle or the methylation pathway. And if there is any defect right from the dietary deficiency to formation of methylcobalamin or these two enzymes or even the MTHFR pathway, some of the polymorphisms can adversely affect the formation of methionine from homocysteine. And in these conditions, we will get high homocysteine while low or normal methionine. The other pathway which homocysteine is degraded through is the transsulfuration pathway, which involves the cystathionine beta synthetase gene enzyme, and this is facilitated by the cofactor, which is the vitamin B6, which is pyridoxine, and it is ultimately forming cysteine, which forms glutathione and also takes part in the energy metabolism. So these are the two ways in which we may have high homocysteine levels, either a block in the methylation pathway or in the transsulfuration pathway or anywhere defect in the cobalamin synthesis and utilization in the intracellular level. So if there is a block in this pathway, you can have high methionine as well as high homocysteine. So we come to the next case. Now, this was a 4-year-old girl who started with the seizures since the age of 13 months, which were not responding to antiepileptics. She developed increasing hyperpigmentation as well as there was a very strong family history and regression since the last 1 year. So when she was brought to us, she was having this kind of encephalopathy, spasticity, these involuntary movements, including tremors and dyskinesias. And on examination, she had hyperpigmentation. EEG showed an encephalopathic background. MRI showed generalized cerebral atrophy. So we thought of B12 deficiency again, and the CBC also showed a megaloblastic anemia. But her B12 levels actually came normal and homocysteine was very high. So she was again started on injection B12 and she showed a dramatic improvement. You can see by the end of the third day, she had started at least cognitively responding. She's following the at least the objects, and on discharge, she was after 1 month we repeated the homocysteine, which had improved to normal levels, and this was her video at the end of 1 month. You can see that cognitively and interaction wise she has improved much more, although there was still a lot of spasticity present. So this, because of the family history and normal B12 levels, we wanted to say where is exactly is the defect in this pathway. And so we sent the exome studies, which showed a mutation in the MTR gene, which is the gene for methionine synthase enzyme. And this is classified as homocystinuria with megaloblastic anemia, CBLG complementation defect. So what are these complementation defects? I'll just show you in a moment. So when the cobalamin, transcobalamin is entering the cell, it enters the lysosomes where it is cleaved. The free cobalamin enters either of these two pathways after a series of reactions. These reactions are known as the complementation products. So the pathway which enters the Krebs cycle in the mitochondria is the adenosylcobalamin pathway, and it facilitates the conversion of methylmalonic coenzyme into succinyl coenzyme. So if there is a defect in this pathway, these complementation defects will give rise to methylmalonic acidemia. The other pathway goes to formation of the methylcobalamin, which I have just discussed, which is important in the methylation of homocysteine. And these are the complementation defects. So our patient had the G defect. If there is a defect in the initial pathway, so complementation I, E, J, C, D can give rise to defects in both the pathways. So you will have methylmalonic acidemia as well as homocystinuria. So these are a list of all the complementation defects, and they are rare disorders of B12 intracellular metabolism. Some children may present with spastic paraplegia, some may present with acute neuroregression in infancy, and our patient had CBLG mutation complementation defect affecting the methionine synthase. Now I come to the next case. Now this was an 8-month-old baby admitted with these kind of ocular movements and tremulousness. You can see the EEG showed burst suppression. There was a positive family history of seizures. MRI was, however, normal. So this baby was again pending the investigations. We started on B1, B6, and B12 because there was no structural cause for these seizures, assuming a channelopathy or a metabolic disorder. The metabolic workup showed elevated homocysteine and CSF blood glycine were normal. So we sent the exome studies, and what it showed was a defect in the mutation in the cystathionine beta synthetase enzyme, which I have already showed you is the degradation pathway from homocysteine to cysteine through the transsulfuration mechanism. And this requires B6 as a cofactor. So you can have, depending on which mutation, you may have with or without response to pyridoxine. Fortunately, our patient responded with pyridoxine. The next case, the same pathway can give rise to a very different phenotype. This was a 13 years old male child and had 2 brief seizures in last 1 month and now presented with status epilepticus and coma. He received anti-epileptic drugs. He had left hemiparesis, signs of raised ICP, pupillary asymmetry. So he came with a very acute kind of presentation like a stroke. So we did a stroke protocol which showed acute hemorrhagic infarct in the right frontal region. There was cerebral venous thrombosis, and this was the ischemic areas. This child had a very significant past history. So at the age of 7 years, he was taller than his peers. You can see the marfanoid habitus. He had visual difficulties for which he was evaluated and found to have medial and inferior lens subluxation. He underwent bilateral lensectomy, and you can see the long slender fingers. He also had poor scholastic performance and severe behavioral issues, because of which he left the school. So he was diagnosed with homocystinuria at the age of 7 years, but there was very poor compliance because of the behavioral issues. And this was his photograph at 13 years of age, just before he developed the stroke. So you can see the Marfanoid habitus, the arm span was longer than even his height, and the long hands and feet. And he was wearing these very thick lenses because of the lensectomy. So when we did his investigations, his homocysteine was very high, methionine was also high, and on discharge he was left with a permanent hemiparesis and dysarthria. And younger female sibling was screened. She also turned out to have high homocysteine and methionine levels, and we have started treatment for her. So this is the classical homocystinuria where the ophthalmic findings appear after 3 years. There is progressive intellectual disability, psychiatric and behavioral disorders, Marfanoid features, and they are likely to get thromboembolic episodes if the homocysteine levels are high. So as I've already shown you the pathway, this is the cystathionine beta synthetase enzyme, which is also affected in children with classic homocystinuria. So we can give what is known as betaine. We donate some methyl group directly and can convert homocysteine to methionine. So apart from giving the B12, B6, carnitine, folic acid, etc., with methionine restriction, betaine helps in conversion of this high homocysteine to methionine. So what is the mechanism of these thromboembolic infarcts? Although the exact mechanism is not clear, some authors have proposed that this homocysteine is ultimately converted to glutathione from cysteine, and this glutathione has a big role in preventing oxidative stress to the mitochondria as well as detoxification processes, because it acts as a free radical scavenger. So when these processes are hampered, there are high chances of getting thromboembolic episodes, which is the classical phenotype in classical homocystinuria. So the treatment is for deciding whether it's B6 responsive or unresponsive. There is a protocol in place that you give first B6 and then monitor the homocysteine levels. And if they do not respond, then you label them as partially responsive. You start with restriction of methionine and cysteine supplementation, though dietary role is controversial. And of course, addition of the betaine, as I already said, trimethylglycine. So this methyl group is directly donated to homocysteine to convert it to methionine. Now this is another case. This is a 20-day-old baby who came with these kind of movements, very frequent oculogyric kind of movements, and this baby was very hyper alert, agitated, restless. He was treated with 2-3 antiepileptics but no response, and the parents had not slept for days together. His EEG showed burst suppression, MRI was normal, and a trial of IV pyridoxine was given in view of refractory seizures. But after giving pyridoxine, though the seizures stopped, the baby became very deeply encephalopathic, required oxygen for one day, and then once he recovered from that encephalopathy, there were no further seizures. The EEG also normalized. This was the EEG after 24 hours, and the baby recovered completely in the next 2 days, started feeding well, and no further seizures. The parents also reported sleeping peacefully for the first time. So he was discharged on oral pyridoxine, weaned off all the antiepileptic drugs. So this is a patient with pyridoxine-dependent epilepsy. So what is the role of B6 in our body? I've already said it is taking part in the folate cycle as well as a cofactor for the cystathionine beta synthetase, which is the homocysteine degradation pathway. But it is an innocent bystander which gets affected in a lysine catabolism pathway. So if we see the lysine metabolism, there is a enzyme called antiquitine, which is aldehyde dehydrogenase. And this enzyme is, if it is deficient because of a mutation, then the precursor, which is AASA, gets elevated, which is in equilibrium, which gets converted to this piperidine 6 carboxylate. And this can be detected by a surrogate marker called pipicolic acid. Now, once this product is formed in high levels, it binds irreversibly to pyridoxal 5-phosphate and just blocks it. So pyridoxal 5-phosphate cannot do any of the activities which it is supposed to do. I'll just show you what are its functions in the cell. So this antiquitine gene mutations can give rise to secondary pyridoxine dependence, and this is the commonest cause of pyridoxine dependent epilepsy. So in our patient, in those days, these investigations were not available in India. This was sent to a Zurich lab. We found AASA levels were high and antiquatin gene mutations were also present. So this was a child confirmed with vitamin B6 dependent epilepsy. So the other problem which can be there in the metabolism of B6 is the mutation of the enzyme PNPO, which is pyridoxine phosphate oxidase. So all dietary types of pyridoxine, which are pyridoxal, pyridoxamine, have to ultimately be converted to pyridoxal phosphate through this enzyme, and then only they can participate in the intracellular reactions. So sometimes if the patient is not responding to B6, you may have to give pyridoxal phosphate to overcome the metabolic clock, because giving pyridoxine here will not help you. So this is the second type of pyridoxine dependent epilepsy, which is known as PLP dependent seizures, and these mutations can give rise to similar kind of picture. So what is the PLP doing? How is it important? It is an important cofactor for so many of reactions, but more so for the neurotransmitter pathways. For example, tyrosine to dopamine, noradrenaline, tryptophan to 5-HT and serotonin, glycine cleavage, and most important, glutamate to GABA. We all know glutamate is an excitatory neurotransmitter, GABA is an inhibitory neurotransmitter. So when you give B6 to a child with this dependency, suddenly all this glutamate is converted to GABA, and because of surge of GABA, these patients may develop encephalopathy and even respiratory depression. So always this should be given in a control setting that facilities for respiratory support are available. That is what had happened in our child also. So that doesn't mean that we remove the pyridoxine. We continue that. Only thing is we need to support it till this GABA surge subsides. So pyridoxine, the classical pyridoxine dependent epilepsy will respond to pyridoxine, and the child remains seizure free after withdrawal of all antiepileptic drugs. And we have to give 15 to 30 milligrams per kg per day of pyridoxine. Maximum is 500 mg. This dose should not be exceeded because it can cause peripheral neuropathy. There are certain atypical forms where they start with HIE and intractable seizures, or they give partial response to B6, or they don't relapse even after stopping B6. And as I showed earlier, pyridoxal phosphate should be tried in pyridoxine unresponsive seizures, which is the dose of 30 mg per kg per day. And folinic acid responsive seizures is also an allelic disorder to the pyridoxine dependency. And here we need to give folinic acid and not folic acid. In severe cases, you may have to give lysine restricted diet with or without arginine, and monitoring of AASA levels is recommended. So just a slide to show the difference between the PLP dependent seizures, which are much more severe. You have prematurity, you may get hypoglycemia, lactic acidosis, elevated glycine and threonine, because PLP is part of lots of metabolic reactions, carboxylation, transamination, etc. And you will have the neurotransmitter abnormal analysis, while in your antiquatin related pyridoxine dependent seizures, the only two markers which are abnormal are the elevated AASA and the pipicolic acid. So this is about the B6. Now I come to the last case, which is, this is a 20-day-old baby with sepsis and an ICU stay. He started developing myoclonic and clonic seizures, again not responding to multiple antiepileptic drugs. He was noted to have these rashes, and his hair, the sister noted that his hair was just coming out very easily. It was just coming out in bunches like this. EEG showed burst suppression, and MRI showed these bilateral hyperintensities in the basal ganglia. So this, the metabolic workup showed lots of abnormalities. There was metabolic acidosis, large ketones, sugars were fluctuating. TMS showed elevated C5 metabolites. His biotinase levels were very low, and this was suggestive of profound biotinase deficiency. So he was started on a metabolic cocktail including biotin, and this showed a dramatic response. We could stop all the antiepileptics. You can see the skin has improved, and the hair, which had all gone, had started coming back. Presently, the child is 5 years old and does have sequelae of the hypoglycemia, has spasticity, hearing loss, and optic atrophy. So depending on the damage to the basal ganglia and secondary metabolic abnormalities like hypoglycemia causing damage, some of the effects may be irreversible. So what is the role of biotin? So biotin is freely available in the diet, and it actually converts the inactive carboxylases into active carboxylases, which are involved in carboxylation of all the three subgroups like proteins, fats, and carbohydrates. But this biotin has to be reutilized in the pathway. So biotinase enzyme, it actually cleaves the biotin from these active holocarboxylases and makes it available for the next cycle. So whenever there is a biotinase deficiency or in the diet there is something like evidin which binds the biotin. Now this is present in the raw eggs, or if there is a holocarboxylase synthetase deficiency. The manifestations may be similar, so they can start with seizures, they can have skin rashes. So our patient had actually biotinase deficiency, which was proven on the exome studies. So the just a summary of the pharmacological considerations for suspected vitamin dependent epilepsies. So we give pyridoxine, we give pyridoxal phosphate if required, add biotin, folinic acid, either stepwise or in a patient where the baby is having very severe, at least start with pyridoxine, biotin together. And of course, in Indian scenario, if you're suspecting B12 deficiency, then B12 should also be a part of this cocktail. So there is, just briefly, I'll scroll through the different vitamins which are important in child neurology. Vitamin D deficiency is a common cause of hypocalcemic seizures in our country. Low vitamin K levels can give rise to HDN. B12 is also associated with subacute combined degeneration of the cord, riboflavin responsive condition, one of them is BVVL. Plus, it is also part of the folate cycle, as I've shown you. Biotin thiamine responsive basal ganglia disease can present with subacute encephalopathic crisis. You have thiamine responsive pyruvate dehydrogenase deficiency. You can have folate transporter defects or the folinic acid I've covered. You can have MTHFR pathway polymorphism, some of which can cause homocystinemia. Then you have niacin, which can contribute to dementia in pellagra, and folic acid is very important vitamin to prevent neural tube defects. So to summarize, most vitamin-dependent epilepsies present as epileptic encephalopathies not responsive to anti-epileptic drugs, mostly present in newborn or early infancy. Most of them are having myoclonic seizures with or without movement disorders, and if untreated for long, then they may lead to irreversible damage and developmental delay and regression. Look for the clues. The family history is important, consanguinity is important. Look at the skin, whether there is any kind of rashes, hair, any depigmentation in the eyes, any oculogyric movements, or any lens subluxation, etc. Always rule out the treatable causes in appropriate settings. So pending a definitive diagnosis, give a trial of B6, B12 and biotin in all early onset refractory seizures if there is no structural cause like a dysplasia, lissencephaly, etc. identified. Genetic studies are needed to confirm the diagnosis and offer prenatal counseling, except if an acquired cause is identified. So thank you very much for patient listening. And if there are any questions, I'll be happy to answer them. Thank you very much.
Thank you, madam, for that very lucid and comprehensive talk on vitamin responsive epilepsies. We now go on to the question and answer session. Dr. Rosemary.
Thank you, ma'am. I hope I'm audible.
Yes, you are.
Yeah, madam. So we, there are, okay, thank you, madam, for a very crisp presentation. We had a very clear idea about the different cases in the presentations. Like in intensive care, we usually, when we are, treating a case with refractory seizures, we usually feel that the walls are closing on us, closing on us. Then we sometimes we actually hope that it's a vitamin responsive epilepsy. So, like, madam, what would be your advice to as to what will be the order in which you would like to try the various vitamins in a case of refractory status? Like, will you can you give a like approach for that?
Yeah, so if we are suspecting a baby who has got epileptic encephalopathy, there is no role of trying one after the other. I think the whole cocktail has to start immediately as a part of the metabolic cocktail also, because we are not sure at that moment if it is not responding to the antiepileptics, and we are excluded the structural causes or infective causes, any acquired cause, then there is a need to start the vitamins as a part of the metabolic cocktail along with carnitine and all. There's no time to lose there, because the more we wait, there may be irreversible damage. So I would, what we usually do is we start the injection optineuron, which has got B1, B6, B12, okay, and we add folic acid to the RT. Folic acid is usually not that deficient. So mainly we start with the B1, B12 and B6. And in 1 or 2 days, we do, understand whether the child is responding or not. In fact, we should not wait for more than 24 hours, and we usually then add PLP and folinic acid as well. So it should be done as fast as possible rather than waiting for too long. Or if there is anything like a family history positive and all, we may even start with PLP and folinic acid, because it's a little difficult to procure PLP because it has to be ordered online. It's not freely available in the pharmacy stores. So it usually takes around 24 hours to, get it. But folinic acid and all, we can start immediately. So I would suggest that B1, B6 and B12 should be really started very early.
Okay. Madam, there's a question. What is the role of a clinical exam for mother? Case?
Your voice is breaking, sorry.
Madam, what is the role for a clinical exam in the mother in such a case?
So yes, very, very important, because mother will give you a lot of clues regarding B12 deficiency. You take a detailed dietary history, whether she's a pure vegan, what is her B12 intake, does she have hyperpigmentation. We in fact even do CBC of the mother. Sometimes it shows macrocytosis. Babies may or may not show macrocytosis. Sometimes they may have just neurological manifestations even before they develop macrocytic anemia. So you may have to do mother's CBC, and many a times we also find that vitamin D deficiency in mother, translating into hypocalcemia in the baby, and vitamin D levels in the baby will take some time to come. So you get a cause immediately once you, suspect vitamin D deficiency and vitamin B12 deficiency in the mother. So yes, mother's examination is very important. Apart from that, consanguinity and any other family history has to be taken from mother only. So any kind of previous fetal losses, all these can give you a clue to whether there is any kind of, cause like genetic or any metabolic etiologies.
Okay, madam. So on the same lines, is there any? What is the feasibility of a prenatal diagnosis? Is it possible or what conditions will it be possible to have?
So like I showed you the cases where there are acquired causes, we don't need to worry about it. But when there are most of the causes which cause severe deficiencies are supposed to be genetic. And there is a definite role for prenatal diagnosis. But for that, we need a correct diagnosis in the index child. So in the index child, you need to do the studies first, maybe a little bit of metabolic to see whether homocysteine is raised, which pathway is exactly involved. So if you're suspecting a B12 deficiency, B12 dependent like cobalamin synthesis defects, complementation defects, etc., or the deficiency of the methionine synthase enzyme, for example, these will only be picked up by the exome studies. There is no enzyme study like biotinase to measure the level of methionine synthase. So genetic studies have to be planned in the baby first, and then once you have a definitive diagnosis, definitely a prenatal counseling can be offered to the parents. The one point I want to reiterate is commonly we assume that this MTHFR polymorphisms are very commonly attributed to be associated with thromboembolism, but the ACMG, that American genetics guidelines, have clearly said that there is no role of routine polymorphism testing, and you do the homocysteine levels first, and if the homocysteine levels are high, directly go for exome studies rather than looking for just MTHFR polymorphisms, because more often if there is a severe deficiency causing an infant to present with seizures, they are due to mutations in the MTHFR enzyme, and these polymorphisms, which are very common in the population, may increase the homocysteine to a certain level, but they are not associated with increased thromboembolism or causing seizures. So the emphasis has to be on the exome studies to look for any mutations in any of these vitamin pathways enzymes.
Thank you. Then another common doubt that most of us reading would be like, when we give paradoxin, it's like
Sorry, again, your voice is breaking. Can someone else speak the question if they have heard clearly? Dr. Meena? Ma'am, you are muted.
Sorry, ma'am, I just, yeah, it just seemed to muted now. Okay, so
Sorry, I'll just off my video. I'm not able to hear the question. I'll just off my video and see if it's better. Yeah, can you repeat the question?
Okay. Yeah, madam. So paradoxin we usually give in a very high dose, no, madam, around 100 to 100 to 500 mg or like 30 mg. So yes, like when you give for a long period, like almost lifelong, can it cause other side effects?
Yeah, that is where they've said that you cannot exceed the daily dose of 500 mg. Usually when we give the first dose, it is 100 mg IV. Yeah, and then we continue for 30 to 50 mg per kg per day. And if it doesn't respond, of course, PLP and folinic acid is added. But I have no experience, I mean, of giving very long term, like many years, and what happens to them later. Do they develop neuropathy or not? But it is mentioned in the literature that if you give it for if you exceed the dose of 500 mg per day, then you may land up with neuropathy. The youngest child, I mean, the oldest child I have is only 5 years.
Okay. There's another question, madam. Yeah, that you have already answered. Is there any role for empirical megavitamin therapy without precise diagnosis in suspected intractable seizures? You have already you described as to what vitamins have to be used. So I think, madam, we do not have any more questions. Yeah, so I think we can wrap this session, madam.
Okay, thank you very much, AOCN, for giving me this opportunity.
Thank you, Kavita madam, for this wonderful session. We now pass on to the next topic, which is status epilepticus, recent advances in management and outcome. I invite Dr. Rekha Mittal for presenting this topic. Madam is the current president of AOCN. She is the additional director, pediatric neurology of the Rainbow Children's Hospital, New Delhi. She retired as senior advisor in pediatrics and pediatric neurology to the armed forces and professor in pediatrics based hospital, Delhi Cantonment and Army College of Medical Sciences. Her areas of special interest are epilepsy, cerebral palsy, and developmental delays. Rekha Madam is a founder member of the Association of Child Neurology. She has several presentations and publications to her credit, both in national and international journals and conferences. Welcome Rekha Mittal Madam to present the topic Status Epilepticus, Recent Advances in Management. Over to you, Rekha Madam.
Morning, everyone. I would like to thank the organizers for inviting me to speak on recent advances in management and outcome of status epilepticus. It is one of the conditions in which recent advances gains in knowledge have made management simpler for the clinicians, and hopefully this will translate into better outcomes for the patients. I have no disclosures to make. So, status epilepticus is the commonest neurological emergency in children, with a reported incidence of about 20 episodes per 1 lakh population per year worldwide. Of this, 10 to 40% of the patients would have refractory status epilepticus, and around 15% would have super refractory status epilepticus. To start at the very beginning, seizures are the clinical manifestations of paroxysmal, abnormal, hypersynchronous electrical discharges in the brain. But since these discharges are paroxysmal, the seizure ends by itself in a short while. So why do seizures occur? Why do they stop? And why sometimes they don't and go on to develop into status epilepticus? It can be explained by the neurotransmitter levels, the receptors they act on, and the ion channels. In the resting state, the neurons could have excitatory postsynaptic potentials or inhibitory postsynaptic potentials. If the glutamate levels rise, then there is a sodium influx, calcium currents, and resulting paroxysmal depolarization. On the other hand, if GABA levels rise and this acts on its receptors, there is a resultant potassium efflux, chloride influx, and this along with the sodium potassium pumps results in inhibitory postsynaptic potentials. Now, sometimes the levels of glutamate rise, giving rise to increased levels of EPSP, resulting in a seizure. But what happens is that whenever glutamate levels rise, the enzyme GAD, that is glutamic acid dehydrogenase, converts the glutamate into GABA, which acts on the receptors to produce an inhibitory postsynaptic potential, resulting in seizure termination. However, if there is an underlying pathology that causes increased in glutamate levels or its action on glutamate receptors, or continuing seizures causing the GABA receptors to internalize, or externalization of the AMPA or NMDA receptors, then there is a continuous increase in the EPSP, causing calcium influx and free radicals, neuronal death and neuronal injury, and alteration of neuronal networks will result. So how can we define status epilepticus? This is a definition which has been evolving over the years. In 1983, the duration of a seizure to qualify for status epilepticus was 60 minutes. In 1993, it was 30 minutes, and this became the conventional definition for many years. However, in 1999, Lowenstein was the first one to suggest that the definition to call a seizure status epilepticus duration should be 5 minutes, because a seizure that continues for 5 minutes or 5 minutes is unlikely to terminate on its own. But it was not until 2015 when the ILAE task force on classification of status epilepticus actually came out with a revised definition, which said that status epilepticus is a condition that results from either the failure of the mechanisms responsible for seizure termination or initiation of mechanisms which lead to abnormally prolonged seizures after time point T1. And after this point, the seizure is unlikely to stop by itself. It can have long-term consequences such as neuronal death, neuronal injury, and alteration of neuronal networks depending on the type and duration of seizures after the time point T2. Now, time point T1 is the time at which treatment must be started, and this is equal to 5 minutes for tonic-clonic seizures, 10 minutes for focal seizures with impaired consciousness, and 15 minutes for absent seizures, while time 2 is the time at which consequences can be expected and aggressive treatment must be started. And this is equal to 30 minutes for tonic-clonic seizures, 60 minutes for seizures, focal seizures with impaired consciousness, and for absent seizures, this time period remains unknown. In all cases of status epilepticus, description should also include classification in 4 axes, that is semiology, etiology, EEG, and age. Of this, the semiology and etiology is very important from the management point of view. In semiology, unlike the classification of seizures, where we start with focal and generalized, here we describe them in form of prominent motor symptoms or without prominent motor symptoms, and these are further subdivided into those with motor symptoms could be generalized or focal, myoclonic, tonic status, hyperkinetic, whereas without prominent motor symptoms could be with coma or without coma. In etiology, it could be known or unknown, but out of the known etiologies, it is the acute symptomatic status epilepticus, which is the commonest in young children. EEG descriptions should also be included, and age could also be used to describe or classify the status epilepticus. But remember, in children less than 2 years of age, it is the acute symptomatic status epilepticus that is the commonest, and all efforts must be made to find a cause of SE in young children. In children older than 2 years of age, it is pre-existing epilepsy or neurological abnormality that is the most common cause of status epilepticus. So, coming to management, I would be dealing only with generalized convulsive status epilepticus because this is all I can cover in the time allotted to me. Since the seizures start at home, very often the pre-hospital management is carried out by the paramedics and the caregivers at home. But this treatment is often delayed. In a review of 15 studies of more than 2,200 patients with status epilepticus, it was found that the average time to treatment was 42.4 minutes, and that patients were able to arrive at a hospital as late as 56 minutes. The treatment by about 51.8% of the patients could be treated by the paramedical workers and only around 13% by their families. Therefore, this is the biggest gap in status epilepticus treatment, and all efforts must be made to improve the training of paramedics and as well as caregivers of children who have already been diagnosed to have epilepsy. Once the child comes to the hospital, a number of categories of staff would be handling the patient. It could, in the casualty, it could be nursing staff, CMO, residents, pediatricians. In the ICU, there's a whole team. So the management has to be pretty much very well organized. So the goals of management, of course, would be to control seizures, both clinical and electrographic, and prevention and treatment of systemic complications related to treatment with intravenous anti-epileptic drugs and anesthetic drugs, conditions resulting from prolonged unconsciousness and ICU stay, and eventually preventing neuromorbidity and resultant mortality. In a good setup, it has been said that 80% of the children with status epilepticus should be treated appropriately at least. So, time is brain is the most important principle of management, and therefore it is important to follow timelines. And this can only be done by developing extremely good protocols. Each center must have its own protocol or algorithm depending upon the resources available in-house. And the protocol must incorporate transport decisions into the protocol, and this is applicable to hospitals in the periphery or at a district level. The management must be carried out in 4 domains. Airway, breathing, and circulation is the first one, and this should take precedence over seizure control. The next is that we need to stop the seizure activity ASAP and prevent brain damage. And for this, using the correct route and dose of medication is extremely important, and a timeline is required for every step. The diagnostic evaluation and treatment of the underlying condition is also to be carried out at every step. Monitoring is again important at every step. So this is in the guideline for status epilepticus by the American Epilepsy Society given in 2016. They stated that the treatment algorithm is not age specific, since the disease pathophysiology of prolonged seizures in status epilepticus and the effect of anticonvulsant drugs on neuronal receptors are the same from infancy through adults. And therefore, it is quite all right to have a unified approach for all patients older than neonates. So how can we define the stages and timelines of status epilepticus? According to the ILAE, there are 4 stages of status epilepticus. The first is the early stage, which starts at 5 minutes of seizure onset and continues to 10 minutes. The second is the established phase, which is from 10 to 30 minutes. Then is the refractory status epilepticus from 30 to 60 minutes after seizure onset. And stage 4 is the super refractory status epilepticus, which is more than 24 hours after seizure onset and or it has continued for more than 24 hours despite treatment with anesthetics. However, these timelines are not sacrosanct, and other workers have used a period of 30 to 60 minutes for established status epilepticus and more than 60 minutes for refractory status epilepticus. These time frames can vary considerably with treatment, and there is a high degree of variability in the current literature. Since there is often no clear definition of the stages, one might merge into the other, and clinical practice now defines the first stage with a time frame, that is 5 minutes of convulsive or 10 minutes of focal non-convulsive status epilepticus, and later stages by the treatment response. So thus, status epileptic here, onset of status is defined by the time of seizure persistence, that is T1. Established status epilepticus means persistence after first line treatment, that is the benzodiazepines, and therefore called the benzodiazepine resistant status epilepticus. And the refractory status epilepticus is one which persists after the first line benzodiazepines as well as the second line benzodiazepines. Here, the time periods are not defined. This is the guideline given for management of status epilepticus by the Epilepsy Foundation of America in 1993. You can see here that the time for starting benzodiazepines here is given at 10 minutes, and the time for starting infusion with general anesthetics is 60 minutes. And let us see how this compares with the new American Epilepsy Society guidelines of 2016. We can see here that in 1993, where benzodiazepines were recommended to be started at 10 minutes, we now have benzos recommended at 5 minutes. The second line AEDs are similar in both the guidelines, but in the 1993 guidelines, where general anesthetics or a repeat of a second line AED was 60 minutes, this time has now been moved ahead to 40 minutes. That means we are doing everything earlier to save the brain. So when a child presents with seizure, during the first 5 minutes, it's incipient status epilepticus. At this time, it is just an acute seizure. And during this time, stabilization of the child is carried out, and all the basic principles of emergencies are followed. The ABC, IV access, immediate investigations have to be started. The immediate investigations are basically to find the cause of status epilepticus, and would be decided by the history of past seizures or epilepsy, breakthrough seizures, if there is fever or not, and if it is considered necessary, a toxicology screen may be done. At this time, a quick history of seizures have to be taken, in which you can ask for the duration, the semiology, any past history of seizures, anti-epileptic drugs, or precipitating or underlying illness, and a quick clinical examination may also be done. However, as soon as 5 minutes are over, the child is said to have passed into early stage of status epilepticus, and timely benzodiazepine administration is critical. It has been found that if the benzodiazepines are given after a duration of 10 minutes of seizure onset, it is associated with a higher death rate, higher rate of continuous infusion, and higher duration of status epilepticus. So now that we know that benzodiazepines have to be given ASAP, which one should we use? We have in our armamentarium 3 most commonly used drugs, that is diazepam, lorazepam, and midazolam. So this table compares these 3 drugs. It can be seen that all 3 drugs, by whichever route they are used, would mostly result in termination of the seizure before 10 minutes. However, the duration of action is different. Lorazepam is long-acting and can be effective up to 12 to 24 hours, many times obviating the need for a second-line anti-epileptic drugs, and is being able to prevent recurrence of a seizure very soon after the administration of the benzodiazepine. The diazepam and the midazolam are short-acting. However, lorazepam can cause sedation and may pose sometimes difficulty in monitoring the consciousness state of the child. And most importantly for India, it has to be refrigerated, and this may be a problem in some of the peripheral centers. So which one should we use, diazepam or lorazepam? In the 90s and the early 2000s, that means up to 2010, there were some meta-analysis of RCTs found that lorazepam was superior to diazepam, and we felt we were in a dilemma how to manage these cases, how to give the best treatment to our patients. But in 2016 and 2014, the more recent meta-analysis have shown that lorazepam is not superior to diazepam. So this was a big relief to us. If we have to consider the non-IV routes, then we have lorazepam, which can be given nasally, diazepam, which can be given rectally, and midazolam, which can be given nasally, buccally, or intramuscularly. So in this very important study, in which intramuscular versus IV therapy for pre-hospital status epilepticus by Robert Silbergleit, it was found that IM midazolam in out-of-hospital setting was very good. IM midazolam is at least as safe and effective as IV lorazepam. Thus, for pre-hospital cessation, IV lorazepam, IV diazepam, and IM midazolam have equal efficacy. And in my opinion, this is a very good thing, and IM midazolam can be used in casualties in India, which may be manned by nursing staff, which may not be so efficient in starting IV lines in children, especially young children who land up with status epilepticus. This is the pattern, or this is the recommendation of ILAE of 2015 for the first line treatment, lorazepam, diazepam. They have recommended clonazepam, but this is not available in India in an IV form, and phenobarbital can also be given. The American Epilepsy Society guidelines, seem better suited to Indian requirements, they have recommended for all, for whether pre-hospital or in hospital, intramuscular midazolam, IV lorazepam, and IV diazepam can be given, and they are all equally effective. If none of these options are available, then it could be IV phenobarbital, rectal diazepam, or intranasal midazolam, or buccal midazolam. Now, if despite the benzodiazepines, the child still continues to have seizures, we have a choice of 4 drugs: phenytoin, phenobarbital, sodium valproate, and levetiracetam. Phenytoin is the one which which was there in the protocols for many decades. But are they all equally effective? Are they different from each other? So in the ESET trial, in which 384 patients at 57 emergency departments in USA were studied, it was found that fosphenytoin, valproate, and levetiracetam were clinically equivalent, and each of these 3 stopped the seizure in about 45% of the cases. And there was no difference in median time to seizure cessation, seizure recurrence 1 to 12 hours after drug infusion, or the rates of life-threatening events. In this data from Sanchez, Fernandez et al., they studied, this was a meta-analysis of 1,185 status epilepticus episodes, and these 5 drugs were compared. And there was a big surprise here. It was found that phenobarbital is the most effective drug, followed by valproate, and phenytoin, which we had been using for many years, was actually least effective. In this study also, it was found, the ECLIPSE study and the CONCEPT study, it was found that levetiracetam and phenytoin or fosphenytoin, there is no significant difference between levetiracetam and phenytoin and fosphenytoin. And therefore, in established status epilepticus, we have a choice of these 4 drugs, and all 4 of these are easily available in India, and people have started to use these options frequently in our casualties. In the ILAE guideline, they have given phenytoin, valproate, levetiracetam, and they have added lacosamide for treatment of established status epilepticus, whereas the American Epilepsy Society does not add lacosamide. They advise IV fosphenytoin, valproic acid, levetiracetam, and IV phenobarbital. In this, 40% of the patients will respond, and rest will progress to refractory or super refractory status epilepticus. By the time stage 3 and 4 is reached, management will be required in the ICU, and along with the pediatrician and pediatric neurologist. By this time, excitotoxic processes which compromise neuronal survival have already been activated. So therefore, the goal of treatment would be to limit or reverse these processes, prevent further neurological injury, and preserve the extraneurological systems. For this stage, we have 4 drugs which are used commonly: the midazolam infusion, thiopentone or pentobarbital, propofol, and ketamine. At this time, EEG monitoring has to be instituted, and ventilation may have to be started. So if we look at this, we will find that 3 of these drugs are actually GABA receptor agonists, while ketamine is an NMDA receptor antagonist. So which one to use? Now, midazolam is the one in which we have maximum experience. It gives good seizure control, but there is a risk of breakthrough seizures. Thiopentone is more potent, but has more side effects and may have a higher mortality, especially as it can cause an increased incidence of sepsis in the ICU. Propofol is better suited for short-term use as a stopgap measure, maybe, because it can cause because there may be a small risk of propofol infusion syndrome. So ketamine is emerging as a good drug for refractory status epilepticus because it is an NMDA receptor antagonist. It can have prolonged action because glutamate receptors get externalized with increasing duration of status epilepticus, and this quality of it being an NMDA receptor antagonist would stand it in good stead. It may also be neuroprotective. The therapeutic target in refractory status epilepticus would be either seizure suppression, and if EEG is there, then burst suppression pattern or electrocerebral silence. And therefore, as soon as the second line anti-epileptic drugs fail and we start with infusions, the rate of infusion must be rapidly escalated to achieve these levels. In all of these three parameters, which one is going to give the best outcomes is not clear. However, the EEG must be reviewed frequently to ensure that burst suppression is maintained. If the seizures continue despite these infusions, the child is considered, if the seizures continue for more than 24 hours after starting the infusions, the child is said to have progressed to super refractory status epilepticus. By this time, there are no clear recommendations. Most of the treatment methodologies are just anecdotal reports. One could use inhalational anesthetics, magnesium, topiramate, many are there, and I would not be going into details of any of these because this mostly comes in the purview of the intensive care team, and also there is limited time. However, it's important that we must keep in mind all new therapies and try them out, because especially if nothing is working. A word about lacosamide. It has emerged as a good drug recently, and its overall efficacy is 57% for both non-convulsive status epilepticus and a similar efficacy of 61% in generalized convulsive status epilepticus. But it is very good for focal motor status to the tune of 92%. In children also, the efficacy might be to the tune of 45 to 78% of cases. Perampanel is another emerging new drug. It has a novel mechanism of action as it acts on AMPA receptor. It's an AMPA receptor antagonist and therefore counters the effect of glutamate, and its efficacy in refractory or super refractory status epilepticus has been found to be around 20% or less in adult series. At what point of time should we stop the treatment escalation? If long-term EEG monitoring is available and there are no electrographic seizures or burst suppression pattern has been maintained without any seizure activity, then one can stop escalation of treatment. But if there is no EEG monitoring, then clinical seizure control, or when we try to withdraw, then we find that the sensorium is a bit better in the child. At that point, we can stop escalation of the treatment. But while we are continuing this, the infusions, it is important to continue the maintenance doses of the second and third line drugs, such as phenobarbital, phenytoin, levetiracetam, and valproate. Discontinuation can be attempted after 12 hours of clinical or electrographic seizure freedom in cases of established status epilepticus, but in case of refractory or super refractory status epilepticus, this can be attempted, should be attempted after 24 hours of clinical or electrographic seizure freedom. If the seizures recur during withdrawal, the drug is reinstated and weaning is tried at 12-hourly intervals. Also, one can try to, if seizures recur on weaning, topiramate, lacosamide, or perampanel, one of these drugs can be added. Other investigations can be that would be required to find the cause, and also for monitoring would be EEG, MRI, CSF examination. These can be done as required and as indicated, and other investigations for monitoring from time to time. So is the EEG really useful in management of status epilepticus? It is, yes, it is. It is now the standard of care for established refractory and super-refractory status epilepticus. It can be used to characterize the status, whether focal or generalized, and identify children with non-convulsive status epilepticus. It can also monitor electroclinical resolution of seizures and arrive at a syndromic diagnosis, such as in cases of absent status. If continuous EEG is not available, 12 or 24 hourly recordings may be done. This is a guideline that was formed by our Association of Child Neurology way back in 2014. This was published in Indian Pediatrics. It is quite similar to the initial part of the management is quite similar to what is followed, being advocated currently, but here at 10 minutes, that is for the second stage of status, the recommendation is for IV phenytoin, and other drugs have not been proposed. This we are hoping to revise these guidelines short. Outcomes and prognosis. The adverse outcomes in children could be mortality, which could be short term to the tune of 0 to 4%, 0 to 22% long term. Cognitive impairment may be seen in 28 to 34% of the children. Permanent neurological deficits, subsequent epilepsy, 5 to 36%, and recurrence of status epilepticus, 10 to 56%. These adverse outcomes could be due to the status epilepticus itself, duration of status epilepticus, etiology, age, and treatment, how this seizure was treated. The effect of various factors is not clear. So whether the morbidity and mortality rates are lower in children is not really confirmed. Vulnerability versus susceptibility is the question. However, in this respect, retrospective study of 2 children who were more than 2 years to 12 years of age, they found that etiology depends, outcome depends upon etiology, duration of status epilepticus, and non-administration of AD before hospitalization, and not affected by age, sex, and presence of pre-existing epilepsy, duration of seizures prior to reaching the hospital, or response to the first-line benzodiazepine. Most workers have actually, however, reported that the outcome depends upon etiology and duration of status epilepticus, and as in one study I quoted before, late administration of the first-line anti-epileptic drugs. However, this interesting study by Pujar et al. Found that childhood convulsive status epilepticus is associated with long-term neurological morbidity, but this morbidity occurred primarily in those children who have pre-existing epilepsy and neurological abnormalities before the episode of convulsive status epilepticus. Those survivors who did not have neurological abnormalities before the status epilepticus have favorable outcomes. So let's see what further studies say. The pathophysiology, we know that it's the ion channels, the receptors, and the neurotransmitters which are responsible. The interplay of these parameters is important in deciding the status epilepticus and when it occurs. Definitions, we now have T1 and T2 to guide management. Timelines and stages have been defined. Stage 1 is defined on the basis of time, and the other stages on the basis of response to medication. Treatment of stages, early treatment, adequate doses is important. Stage 1, we find that IV lorazepam, IV IM midazolam, and IV diazepam are equally efficacious and equally useful. In stage 2, we have phenobarbital, phenytoin, valproate, and levetiracetam. Either of these drugs could be used. In stage 3, we have midazolam, pentobarbital, propofol, and ketamine is a good emerging drug. Stage 4, we have no evidence, but try everything, try new treatments based on experience. And outcome depends upon etiology and duration of status epilepticus. And what is old is that protocols are important for improving outcomes. Thank you for listening.
Thank you, madam, for this crisp presentation. I think, madam, you've hit the nail on the head with the take-home message that time is brain. Follow timelines, protocol, protocol, protocol. I totally agree. Protocol is everything. As you said, very well said, that the initial 10 minutes are like the absolute important 10 minutes, and empowering the peripheral health workers to give IM midazolam is probably the best thing we can do. Coming to the question answers, madam, can you hear me?
Yeah, I can hear you. There is a lag between what when you are talking
Okay.
and you know.
Okay, ma'am. I'll go slow then. Okay. So, madam, there are a few questions. One of them is, what is the dose of topiramate that is used, and in what age group is it approved?
So, we don't, in practical situations, we don't go by approvals. Actually, topiramate is used even in refractory neonatal seizures. And once in older children, even once we've crossed the stage of super refractory status epilepticus, then we can add topiramate. And we have a practice of starting with the higher dose first, and we quickly escalate it. So we start with 5 milligrams per kg and then escalate to 8. So
Okay.
it's a, like, as opposed to the traditional way, when we are starting for epilepsy, in status epilepticus, we start higher and faster.
Yes, ma'am. Yes. Okay, ma'am. The next question is, actually, you have touched it in your topic, madam, but probably it might be better to summarize it again. They're asking if we should discontinue the stage 2 drugs once we start the stage 3 drugs.
Actually, no, they have to be continued. And the recommendation is that at least 2 of the drugs, if you've given 2 before we start the infusions, if we've given 2 drugs, those 2 drugs need to be continued. And it's not a good practice to keep changing one drug from the other. Whatever 2 we were giving, say, initially we'd given, say, phenytoin and valproate. Then we continue with these 2 drugs, even after the stage 3 treatment has been started. So,
Okay,
you can, once you've reached super refractory status, then of course, there are many things to try. But you don't discontinue the stage 2 drugs once you've gone into stage stage 3. We continue with those.
Okay, ma'am. Madam, another thing, is there in these protocols, is there any role for vitamin high dose therapy, like in the previous talk, B1, B6, B12, and thiamine, in any of these stages, especially before the refractory level reaches?
So actually, only if we have a prior suspicion of something, there's a previous history of refractory epilepsies, only then one may consider it, but not as a routine. Not in the early stages, of course.
Yes, that's right. Madam, again, when we are giving these stage 1, stage 2, stage 3 drugs, do you have any experience with synergism? Do you feel that some of these combinations work better than the others?
Yeah, it's always better to use drugs with different mechanisms of action. That's why ketamine is coming up in a big way, because in the initial stages we've used benzodiazepines, which are GABA receptor antagonists. Then we know that these we need to have a different mechanism of action. Now, if we go to the stage 3 drugs, like all 3 of them, midazolam, pentobarbital, all of these are also acting on the GABA receptor. So we don't know whether how effective they'll be. And that's why ketamine, which is an NMDA receptor antagonist, would be a good choice, because these are the receptors which are playing a more important role in stage 3 and stage 4. So that's why ketamine is coming up in a big way. So it's always, whenever we are treating seizures of any kind and they are refractory, whether in status or even in epilepsies, we always try to use drugs with different mechanisms of action.
Yes, ma'am. Yes, ma'am. Thank you. Then, madam, how will there, can there be a protocol or a guideline as to which drugs to be chosen to continue? Like what criteria will you be basing them
So
on?
something would depend upon the pre-existing state. Suppose it was a focal status epilepticus, then we may use, in the long term we may use drugs which are more effective in say focal epilepsies. So a lot depends upon what the existing child was. Now if it's a first time status, you don't know what caused it, what didn't, then valproate and levetiracetam would be a good choice to continue after the child goes home. It all depends upon the clinical scenario, what the cause of status epilepticus was. Suppose we identify, say, encephalitis. So then, and we don't think it was an inborn error of metabolism or something, then we can continue with valproate also. So it all depends upon the clinical situation, and we have to use our judgment to decide which one would be the best. Ideally, we should be tapering off. Fosphenytoin is never a good choice to, or phenytoin is not a good choice to continue. It is better to take that off when the child is going home and continue with one of the other drugs.
Yes. Yes, ma'am. I think we're coming to the end of the session. Thank you very much for sharing this time with us, ma'am. We had a wonderful time. Thank you, ma'am.
Thank you.
On behalf of the organizing team, Rekha Madam, I would like to thank you for this very comprehensive and extensive introduction to us on the recent advances in management of status epilepticus. And we were also able to finish this on time. Thank you once again on behalf of the organizing team. We now pass on
Thank
to
you
the
very
next
much.
session.
I thank the organizers for giving me a chance to speak on this extremely important topic, because it has a bearing on the long term outcome, morbidity, and mortality. We talk a lot about time is brain for stroke, but we don't talk as much about time is brain for status epilepticus, and this is far more common in children. So we really need to get this message out. Protocol, protocol, protocol. Doesn't matter who's sitting in the ICU. I think it's a big boon that the studies have shown that IM midazolam is equal to IV lorazepam or IV diazepam, and we must train our paramedical staff who's manning the casualties to be able to administer it as soon as the patient with obvious seizures come. Thank you very much.
Thank you.
Thank you, Dr. Rosemary. Next is the official inaugural function of AOCN. I request Dr. C.B. Kurian Philip, consultant pediatrician from Trivandrum, Kerala, secretary of IMA and treasurer of IAP Trivandrum, Kerala, to invite the dignitaries to the function. Over to Dr.
Welcome to the inaugural session of the 11th Association of Child Neurology International Annual Conference, organized by IAP at Trivandrum, IAP Neurology Chapter Kerala State, and International Child Neurology Association. For the last 2 days, we had an excellent academic feast by international and national faculties. For the inaugural program, now I call upon stage Dr. Rekha Mittal, President AOCN, Dr. Suhasini Sharma, Secretary AOCN, our chief guest, Dr. M.K.C. Nair, who is the former Vice Chancellor, Kerala University of Health Sciences, Dr. Anita Hegde, AOCN President 2021, Dr. Kavita Srivastava, AOCN Secretary 2021, Dr. Nitish Bohora, Organizing Secretary 12th AOCN Conference, Dr. Mohammed Kunyu, Executive Board Member, South Zone and Organizing Chairperson of the conference. Dr. Pratibha Sanghi, ICNA Secretary, is not able to join due to some personal reasons. Now I hand over the mic to Dr. Suhasini Shah Sharma and Dr. Rekha Mittal for further proceedings. Thank you.
Thank you, sir. A very good morning to all of you. On behalf of AOCN, I thank Professor Kunju and his team and Dr. Mini, the organizing secretary, for organizing this wonderful virtual conference. I think even though we would have all liked to come to Trivandrum and see the beautiful city and meet all of you and all of our friends and colleagues, however, in this time with rising cases, this was the best we could do. And I think that their team has done such an excellent work. We have academics with excellent speakers, national as well as international, and it can all be done from the comfort of our own homes without traveling. And so far, the last 2 days have been a complete academic fest, and this half day also, I'm sure, is going to be very, very interesting. And all the attendance has been tremendous. The students are so excited about the talks and the presentations, and they're all awaiting the validatory function for the prizes. So I think it's been an amazing 2.5 days, and I thank again the organizing team for this wonderful conference. Again, I welcome all of you on behalf of AOCN, and I now hand over the session to Dr. Rekha Mittal, the President AOCN.
Thank you very much, Suvasni. I second every word that she said. This conference has been out of the world experience, and I have been glued to the screen for the last 2 days and also since today morning, because each talk has been a treat by itself. I actually took 2 days off from work just to be able to attend the session from beginning till the end. So anyway, uh, so this Association of Child Neurology from 2002 to 2021, it's been almost 2 decades of stepwise rise and rise. In the beginning, there were only small meetings initially, and we had only a few members to start with. But the association grew in numbers and stature to proudly host the ICNC 2018 at Mumbai, and subsequently we had the 10th national conference in Bangalore, and now we are on our 11th national conference in Trivandrum. So the role of AOCN in developing pediatric neurology services in India cannot be understated. And our members have been real movers and shakers, as they say. The DM Neurology program, as you all know, was started at AIMS by Dr. Veena Kalra. This was followed by a DM program at PGI under Dr. Pratibha Singhi. And after that, there has been actually no looking back. Just more than a year back, the MCI has recognized the DM in pediatric neurology, and 3 institutes are running this course. The efforts of Dr. Kunju have brought results, and he was instrumental in getting this through. And now we can happily say that we are on the threshold of getting a DRNB in pediatric neurology from the national board. Services have also evolved from general pediatric neurologists to now experts in neuromuscular disorders, epilepsies, movement disorders, and stroke. And the future of pediatric neurology is bright in this country. And I'm sure that the AOCN will remain at the forefront of pediatric neurology activities in the country. Dr. Anaita Hegde is taking over as the next president of this organization. No one could don the mantle as the leader of this organization better than her. She is well known. She has trained many of the practicing pediatric neurologists in India and is a very popular teacher. Currently, she is the director of neurosciences at SRCC Narayan Healthcare Children's Hospital, Jaslok Hospital, and Wadia Children's Hospital in Mumbai. She has been the president-elect of our association for the last more than 2 years, but she is also an executive board member and lead of education of the International Child Neurology Association, which is partnering with us on this conference. She's a member of the Child Neurology Society in Mumbai and founder of the Rural Child Neurology Program in Maharashtra. She's the medical director of the Jai Vakil Foundation Center for Children with Special Needs. She has taken a she has been a keen and active member of the AOCN. She has attended all conferences organized by the AOCN so far and has been present at the board meetings of the association. And she was also the organizing secretary of the ICNC held in Mumbai in 2018. She has played the role of president elect with elan and dignity. I feel happy to transfer the symbolic baton into her able hands and wish her all the best from the bottom of my heart. The team she leads is lucky to have a person of her stature at the helm of affairs. All the best, Dr. Anita. Over to you.
Is it my, Dr. Kunju, is the inauguration by Dr. MKC Nair now, or?
As per the schedule, it is the inauguration, isn't it? Dr. Sibi is there? Go for the program is there?
I think Anita is next as per the.
Next, I invite Dr. MKC Nair for the formal inauguration of the program.
Can I start?
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
So good morning, all academicians, friends, and IAP members. Most respected new president, Dr. Anita Hedge, Dr. Rekha Mittal, Dr. Suhasini Sharma, Dr. Kavita, Nitish, Dr. Muhammad Kunya, and from Trivandrum we have Dr. Mini, Bennett Silem, and many others. I would like to open this session remembering Dr. Anandam, who is hale and hearty and doing very well, but because she is a person who brought pediatric neurology to Kerala. To best of my knowledge, 80 when I joined as a pediatric faculty, on one side I was doing child guidance to begin with, then child development. Dr. Anandam was doing the pediatric neurology. So she was always there on my side to help me out if I have diagnostic problems. And then came Dr. Muhammad Kunya, and that relation is still going on. In the second Child Development Center, after the Vice Chancellorship, after CDC Kerala, I have set up a new Child Development Center in the private sector. It's called NIM Spectrum Child Development Center. There also Dr. Kunj services is available. A clear message I would like to give, and that is, we have whole lot of problems. All of us can't manage all these problems alone. We need to have different kind of people. Now let's take the neurodevelopmental follow-up issues. Okay, it's a huge burden. It's a full-time job. I do not think a full-time neurologist can take care of the whole thing. You need a developmental pediatrician or development neurologist to look after, because that's a huge burden. I know that I have done for last 36 years. So I know how burden it is. My own baby starting at 87. Now they are 36 years old. I'm still doing the follow-up. That 24 years, I gave the findings for a doctor of science. Now my assistant is doing a PhD at 34 years to be exact. So that means a huge work. But every 10 cases that we see, we may have one child whom we need opinion of a pediatric neurologist. And that time he will have to or she will have to spend an hour or two really looking at the child in great detail. That's how we have a collaboration, how it is working, apart from all other group that we talk about. Now look at what are the burden of problem that we have. The maximum burden is development delay, language delay, communication delay, autism, the whole group. Okay, that a developmental neurologist can take care of. But when it comes to global development delay, you need services of a pediatric neurologist and maybe geneticist. So that's a very important area that we have to look at. Global development delay is becoming a major chunk where the collaboration start actually. You can really collaborate, and in fact, that's exactly what we do. Then you have the major chunk of epilepsy, which is the forte of pediatric neurologists. And you need to really focus on that. And then you have a whole lot of developmental disorders. Yes, both can look after that. And then you have the rare disorders, where genetic metabolic disorders, where you need also services of a geneticist. So in our center, that's exactly what we do. We three work together, and that's the way it should be, I believe. Now, what is the role of whole lot of developmental therapists is there? And you cannot run a clinic. Service you cannot provide unless you have a whole lot of therapists, starting with a development therapist, then physio, occupational, blah, blah, everything that we talk about. I won't name everybody, but the whole group we need. It's not easy to get all these people. The only place where now it is getting available easily is the Rashtriya Bal Swasthya Karyakram, for which I'm so glad that I could make so much contribution in the first discussions, where we made sure that there has to be therapists if you are going to give a service. Till then, most of the government programs will talk about, training and whatnot. You do a lot of training, but there's nobody to provide service. Whereas a district early intervention center definitely will have a pediatrician, a manager, a nurse, you have a physiotherapist, speech therapist and whatnot. Even dental person is there. That it's a comprehensive clinic. What is missing is probably they should have had a part-time service of a pediatric neurologist. That is something we can still do. If we have that part-time service, that would have been great. Now, we know the impairment, disability, handicap cycle, the whole way it moves. The developmental, first, let's say, let the neonatologists have to be really careful to prevent impairment as much as possible. Not really possible. Then you have the developmental pediatrician to prevent delay from becoming disability. And you have the pediatric neurologist to preventing that the disability from becoming the handicap. That's why under England, we did the largest study in the world. Myself, Dr. Arora and Shefali. And now Shefali has continued it in All India Institute. What we have found is easy way to remember, it's not exact, less than 10% children have 10% developmental disabilities. And this is not an estimate. This is the absolute truth, because we had 4,000 children from 4 different parts of India selected by the best research methodology, population proportion sampling. And the importance is all the children had 10 diagnostic tests done. So there's no question of false positive, false negative. This is the most accurate data that we can have. Now, once we have data, let's say that 10% of children have some sort of problem, we need more pediatric neurologists, we need more developmental pediatrician, we need more therapists, particularly the therapists. In Kerala, we started the PG diploma in clinical child development for last 15, 20 years. But it is not possible in other part of the country because of its own problems. So we have started a new course called Developmental Nurse Counselor, the BSc nurse actually helping you. So a busy pediatric neurologist or a developmental neurologist can take the service of a developmental nurse counselor to do the bulk work, and you only need to focus on the essence. And I always say, Dr. Mohammad Kunya, that you are the true scientist. The pediatric neurologist is a true scientist. The developmental pediatrician is little more the community scientist. You understand what I mean? We are more concerned, not so much concerned of the nitty gritty of the absolute diagnosis. Truth, nothing but the truth, gospel truth. We are not bothered. We are much more bothered about what after making a diagnosis. And that we do what is called a biopsychosocial model, and which we have just published, where the individual care plan is very important. What do you mean by individual care plan? We do a SWOT analysis of the situation in the family. What are the strength, weakness, opportunity, and threats in the family, and take what are the biological needs, the biological drug treatment, what are the investigation that is required. Then you have psychosocial part, the problem of the mother and the problem of the family, particularly when you come to autism. This is the most important thing. And the way the parents are happy, if you look at their problem and say, I'm there, we are there to support you. A busy neurologist may not be able to do that much service. So you need to help up somebody else to do that. So it's a symbiotic relationship. Your time is so precious. You need not spend time on all this, but you need to be aware of it, as well as Anita, madam, I'm just telling you that now that you are taking over, I think keep this in mind that we cannot do everything alone. We can give a diagnosis, but if you really want to give care to the child, and that is what the parents want, that is what the mother want, we need other people with us. And if the patient is coming from faraway places, RBSK, Rashtriya Bal Swasthya Karyakram, is one of the best. Recently, I visited the one in Trivandrum where Bennett Asylum is working. You know, we had a DEIC I visited. Beautiful place. What took me 25 years to develop, it could be done in 1 year because the government support is there. So ultimately, I'll end by saying, I forgot to say, Dr. Pratibha Singhi, my old friend, and all others. Dr. Shefali, I understand, is going to take a bigger responsibility in the association. If it is true, then I think it is again a 2 years of golden period for pediatric neurology and for collaboration with others, where we treat each other with mutual respect. That word is very important. Mutual respect. That is the most important thing. After having practiced for 41 years, I have realized alone you can do nothing, but together we can do lots of things. Thank you. Thank you all very much. I hope you will take this message seriously and have great pleasure in inaugurating the conference, maybe at the fag end of the conference, but still, that is the most important part. Thank you. Thank you all very much.
Thank you, Dr. M.K.C. Nair. He is the former Vice Chancellor of Kerala University of Health and currently the Director of the Child Development Center as well as the Research Center, NIMS Medicity. And actually, Suhasini should have introduced him in a better way. But anyway, because of the lack of time. And definitely, MKC's words will be a good lighting point for the AOC and continuing activities. Now, it is a thank you, MKC, sir, once again for your wisdom and being with us for this program. Now we have
thank you very much.
Okay. We have the official induction of our new president, Dr. Anita Hegde. We have that her just one slide of her introduction is there. She just wanted it to be very simple, and I invite Dr. Rekha, the current president, to hand over the baton, and then Dr. Anita to say her introductory words and her presidential action plan to be revealed to AOCN members. Dr. Rekha first.
So actually, I am not sure how I'm supposed to hand over the baton, but I can only give her a high five. So this is how we can do it. And I'm so happy that a person like Dr. Anita Hegde is coming as the captain of the ship, or leader or the general, whatever you can call it. Uh, I am so happy to see you finally take over, and I wish you all the best.
Thank you. Thank you very much, Rekha. Um, Dear members of the AOCN, ICNA, national and international delegates, and respected Dr. MKC Nair, I would like to start by thanking Team Trivandrum for organizing this Child NeuroCon, the 11th AOCN International Annual Conference of 2021. The faculty and the science have been par excellence. The amalgamation of AOCN with ICNA support has created a fantastic program of the highest scientific content. The organization and communication has been exceedingly efficient, with special thanks to Professor Pam Kunju for accepting, coordinating the scientific feast at such short notice in spite of the COVID pandemic and its deterrence. But we do know that no captain can steer a ship without a solid, efficient team behind him. So a special thanks goes out to Dr. Bennett, Dr. Minnie, the entire team, and we cannot forget the Biju Hamid for being involved with the program from inception, planning, and execution. Biju, you have outdone yourself. Your commitment and support has helped strengthen the ties between the AOCN and the ICNA. As incoming president of the association, I realized for the first time the effort and the work that has gone into the creation, nurturing, and promotion of our national body of child neurologists. What started as a small sapling planted by Dr. Veena Kalra many, many years ago, tenderly nurtured by all our esteemed past presidents and secretaries, today has grown into a small tree. And I say small because I think we have potential to grow into a giant tree. With a membership of more than 350, an active executive board, and ongoing academic programs on par with any international standards. The present elections itself for different AOCN posts is the first of its kind, showed us how we have grown into a sought-after, larger association of repute. I extend a warm welcome to all the newly elected executive board members and a special welcome to Dr. Kavita Srivastava as secretary for the coming term and Dr. Shefali Gulati as president-elect for 2023 to 2025. Being on the executive board of ICNA as well, I think I must acknowledge the efforts and the hard work over many years of Dr. Pratibha Singhi. Dr. Pratibha was a founding member and a past president of AOCN. With her efforts, has placed India on the international map of child neurology. This hard work has culminated to a proud moment for us as Indians to have Dr. Singhi elected as the president-elect of the ICNA 22 to 2026. So a journey that started in 2002 in co-creating the first child neurology body in India to becoming the president of the international body is not a small feat by any consideration. I would like to extend a huge thank you to our outgoing president, Dr. Rekha Mittal and her team for ably guiding the association over the last 2 years. The executive board has been very supportive, proactive, passionate on many fronts. They accomplished a significant amount in the space of education, research, advocacy during their tenure. The biggest feather in their cap has been the recognition of child neurology as a pediatric subspecialty by the Medical Council of India. And for this, I think we owe a huge thank you to Dr. Kunju, who used his good offices to achieve this much sought credibility. Hopefully, we shall have many more brilliant indigenously trained child neurologists with us in the coming years. Thank you, Rekha, Suvasini, and Kaushik for creating a supportive, congenial, and happy camaraderie. It is always easier and more effective if we work as friends. We, myself, and our team, our new team, look forward to continuing and enhancing the dedicated work handed over over the years from one team to the next. The ongoing pandemic has changed a lot in the ways we connect, educate, interact, and reach out to those with limited resources. We will continue to focus on education, promote projects in the space of research, hoping to initiate outreach programs and push on the advocacy front. The last year has taught us the importance of the virtual world, and our website will soon be the face of all our activities. Last but not least, we will continue to use our finances judiciously and to try and augment our existing resources. For this, a big thanks to Dr. Udani and the ICNC 2018 team, so that going forward, we may conduct more funded activities. We invite you all and look forward to the 12th AOCN annual conference to be held by Team Gujarat in Ahmedabad 2022. And last, on a personal note, I would not be here if it was not for my teachers who have always encouraged, promoted, and mentored me over the years. Big thank you to Dr. Brajesh Udani, Dr. K.N. Shah, and Dr. Surekha Rajadaksha for molding me and always being there when I need help. The learning process never ends, and I thank my seniors, contemporaries, juniors, fellows, and students for all I learn from them on a daily basis. Thank you for your confidence in us, and on behalf of our team, I promise we will try our best to promote and enhance our fraternity. I look forward to enjoying this journey together over the next 2 years. Dr. Kavita, the incoming secretary, and myself have put together a few slides to highlight the skeletal structure of our ambitions on behalf of the incoming board, which I think Kavita will present after she has been introduced. Thank you.
Okay. Thank you, Dr. Anita, for that excellent words, and you are putting your action plan. And now I invite Dr. Kavita, the incoming secretary. Before that, I ask Dr. Suhasini for introducing the new secretary.
Thank you, sir. It is my great pleasure to hand over the baton of the secretary to Dr. Kavita Srivastav. I think she needs no introduction. She is Professor of Pediatrics and Pediatric Neurology at Bharati Vidyapeeth, Pune. She is very well known for a number of things. She's very popular, strong academically. She started the Telegram group where we have had interesting pediatric neurology case discussions. This has been going on for the last, I think, 6-7 years. She's started the EG course and successfully conducted it in many places. And so she is very hardworking, very sincere, very innovative. And I think the next 2 years are going to be AOCN is going to be in very good hands. Dr. Anita at the helm and Dr. Kavita Srivastav as the organizing secretary. And I now hand over to her. Welcome, Dr. Kavita, and welcome to take over AOCN now.
Thank you so much, Suhasini. Thank you very much. Very good morning to all of you, and respected MKC Nair sir, Professor Kunju sir, Dr. Rekha ma'am, Dr. Suhasini, Dr. Biju from ICNA, and all the attendees of national as well as international repute. Myself and Anita ma'am, our incoming president, we have put together a small plan, which is just a skeleton of the things which we need to consolidate further, which has been already started by the previous executive board, and some new things also we want to introduce. So I'll just share my screen. Are the slides visible? Are my slides visible?
Yeah, they are.
Yes, yes.
Okay. So this is on behalf of the new executive board, which is consisting of President Dr. Anita, myself as secretary, Treasurer Dr. Jaishankar Kaushik, President-elect Dr. Shivali Gulati, and immediate past President Dr. Rekha Mittal, along with the EB members from North, Dr. Lokesh Saini, from the West, Dr. Nitish Vora, from East, Dr. Diptanshu, from South, Dr. Lakshmi Narayanan Karnan, and from Central, Dr. Prashant Udke, along with our webmaster, Dr. Ramesh Konanki. So we have identified 6 thrust areas, which will be 4 verticals, and of course, as Anita ma'am already reiterated, finance and website. So after discussion and approval by the executive board, we will be having subcommittees which will be governing each vertical, and each subcommittee may have a president, secretary. The composition will be decided in the EB meetings, and the idea is to include as many people as possible and the helm of the affairs. So these thrust areas would be education, research, outreach, advocacy, finance, and website. So for the education vertical, we are planning to also develop more teaching modules on different topics, explore sharing resources with the existing ICNTN as well as ILA teaching networks, small modules to target subtopics like epilepsy for a PG, epilepsy for a pediatric epilepsy for a pediatrician, for a parent, a small module on anti-epileptic drugs, and so on. The topics will be decided later, and these modules will also have an exit exam. So it will be an assignment based modules. We want to take forward the DRNB, probably as Dr. Rekha has already almost reached the final stages. She would be continuing for the pediatric neurology DRNB accreditation, to lay out standard guidelines for the various fellowship programs which are running in the country under different universities, boards, under different banners. So we will explore the possibility of accreditation by AOCN. Parent education modules for chronic and neurogenetic disorders are the need of the day, like DMD and SMA in the Indian scenario. There are lots of modules available, as I saw on the American Academy of Neurology websites and all, but we also need to have on for our own challenging situations. The research will be another thrust area, and we are planning to form a research cell or a committee to guide the different projects at national as well as international collaborative level. For example, collaborate with the ICNA Research Network, the different consortiums which are going on for different topics in Europe or in ILA, etc. Then multi-center research projects at national level to be kept ready by the special interest groups for submission of grants and submit when the calls are open. We'll like different centers to take leads for different projects, like Dr. Udani had mentioned his interest for doing a metformin study for tuberous sclerosis. Dr. Jitender Sahu is working in West syndrome genetics, and so on. To explore more areas for formulation of guidelines, for example, currently we are just finalizing the stroke, the dry seizures, and NCC guidelines. Similarly, more areas for guidelines need to be explored. We need to also establish registries. Suhasini had already started some of them, and we need to find more avenues for these registries, like autoimmune encephalitis, various neurometabolic and neurogenetic disorders, as these are rare, and without multi-centric data, it's not possible to have the natural history of these disorders in our scenario. We also, this is an item SPECT project to have outreach, and as Nair sir aptly said, 80% of our rural population is not having access to a child neurologist or diagnostic services. So how can we reach them through either teleconsultation, or as Madam has a plan that 20 to 30 child neurologists in each state can be identified, who can spare 2 to 3 hours per month by rotation to provide free teleconsultation to the rural parts of their state, maybe using the website as a platform for appointments, collaborating with the governmental district developmental intervention, early intervention centers, etc. And same can be offered to resource limited neighboring countries, the SAARC countries later. And we also need to have more visibility in the national and local newspapers to increase our credibility. And just like the IAP vaccination committee's approach for all guidelines which the government gives on vaccination, etc. Similarly, AOCN should be the body which should be approached for any kind of guidelines or any kind of licensing with the government. Then advocacy. The existing support groups should be consolidated, like we have already for tuberous sclerosis, and RETS, I think, is in Mumbai. So we need to identify more and more support groups which can be formed, but the legalities and monitoring have to be worked out. Timely statement release on important current issues. For example, what should be the vaccination strategies for children who are on prolonged steroids for like DMD, or COVID vaccination right now for children with disability? What is the role of stem cell therapy, etc.? So all these issues should be publicly available. These issues should be addressable on public platforms, and the links for clinical trials which are going on for different disorders, whether they can be posted in the parent support or advocacy section. tie up with NGOs for fundraising for the needy with neurological conditions. As more and more expensive drugs are coming in for treatment of different disorders, we will need this platform and tie up with the NGOs. Then finance committee will be having, which will develop a portal for online payment, which is currently lacking and linked to the website. Investments of the park money will be thought of how to go about it. Use the interest to pay salaries. Till now, we don't have a dedicated, we had a dedicated person, but it was like on a part-time basis. So we need a person who is there for the secretarial work with the rented space, dedicated computer, cupboard, etc. So all these would be under the finance committee. And of course, the Zoom subscription needs to be linked to the accounts for the periodic virtual EB meetings till this COVID pandemic, and even afterwards, because it becomes a very simple way to communicate with each other. The website already has been revamped to a great extent by Dr. Ramesh Konanki and the website committee. And we would be having more and more links for education on that. Webinars are already posted. We need to have details of the fellowship programs all over the country. Even job vacancies can be posted on that for the fellows or consultants. Then the section for research can be made interactive by so the people can log into special interest groups or research projects. Registries can be made interactive for uploading the data so it stays there. And of course, the section for parents can also have guidelines for management of chronic conditions explained in simple language, timely statements, as I already said. And we can even add a city-wide list of pediatric neurologists. So this all will be a very good platform for parents to access the website and benefit from that. So the way forward we are looking is that all AOCN members will be sending a mail to list your areas of interest and willingness to participate in any of the proposed verticals. And of course, the decision of the EB will be the final in this. And that is what we are looking forward to work as a family in a congenial atmosphere. And see you after this conference is already going great. And on behalf of Dr. Nitish Vora, Siddharth Shah, and Sanjeev Mehta, I also invite you to the next AOCN conference, which is on 25th, 26th, and 27th of February 2022. Hopefully, it may be a physical one. If not possible, at least a hybrid one, like Dr. Kunju sir has already set a benchmark for how to go about it in the challenging situation. So thank you very much on behalf of the incoming Executive Board, AOCN. Thank you very much.
Thank you, Dr. Kavita, for that very
thank you, sir.
Your action plans and revealing of all the activities which you are going to do. And again, you are going to be an all-inclusive secretary. That is a great gesture from your part. Now, because as per our program, it is Dr. Pratibha Singhi has to address our inaugural session, but she is held up. So we have, as Dr. Anita has mentioned, the master of this conference, that is Dr. Biju Hamid. He will just say a few words. Dr. Biju.
Thank you, Kunju sir, MKC sir, Anita, and rest of the AOC and team. This has been a fantastic experience. It was really, really exciting to see the program come together and executed with the utmost precision. And this will remain a fantastic learning experience for students, residents, and a fantastic opportunity for both generalists and specialists alike. And that was what the program was originally intended for. And it has come out exactly like that. And I'm sure all content would be preserved for posterity and would continue to serve all learners. And we're just coming out of a dreadful pandemic. And as we all start rebuilding again, and when we look back at the horrible period that was, this would be one of the positive things that we could talk about. I hope the international organizations, ICNA, IAP, AOCN, would continue to collaborate in education, research, and advocacy matters, and for capacity building and sustainable development, both in manpower, education, and research. I believe when partners come together from across the spectrum of resource availability, there is a lot to gain by involving the key stakeholders and through dissemination of scientific knowledge, help develop technologies to deal with the global issues, and not just the global issues, even the local issues. I mean, the ICNA and the AOCN, the strength is in the dynamic leadership and an active membership. So by planning collaborative activities, we can continue to keep the membership engaged and keep the momentum going. Thank you very much for the opportunity. This has truly been a fantastic experience. Thank you.
Thank you, Biju, for opening up and sharing your wisdom. As well as I must utilize this opportunity to thank you once again for all your fantastic help. And now I invite Dr. Nitish Vora for just because we are going to finish this conference by 2 o'clock today, and you can start preparing for the next conference. So you can invite all our faculties as well as the delegates to your conference. So over to Nitish.
Thank you very much. It has been a fantastic conference, and this is a benchmark for us. We invite you all as a Ahmedabad Gujarat team to Ahmedabad. That's please book the date 25th, 26th, 27th February, and looking for great social and scientific extravaganza. Hopefully, we all will meet up physically, and otherwise will be hybrid. But please book your dates and welcome to Ahmedabad from all of us. Thank you.
Thank you, Nitish. Since we are running short of time, I'll keep my vote of thanks for the valedictory function. And I again, once again, thank all the executive members of AOCN for allowing us to host this wonderful program in Trivandrum, though we are just organized as a virtual session. Actually, we wanted all of you to come to Kovalam to feel our hospitality. Thank you all once again for being with us and allowing us for with this program. Thank you. Over to your web masters.
Thank you, sir. Next session is a keynote address. Introduction of the speaker of keynote address is a great task and will be done by Professor R. Anandam. For introducing Madam and chair the session, I invite Dr. Anju Kanmani, Consultant Pediatrician, Trivandrum. Over to you, sir.
A very good morning to all. It is with utmost happiness and privilege I am here selected by the grace of Almighty and my teachers to introduce a great teacher, clinician, academician, visionary, and epitome of humanity, Dr. R. Anandam, Professor of Neurology. Madam's name is etched in the history of neurologist fraternity as the person who started the first pediatric neurology unit in SIT Hospital, Government Medical College, Trivandrum, way back in 1984. Madam has been trained in neurology by none other than the world-famous pediatric neurologist and author and the pioneer, Dr. Brett. Madam was a Commonwealth Medical Fellow from 1983 to 84 and has received training in pediatric neurology from the Hospital for Sick Children, Great Ormond Street Hospital, UK. Madam retired as the Professor of Pediatric Neurology from Medical College Tirunelveli in 2000, and currently, Madam is providing expert neurologic services at PRS Hospital, Trivandrum. With regards from Child NEUROCON 2021, the 11th International Conference of Association of Child Neurology, organized by the Indian Academy of Pediatrics Tirunelveli, IAP Neurology Chapter Kerala State, and ICNA International Child Neurology Association, I warmly welcome Dr. R. Anandam, Consultant Neurologist, for introducing the speaker for the keynote address. Thank you.
Dear friends and colleagues, greetings from India. I am from Kerala, southernmost part of India. I am Dr. Anandam, the retired professor of pediatric neurology from Trivandrum Medical College. I am indeed very happy and privileged to introduce Dr. P.A. Mohammed Kunju, who is the former professor of pediatric neurology at Trivandrum Medical College. He had worked with me in Trivandrum Medical College for more than 10 years. He is currently consultant in pediatric neurology at KIMS Hospital and also professor and head Department of Pediatric Neurology at Travancore Medical College, Kollam. He had special training under WHF Fellowship at Pittsburgh, and he is the PhD guide for university students of Kerala from 2013. He is instrumental in starting DM pediatric neurology for the first time in Kerala and also fellowship programs in Trivandrum Medical College. He also popularized newborn screening programs and early detection of deafness in newborn period. He also popularized Botox treatment for cerebral palsy. He has been awarded the Best Doctor Award in 2017, FIAP Award in 2021, and FAPN Award in 2014. He is a great academician and has been confirmed Oration Awards. He has taken key positions in various associations like CAN or Kerala Association of Neurologists in the state IAP and state branch of NSI. He has contributed to the textbook of pediatrics by IAP and also pediatric neurology textbook by IAP, and he has presented several papers in the national and international forums. He has started the support group for Down syndrome, autism, and epilepsy awareness programs in schools and colleges. He is also instrumental in starting the massive training program for school teachers in whole of Kerala in 2018. He is a founder member of the executive member of AOCN, and he is the organizing chair for the 11th conference of AOCN. I wish him all success, and let us listen to him and also his experiences. Thank you.
Okay, thank you, madam, for that wonderful introduction. And I must say that I must start this presentation by doing Guru Vandanam to Dr. Anandam, because as being the Kerala Association of Neurology president in 2019, I was able to honor her in the international conference along with the other veterans of neurology in Kerala. This conference, 11th AOCN conference, is being organized in Trivandrum, and we are all happy that we are able to do it in an international manner. And International Child Neurology Association has joined in hand with the Association of Child Neurology. So when we are speaking about the theme of this conference, that is renewing hope through innovation, my journey in the pediatric neurology is actually along with this innovative pathways, because when we started the pediatric neurology along with Madam Dr. Anandam, who did her DM neurology in Madras Medical College and started pediatric neurology in Trivandrum Medical College way back in 1980. I just joined diploma in child health at that time, just after, I think, 2 years after the starting of the department. Since then, I am associated with pediatric neurology. That means from 83 onwards, I have at least some association with the pediatric neurology. And since then, we all know that the pediatric neurology, they didn't have much diagnostic setup. Only the syndromic diagnosis was possible, and most of the time, only the even pain syndromes like headache in children were not recognized. So because of all these things, pediatric neurology was considered as an armchair practice. We just discuss, make a diagnosis if possible, and then just relax back. That was the thing we were doing. But now we all know that it is the era, especially 2021. Though we are all facing the COVID pandemic, there are a lot of treatment aspects are coming in pediatric neurology. Even for the non-treatable cases, the treatment is coming up. For example, cerebral palsy, which was considered as a non-treatable condition. Now, with the various management programs and the early detection, we can treat at least up to 90% of cases. And whole lot of changes has happened in metabolic disorders, then neuromuscular disorders, epilepsy, and even in neurocutaneous syndromes. So new drugs have come for epilepsy, migraine, genetic treatment is there, megavitamin therapy for various syndromes, and neurodevelopmental advances. All these were discussed in the last 3 days. I will just highlighting all these treatment aspect through some of our cases. And finally, we have to tell about the preventive neurology also. And for this, the primary principle of early diagnosis, early intervention, and specific treatment with rehabilitation has to be used. And don't forget our community medicine days. So from the symptomatic treatment, now we are going to a curative treatment, and that is the precision treatment. So this happened when we were all treating certain conditions which were there, but we didn't know the exact etiology and we couldn't give a specific treatment. Earlier, we were having a child with an altered sensorium, abnormal movement in a setting like this, from where the patient will be coming either from a pig rearing area or from a field area or a duck rearing area. And with a manifestation like this, with an abnormal movement, we used to make a diagnosis of Japanese encephalitis. But after that, when we were getting these sort of findings also with the panda sign, with the MRI or a CT scan, we were able to make a diagnosis of Japanese encephalitis. But then that was in the early 80s and 90s. But just after that epidemics of JE, we were getting a group of subacute extrapyramidal encephalitis. And we were trying to find an etiology by sending for the immunological studies. But at that time, only the JE antibody testing was available. And most of the time, it was coming negative. So we were just blaming the laboratories for not making a diagnosis. And that time itself, we were able to identify the prodromal phase, then the behavioral changes, because of many patients were considered as having a psychiatric manifestations, and abnormal the seizures where we knew that it was some type of seizure, but we couldn't call them in a particular manner. But later we know that this were being called as the fasciobrachial dystonic seizures, and many were having severe hyperkinetic phase. Even one adolescent girl has just chewed away her half of the tongue. But in spite of that chewing away of her tongue, she has recovered and she was hale and hearty. But only when in 2007, when Dr. Joseph Dalmau and his colleagues made a diagnosis of anti-NMDA receptor encephalitis, that we knew those cases were only anti-NMDA receptor encephalitis, secondary to various anti-neuronal antibodies, either to surface antigens or to intracellular antigens. And we also collected a number of cases where all of us know that initially we were giving only steroids, but later a combination of intravenous IV, intravenous immunoglobulin with steroids, and with the continuation of the treatment with the second line treatment of rituximab, cyclophosphamide, or mycophenolate mofetil. And then Dr. Kalpana, Dr. Mini, and all our postgraduate students were able to collect a lot of patients, and they have found out a seasonal dispersion of these cases. And especially when just at the beginning till the end of the monsoon season, we were getting a group of these autoimmune encephalitis and other autoimmune disorders. So with the specific treatment modalities available, and government of Kerala through the RBSK and the Arogya Granam programs, we are providing even the costly medicines to most of these children, and except 1 or 2 patients, all of them recovered. Then the understanding of dystonia and movement disorders in children. Earlier, pediatricians or even the pediatric neurologists were not much diagnosing dystonic syndromes. And only movement disorder that a pediatrician knew was only the Sydenham's chorea. From that Sydenham's chorea, rheumatic chorea, the awareness of dystonic syndromes has started way back in 1989 itself, when I was able to make a diagnosis of Sagawa syndrome by just knowing the manifestation, because till then these children who were around 7 years were diagnosed as having a cerebral palsy, but identifying the dystonic manifestation in the child and getting the information that child were just normal in the early hours of the day, giving levodopa has given them a good lease of life. You can see that just after 5 hours of levodopa, those two children were moving around in the wards of the SAT hospital. And they are still under our follow-up. And after 20 years, these are the pictures taken in 2008. Even though they are continuing with levodopa, their performance is good, and both of them are working, and the girl is married. So that is the story of Sagawa syndrome. And even in 2021, we were able to make a diagnosis of this one. But at this juncture, the diagnostic armamentarium has changed. It was not at all clinical, but clinically this child also was diagnosed as having a cerebral palsy. But because there was a regression of the milestones also, diagnosis of metachromatic leukodystrophy was made, but MRI was negative. So gene testing was done, and then the diagnosis came as Sagawa syndrome by identifying the tyrosine hydroxylase mutation. So the patient was given levodopa, and the patient has shown very good improvement and now started walking. So that is the way we have changed from the clinical diagnosis to the gene testing. Simple diagnosis by clinical analysis also will be helping us in the treating problems. For example, when a child comes with an abnormal eye movement or an ophthalmoplegia, if it is bilateral with a diurnal variation, we will think of a myasthenia gravis. But if it is unilateral with a specific manifestation and just looking for an abnormal sensory finding the forehead, we can make a diagnosis. And again, by going for a contrast MRI, we can make the simplest diagnosis or a simplest treatable condition, that is a Tolasa-Hunt syndrome. By the only thing is that you have to go for a contrast enhanced MRI. And the patient is treated with methylprednisolone at a higher dosage, that is 30 milligram per kg. Just after the 3 days, child showed complete improvement, but the patient was continued on steroids. Again, the epilepsy treatment from just a diagnosis of seizure disorder, we have gone far ahead. First, again, the principle of the treatment of identifying the mimics, then seizure types, and finally the syndrome. The diagnosis of the syndrome has helped us in identifying the various genetic manifestations as the genetic variabilities according to the geographical areas. And again, the knowledge of a reflex anoxic seizure has helped us in reducing the unnecessary anticonvulsant treatment for patients with epilepsies. And I always tell this 10 diagnoses that you cannot afford to miss as treatable epilepsies, because all are aware of the B6 and related epileptic syndromes, glucose transporter 1 deficiency, hyperinsulinism, hyperammonemia syndrome, developmental delay, epilepsy, neonatal diabetes, which can be very well treated by metformin. Then even the hyperexplexia syndrome can be managed by just giving clonazepam or by the Vijayavanu's mothers, and going for a MRS will help us in identifying creatine synthesis disorders. All these disorders were discussed in our various talks that we have had in the previous days. This was again an earlier diagnosis of a biotinidase deficiency by just the child who was having a fragmentary myoclonus in a very resistant manner, but identifying the skin manifestations, alopecia, and doing the blood biotinidase level by the help of the CDFD, because CDFD was helping us from very early time onwards. By starting biotin, the children has improved considerably. Then again, the utilization of the MRS also help us in identifying various treatable conditions, as in this case where the creatine peak, which is absent in a case of an intractable epilepsy, the commercially available creatine itself can be used for the management of these patients, because these are available in the various protein stores that are available in our neighborhood. And all of us are aware of the coming up for the various anticonvulsants. You can notice that up to 80, see, and up to 1990, very few anticonvulsants were there. When Adam and the madam was there, we were just middling with 2-3 drugs. And one of our special drug at that time was primidone, which was utilized for treating seizures with complex partial manifestations. And now we know that every year or even every month, newer drugs are being added, and especially from 1990 onwards. And the final, the entry is brivaracetam, at least by 40 manufacturers in India. And even we have tried cannabidiol and styripendol, even though touted to be having an excellent effect. But again, because we are using in various epileptic encephalopathies, we are not able to get much effect. And I find clobazam as a wonderful drug, which we started using from 1989 onwards after the World Congress of Neurology in New Delhi. And it can be considered as a wonder drug, which can be used even in situation-related epilepsies. And as Indians, we are all using clobazam as a prophylactic drug, even though all the bodies are not advising any prophylaxis for febrile convulsions. All the clinicians in India will be using clobazam, and most of the people are happy with it. And finally, regarding epilepsy, we all know that we can detect it and manage them in a very, very manner. For we know that the MRI in temporal lobe epilepsy, especially in older children and adults, are giving us a lot of diagnostic clues, and by which we can give a surgery. This is one of our case which we did surgical correction. That was a ganglioglioma in a child with complex partial seizure, again way back in 1996. And recently, with the help of Srijitra Irnal, we are able to do epilepsy surgeries. And this is one of the cortical dysplasia, focal cortical dysplasia, which was diagnosed only by again the newer innovation of 3-TELSA MRI. You can see that the usual MRIs was not showing that lesion, but the lesion is seen in the MRI at the 3-TELSA, and the surgical removal has given. And in the field of epilepsy, in spite of all these advances in the treatment, we were in the forefront of alleviating the myths related to the epilepsy, because even now people are always giving the knife or the key for controlling the seizures. And we produced a film on epilepsy, and it is being widely seen among through the YouTube. And then regarding the migraine, we must also know that earlier migraine was not at all diagnosed in children. And M.K.C. Nair, he was instrumental in bringing out the importance of migraine in children way back in 80s itself. And now I always teach a comprehensive evaluation of migraine for a simplified treatment protocol, because the EC3s, actually in neurology, the triad approach is very, very useful. And for headache management also, this EC3s can be utilized. That the 3 types of primary headache are there. 3 types of headaches are there. They are primary, secondary, and various facial pains. And 3 types of primary headaches are migraine, tension type of headache, and earlier called as cluster headache, now called as the trigeminal autonomic cephalalgia. And for the primary headache, we have 3 modalities of treatment. They are the acute or the abortive treatment, preventive treatment, and the biobehavioral treatment. And we have three modalities of preventive treatment. They are the for the acute treatment, we have a non-steroidal anti-inflammatory drugs, anti-emetic drugs, and the triptans. And for three types of treatment for the preventive treatment are beta blockers, antidepressants, especially amitriptyline, and the anti-epileptic drugs like topiramate. And currently, a lot of newer modalities of treatment are also coming, like CGRP drugs. But it is seen that they are, even though a number of drugs are there and people are using it, but it's add little to the migraine care. Various Zumabs are available, and it is said that this anti-CGRP MABs are useful, especially when one is having more than 8 headache days per month, or have a pedometer score of greater and failed at least 2 other therapies. Then CGRP drugs can be utilized. And we all know that neurometabolic treatment has become equivalent to pediatric neurology, and all the pediatric neurologists are neurometabolic specialists. From the very early age of diagnosing metabolic disorders by doing a urine ferrichlorate test, where an emerald green color will be obtained in phenylketonuria, greenish brown color in histidinemia, and a navy blue color in maple syrup urine disease. From that, we have now easy method of doing TMS or a GCMS, and enzyme estimations, and genetic diagnosis. So with that, we can make a diagnosis. This was one of our earlier case of phenylketonuria, very rare in Kerala, where we can go for the drug the dietary modifications, but we get a few, quite a few cases of maple syrup urine disease, where again we can go for a leucine, isoleucine, or valine deficient drug, and where diet. We are all aware of other dietary modifications of various other metabolic disorders. I'm not going to that. And very early ages times itself, we were able to make diagnosis of Mengi-Skingi disease, where Thomas of Vellore for getting the copper histidinate. And you can see that CT diagnosis of adrenoleukodystrophy, where again the posterior part of the MRI will be posterior hyperintensities will helpful in the diagnosis, and the Garlanding sign is the diagnostic clue. But even though the Lorenzo soil was touted to be a good drug or a good dietary modification for this, but people go for it, but without much benefit. But now we know that early diagnosis and stem cell therapy will definitely help these children with adrenoleukodystrophy. And we are into enzyme replacement therapies also. We are giving a treatment for Pombe's disease, Hurler syndrome, and various Fabry-Syme for and through the charitable help by Shire as well as Genzyme. And the current inclusion is the Brainura, that is the treatment for the neuronal lipofuscinosis type 2. All these are can be considered as a definitive treatment for these children who would have died earlier without this drug. And again, various modalities of treatment are also helping. For example, when you have a therapy in Gaucher syndrome by giving imiglustat or imiglustat glucerase is also there. So that means
I think there is some connectivity issue with Kunji sir. We will wait.
I'm sorry that the connectivity has gone because actually I have logged in from hotel Wi-Fi. That is why. Okay, I'll be just concluding my talk in another 2 or 3 minutes. We all are aware that we have a very good treatment opportunities nowadays for neuromuscular disorders. We with just our Dr. Kalpana has just given Zolgensma enzyme replacement, the gene replacement therapy for one of the patients with SMA. And yesterday, one of my patient just called me that she has been allotted nusinersen for the treatment program. So that means we are all into newer modalities of treatment. Earlier itself, we were making diagnosis of Duchenne muscular dystrophy, and we could give a good ambulatory support by giving deflazacort and by the steroid treatment. Because of the steroid treatment, we all know that by the ontology of the treatment, the patient usually child with Duchenne muscular dystrophy will become wheelchair bound by 12 years. But by giving a early steroid treatment, earlier with prednisolone and now with the deflazacort, we can definitely improve their ambulation up to 17 to 18 years. I have my patients are even, especially the +2 children, are traveling to schools by themselves. So again, a lot of DMD gene therapy has come up. We had a very good debate on this also, and we know that many of these treatment will be made available to India also. Finally, it is a cerebral palsy. This still the main thrust of treatment. Here again, in spite of all these advances in the treatment, the early development, early diagnosis, and the early stimulation, and the advent of the developmental observation card. Again, I always tell about this in all the forums in India, where Dr. M.K.C. Nair was instrumental in identifying development or formulating this developmental observation card by just looking at 4 developmental milestones and easily rememberable. That is head social smile at 2 months, development head steadiness by completed 4 months, sitting without support by completed 8 months, and standing without support by 12 months. That means 2, 4, 8, 12. Just remember this, and if there is a delay, you go for the early stimulation. By just simple technique like this, asking the mother to carry the child astride and moving the angle as well as the knee in both directions by carrying in both the hips, and one will be where mother will be, and mother as the therapist will help in reducing the spasticity and bringing these children as well as activities of giving importance to the activities of daily living by improving their functioning and enabling these children and empowering them to the society. And again, we all know that we have to be the advocates for mainstreaming and providing them the opportunities. And now there is a paradigm shift from the just hypoxic ischemic encephalopathy to the genetic basis of cerebral palsy, because up to 50 to 60% of the cases of so-called cerebral palsies can be due to genetic disorders, and several genes have been mapped, and this will give an opportunity for identifying newer treatment modalities also. And already I have mentioned about the importance of giving levodopa, and we have used the baclofen pump for some patients with cerebral palsy. Similarly, the earlier simple surgical treatment or a phased treatment has given way to the Semlaris, where a single even multi-level liver arm restoration and anti-spastic surgery is the best one, because earlier people used to do a single surgery and wait for the effect. And I am happy that from the very beginning of botulinum toxin availability, we were able to use it for children with various problems, like so for example, a dynamic ankle spasm, or for a hamstring spasm, and for a adductor spasm. So these drugs can be used. For example, hamstring injection for couch gait, hip adductor spasm injection, hip adductor injection if there is a scissoring, and for a dynamic equinus, you can give injections to the calf muscles. So the standardized dosage is also available, and even for children with hand function abnormalities, especially with hemiplegia, we are using botulinum toxin treatment. Along with this, we have to advise the night splinting as well as other splinting. Again, pediatric neurologists must be knowing all these things, and they must advise the treatment in a systematic manner. And botulinum toxin has got a remote effect, like improving the facilitation of the hygiene also is there. And also, I have been an advocate in providing squint surgeries for these patients, because many times ophthalmologists never give any importance to the squint surgery, because it is a time-consuming surgery. And new knowledge in the management stroke also has come, especially the vasculitis syndromes. And before stopping, I must tell that how we conquered Nipah, as well as we are conquering COVID-19, because we all know that we were able to contain Nipah within 1.5 months. But now the world is struggling with COVID-19, and we are having a resurgence also. And finally, I must say that we were able to eradicate most of many neurological problems, like through the which was produced by polio, but still we are there to eradicate leprosy. This is one patient which was not being diagnosed just because the shirt was not removed by the other people who haven't seen the seen the patient and made a diagnosis of hereditary motosensory neuropathy. By just undressing, the diagnosis was obvious. That was a case of Hansen's disease. And we all know that we are into the eradication of tuberculosis, and we are seeing very few cases of tuberculous meningitis now. And to conclude, even though I have told about a lot of innovations and the treatment strategies, we can't forget the common conditions. Your common gadgets you have to utilize. For example, this child who presented with a sudden deterioration of vision without any precipitating event. And the MRI showed this picture. And after the MRI, people measured the BP. So this was a case of press producing cortical visual impairment. So you should not be forgetting our blood pressure apparatus. And this child was having a renal artery stenosis, and you can see that there is complete atrophy of the kidney on one side. So never forget your clinical instincts and the basic examination skills. So to summarize, we know that the common conditions should not be forgotten, but by the newer techniques like the gene advances, as well as the various modalities of imaging, we are having better knowledge, and we are having a lot of advances in the epilepsy and migraine treatment. We are still getting newer and newer treatment modalities for cerebral palsy, and we are into the neuromuscular curative treatment, similarly neurometabolic treatment. I take this opportunity once again to thank all of you for partnering with Trivandrum, IAP Trivandrum Neurology Group, as well as the Indian Academy of Neurology, Neurology Chapter, Kerala, and Indian International Child Neurology Association. Thank you once again. Okay, Dr. Anju, you can continue.
Yes, sir. Thank you, sir. Thank you, Dr. Mohammad Gunni, sir, for that excellent delivery of the keynote message. for the comprehensive presentation covering the historical milestones with the rare and interesting invariable photographs and videos, and for providing the state-of-the-art situation of the spectrum of neurological diseases, stressing the updates and conveying the U-turns and the importance and duties of the neurologist in the society for the better outcome of the world, that is renewing hope through innovation. Thank you very much, Dr. Ananda Madam and Dr. Mohammed Kunya sir. Now we will go on to the next session as soon as possible. Thank you very much.
Coming up is an important session on newer anti-seizure medications and on SUDEP, which is an under-recognized serious cause of concern in patients with epilepsy. Chairs of the session are Dr. Deepak, consultant pediatrician from Kollam. He is also the master brain behind the Child NEUROCON logo and brochure. Dr. Rajagopalan, consultant pediatrician and neonatologist. He is a chairperson of IAP Neurology Chapter, Kerala. This interesting session is moderated by none other than Dr. Biju Hamid, the editor of ICNA and the man behind this conference. Over to you, sir.
Thank you very much. I have great pleasure in inviting Dr. Anita Hegde to give her talk on anti-epileptic drugs. Anita doesn't need any introduction. Over to you, Anita. Thank you.
Sorry, will they start the recording? Good day, everybody. My topic for today is newer anti-seizure medication. I'd like to start by thanking the team at Trivandrum, Dr. Kunju, Dr. Mini, and the entire team for giving me this opportunity. I'm going to start with a little bit about the history of anti-seizure medication. It's always interesting to know how something started. So prior to the 19th century, which was the early era, epilepsy was treated with spiritual and supernatural remedies, and it was known as a sacred disease. And it was not until Hippocrates discovered that it was really a disease arising from the brain. Herbal and botanical products were used freely, and it was by serendipity that Sir Charles Locock discovered the first anti-epileptic, that was the bromide salts, in 1857, when he realized that the salts which he was using for preeclampsia in his pregnant women, he was an obstetrician, was actually helping with the seizures. Subsequently, a German company, Bayer, produced a drug called phenobarbital, which was called luminal, and it was really made for its sedative effects until Dr. Alfred Hoffman in 1912 realized that it had very potent anti-epileptic effect. We then moved to the pre-modern era, where we start in the 1930s, where Merritt and Putnam discovered the first model or seizure model, and subsequently phenytoin was discovered. It was found to be very good for seizures and less of a sedative effect, and more drugs was trimethadone, succinamides were all discovered over a period of time, but the whole era was largely focused on finding different animal models or different epileptic models on which they could try the drugs. We now move to the modern era, where we have 20, 30 anti-epileptic drugs in the market. And while the newer ones are as effective, they've improved the quality of life because of better tolerability, but the efficacy is roughly the same. The tendency and the move is now to go towards modifying treatments, which we still haven't succeeded in today. And with the advent of personalized medicine, we're going to have smaller patient cohorts, targeted trials, directed therapies. So this is a chart we're all familiar with. We started with the early period, the 2 drugs for a century, and then you have first, second, and third generation. And today what we're going to discuss is only those beyond 2010, which is half of the third generation. So when you see these drugs, they are approved by different bodies. So you have the European Medical and the Food and Drug of America, the FDA. And while you see stiripentone came out in 2007 in Europe, it came out as late as 2018 in the US. Fenfluramine is the latest one who's come out here. So usually when a drug comes out, it comes out in adult first. It comes out as an adjuvant first. A whole 5 to 8 years later, it comes out in pediatrics, first as an adjuvant and subsequent as monotherapy, first maybe in focal and then in generalized, or the other way around. So pediatrics usually gets the benefit of a new drug a whole 5 to 8 years after it comes out in adults. The phases of drug development, you see when a molecule is discovered or thought of, you go through a preclinical stage, which is animal model. You then go through clinical development, phase 1, 2, and 3, which focuses on safety, what it does to the human body, efficacy, and then long-term tolerability. And then you go through the application through the drug bodies. And then this is where we actually come in post-marketing development, which is phase 4. But you do see that the timeline from the onset is from -0 to almost 13 to 15 years. All these products, for every 10,000 products which have a drug discovery, as little as 1 will come out, which will eventually reach the chemist's store. And you go through all the stages. So you realize that it's labor intensive, it's finance intensive with a very low success rate. So how are drugs developed nowadays? One is this method, the new molecule method. It's expensive. It's a very long duration from the chemical to the drug. The time lag is very long for approval and the success rate is low. Then you have parent offspring method. You benefit from a primary research molecule. You tweak it to make it more effective, more tolerable, different indication, and it subsequently is less expensive. It's easier to market. It's well tolerated and accepted, and shorter approval duration. And then you have repurposed molecules where after the onset of genetic understanding of genetics, you can use a molecule which is already in the market for another indication, understand how it is worked and see whether it has an anti-epileptic and then bring it into the market as an anti-epileptic. So we're going to start with drugs. The first one is ritagabin. It was approved in 2011 and then discontinued in 2017. It works on potassium channels. It's for focal seizures with or without generalized epilepsies, and it's an oral preparation. And it was sad to see it go in 2017, not because it was not effective, not because it was not well tolerated, because of commercial reasons. There were too few prescriptions and too little margins. So it was taken off because there were not enough indications for this drug. The next one we have is eslicarbazepine, 2013, and then pediatrics in 2017. It's a voltage-gated sodium channel, slow inactivation. It's an adjuvant for focals. The doses are similar to the parent molecule, and it's available in tablet with no syrup and injectable. It's found to be effective in children and adolescents for focal onset seizures. It's found to be safe in children and adults above 4 years of age, as safe as it would be in adults. Its side effects is relatively similar to what you see in its parent molecule, carbamazepine and oxcarb. Its adverse events, the main ones are dizziness, somnolence, diplopia, and a little bit of ataxia, which may be there. Advantages: single daily dose, no drug-drug major interactions, its favorable safety profile, less cognitive behavior concerns. The main thing with carbamazepine we have is the fear of the skin rash with the HLA 1502 and 3101, which by default, you would have presumed you should contraindicate it for the same reasons, but there is a very good study to show that in a patient with carbamazepine drug rash, eslicarbazepine was used and was very well tolerated. The other concerns we have is this is a slow inactivation pathway. Against the other two are fast sodium channels. And while we know that carb and oxcarbazepine are pro-epileptic, they induce seizures in myoclonic absence seizures, etc., esli does not have that effect, and it actually lacks an ability for seizure exacerbation. It, in fact, inhibits the generation of hyperexcitable networks and to some extent has a mild anti-epileptogenic effect. So when you compare, you can see from 68 to 99 to 2013, how long this, it's like parent, grandparent, son, and grandson virtually, which has come through. Its epoxide lacks the epoxide. It is a weak inducer. It has a very long half-life. That's why it's OD use. Dose is relatively similar. It's a slow sodium channel inducer. It has less side effect. It does not have pro-epileptic activity, and it comes only in the tablet form. The next one we go to is brivaracetam, FDA approved in 2016 for pediatric approval after 4 years. It works on the same mechanism levetiracetam, an SV2A vesicle protein. Monotherapy, adjunct therapy, doses 1 to 2 per kg, maintenance 1 to 5, maximum is 200, and dose is tablet 25, 50, 7500. Syrup is not there, but trust me, it's coming in a very short while. And literally, as I talk, yesterday, the first injectable was released. So for all of you who've been going to clinic and have reps coming to you, I'm sure you noticed that overnight, one day, we had 10 different brivaracetam preparations at our doorstep. And I sat down to think, how could it happen that overnight 10 companies came out with the same product? And that's because of our Indian patent regulations, where the method of manufacture, ideally a patent is for 15 years, 14 to 15 years. But if the substance is intended to be used as a food, a medicine, or a drug, then the period of 7 years from the date of filing or 5 years from the date of sealing the patent, it can be released. And that is why you see it was February 16, literally in the last week of February 2021, 5 years later, all the Indian companies were ready with their brivaracetam preparation and flooded the market. It shows we've got ample literature to show it's very effective. It has very little side effects. It's in fact more effective than levetiracetam. Side effects are similar, but to a lesser degree as what you would get with levetiracetam. And when you compare them, it's a more selective binder. It's safer. It's more effective. It's rapid onset, rapid titration, fewer adverse events. We had no syrup, but injectable actually came out yesterday. Not much data yet regarding monotherapy for generalized seizures, and being a new drug, it's not yet under price control, which is for the case for levetiracetam. So finances becomes a concern in a country like ours. The next one is cannabidiol. We are all familiar with the story with Charlotte Figi, the young girl with Dravet, who moved to Colorado and benefited tremendously with the cannabis, and thus an oil was produced, which was subsequently called Charlotte's Web after her. In 2018, the FDA approved cannabidiol for Dravet, Lennox-Gastaut, and intractable seizures. The drug product is called Epidiolex. Unfortunately for us, we lost Charlotte last year due to suspected COVID at the age of 13 years of age. 2 compounds in the marijuana or in the cannabis, which is the THC, which is the psychoactive version, and the cannabidiols, which is the non-psychoactive version. They bind to 2 receptors, CB1 and CB2. The CB1 is for coordination, pain, emotion, mood, thinking, appetite, and CB2 is an immune modulator, inflammation, and pain. So while TCH usually attaches to CB1, the CBD actually attaches to the endogenous cannabinoid receptors and thus produces an endocannabinoid system. So FDA approved it in 2018 for these epilepsies, and subsequent, within 3 months, the FDA downgraded Epidiolex, or downgraded medicinal marijuana from a Schedule 1 product to a Schedule 5 product with a low abuse potential. And the WHO is following suit and will soon be doing the same for medicinal marijuana. So CBD approved in 18, it's a GABA receptor modulator for seizures more than 2 years for these indications. In the initial dose of 5, maximum dose of 20 per kg in BD doses, and it's an oil preparation. So what's the state of medicine marijuana worldwide? The legal state is the green countries are those where it's only authorized if a physician signs for it. And a blue country is where it is states or countries where it is legal at all times. And gray is where it is totally illegal, by definition illegal. However, what's the legal state of recreational marijuana or cannabis? Blue, the same countries, it's legal for recreational as well as treatments. Yellow, it is illegal, but it is decriminalized. So this is where the physician can write your prescription and nothing will happen. Pink, it is illegal, but it is often unenforced. So this is where India falls into the thing. It's officially illegal, but very often it can go by because it's unenforced. And red ones are, it is illegal and criminalized if you are found with it. So other indications, anxiolytic, because it works on the limbic and paralimbic regions, antipsychotic, because it induces endocannabinoids in our system, For neuroprotection, it's found to be neuroprotective. It reduces hippocampal volume loss, anti-inflammatory, antioxidant, and that's why it's finding a place in status epilepticus now. Spasticity 1-to-1 with THC and CBD for spasticity, chronic pain, we know, cancers, and addiction for those who have for cannabis users. The main side effects are largely neurological with sedation and somnolence, fatigue, convulsions, a little bit of hepatic side effects, GI, respiratory, but the main one to remember is it enhances the effect of clobazam. So you need to adjust the dose of clobazam if you're using it with CBD. So this is the Epidolex, which is available in the market in a few countries, FDA approved, now called Schedule 5, effective with a 99 to less than 1 THC. These are the off-the-counter ones which are routinely available, not FDA approved, Schedule 1 still, not proved to be effective, but they claim to have the same concentrations. The next one is perampanel. It's approved in 2012 for children more than 4 years. It came in 2018. It's a non-competitive AMPA glutamate receptor. Interesting, a new method or a new modality of treatment. So it's a good additive drug. Focal seizures with or without generalized seizures. The dose is 2, then 4, then 6, then 8 to a maximum of 12. And it only has an oral tablet. So what do we mean by a non-competitive AMPA receptor? This is the glutamate. The glutamate gives you an action potential. When this happens, the minute it starts, perampanel comes in and binds to the AMPA receptor in competition with the glutamate and thereby aborts the desynchronization or aborts the neuronal hyperexcitability. So when it's competitive, so here you have your AMPA receptors and you have glutamate and perampanel floating around. When it's competitive, whoever is in higher concentration will get the better of the AMPA receptor. When it is non-competitive, once perampanel is bound to the receptor, irrespective of the amount of glutamate in this vicinity, the perampanel will not dislodge from the receptor. As far as initiation, it's oral administered, protein bound by 95%, metabolized by first, negligible by first pass, metabolized by inducers, excreted in the feces by 50, urine by 22. Half-life is 105 hours. That's why it has such a long half-life and has OD dosage. So it's rule in pediatrics. It's an excellent additive drug as an adjuvant for refractory epilepsy. And the main side effects are dose-dependent psychiatric, irritable and aggressiveness, whereas the advantage is it's single dose and it has less cognitive side effects. The next fantastic drug we have is lacosamide. And as we go further, we realize we're using it more and more, and it's very effective. Pediatric approval in 17 for focal, in 20 for generalized, slow inactivated voltage-gated channel, sodium channel, mono and adjunct therapy for children more than 4, 2 milligrams, go to 6 to 8, but those of us who use it know we can go to 10 to 12 as well. It has tablet, it has syrup, it has IV, so that makes it very attractive for the pediatric population. So what is a slow sodium channel? So this is my sodium channel that's here. And you can see that when the channel is open, the ions are moving through and through. This is an activated sodium channel. Now you see this ball valve mechanism at the bottom. When that ball valve goes and closes this hole at the end, it closes the channel and this becomes an inactive sodium channel. This happens very fast. And it opens again also very fast. So this is the circuit for a fast sodium channel. When you have a slow sodium, you don't have a ball valve mechanism. And what it does is the lower half or the thighs or the legs of the sodium channel have to abduct together to close the channel so that the ions cannot percolate through. This action takes time. Inactivation also takes time. And thus the entire cycle is slow. And that is why it is called a slow sodium channel. So this is what a fast inactivation will do repetitively, whereas a slow inactivation will be incremental and build up over time. So other than S-carb, which is a slow channel as well, all the other sodium channel drugs that we have are fast sodium channels. So how does this translate into clinical practice? So now with the advent of so many SCN genes coming through, you want to know which ones you can use sodium channel drugs and which ones you can't. So when you're looking at SCN1, you'll have febrile seizures after 3 months. Most of them are associated with loss of function. And if you have loss of function, it means poor response to sodium channels, actually exacerbation with sodium channels, drugs. SCN2A, you have two variants. You have seizures before 3 months and seizures after 3 months. Those who come before 3 months have usually gain of function. Those after 3 months is loss of function. Gain of function goes well with good response to sodium channel. Loss of function goes with resistant to sodium channel blockers. SCN3 seizures start within the first few days of life. Aggressive epilepsy, gain of function, responds beautifully or very well to sodium channel blockers. SCN8A again has two variants, those with neurodevelopmental disorder and those with epilepsy. The NDD ones have a loss of function, but they don't have epilepsy, so treatment is not a consideration. Those that have epilepsy is gain of function, so they actually may respond well to sodium channel blockers. So in conclusion, those who have late onset seizures greater than 3 months are usually associated with loss of function, have a poor response to sodium channel drugs. And early onset less than 3 months is associated with gain of function, which have a good response to sodium channel drugs. And thus, we can infer that if a child is suspected with a genetic epilepsy in the first few months, less than 3 months of age, you should consider adding a sodium channel drug on them even before your genetic report comes, because we can't afford to lose those 4 to 6 weeks, because invariably it will not be an SCN1A or a Dravet syndrome. So the adverse events is nausea, vomiting, dizziness, very few major side effects. Advantages, effective, safe, tolerated, little drug interaction, enteral and parental, and it's turning out to be a good drug for status as well in the pediatric age group. The next one is everolimus. I just want to run through where it started from in 2009 for advanced kidney cancer treatment. Then it went to pancreatic NETs. Then it went to non-cancerous kidney tumors in TSC, breast cancer, brain cancer, lung and GI neuroendocrine. And eventually it became used for partial onset seizures due to tuberous sclerosis. So you can see how one drug with one pathway or one mechanism is now being repurposed for multiple indications and to treat multiple things. So FDA approval for tuberous sclerosis 2018, inhibition of the mTOR pathway, which regulates growth, proliferation, and survival. Children older than 2 years, 5 milligram per meter square, single daily dose, and it's oral. We do know that mTOR signaling in the brain does not only affect cortical dysplasias, if it has abnormal neuronal morphology leading to intellectual disability, autism. You have increased growth and proliferation leading to cortical tumors, subependymal nodules, and epilepsy. Reduce autophagy and apoptosis leading to SAGAs and cortical tumors, epilepsy. Abnormal migration leading subsequent to tubers, white matter, epilepsy, neurocognitive, and it also interferes with channels and neurotransmitter, interfering with our GABA and glutaminergic excitation, leading to epilepsy, autism, neurocognitive disorders, and social dysfunction. So everolimus is an analog of rapamycin with antifungal and immunosuppressive therapy. It's a hyperactive of the mTOR pathway due to loss of function of the TSC gene, and it is also implicated in the development of benign tumors. So the studies, when it came from epilepsy TS point of view, first it was for SAGAs, where it showed 35% versus 0 in placebo, 50% reduction. Then for angiolipomas, the sizes decreased by 50% in 42 versus 0. And then for epilepsy, it improved by 40% in high dose, 28 in low dose, and 50 in placebo when using it for refractory partial seizures. Adverse events are the main concern, repeated or multiple types of infections. Very often we may need to stop the medication because of this. And we do know when we stop the medication that actually the tumor or the SAGA size may increase. One of the treatment options for drug-resistant epilepsy, particularly for the treatment of the SAGAs. Stiripentone. Discovered in 1978, originally for adults with focal seizures, it failed the trial and it was taken out immediately. A whole 20 plus years later, it came as an orphan drug in the European Medicine Agency for Dravet syndrome. In 2017, it was registered and granted for a drug marketing, again for Dravet only, as an add-on treatment. Then it was approved in Canada, then it was approved in Japan, and now it's been approved in the US as an approved drug for Dravet syndrome. So it's approved in 2018. It's a GABA A receptor modulator. It's adjunct treatment in conjunction with clobazam and valproate for children over 2 years, 5 to 10 milligrams in divided doses to a maximum of 50 per day, and it comes only in capsules and sachets. So it's very well accepted. It's very effective. This was a lovely 12-year observational study with our own Dr. Shekhar Patil as part of it, which showed that it's safe, that it's effective, and its long-term side effects are also, the status also decreased by 40% in these patients. So it's an aromatic alcohol structurally, it's well tolerated, its main side effects are somnolence, drowsy, and anorexia. It has increased risk, but these are the common side effects we see with most of our anti-epileptics that we have. So the concern is availability in India. You need to import it from France. You go through different pharma companies, and these are the types of drugs. So those drugs which are not available in our country, we have the ability to try and source them legally and officially today through certain companies, either those who are still in clinical development, those not available in our country but in another country, off-label indication, discontinued in the market, approved but not yet commercialized, not approved in clinical trial for small populations. So that these are the different categories by which you can put it. But the most important one is called the named patient program, and we'll go into that. So this is just to show you the average timelines of commercially available medicines in India after they've been approved by the US FDA. So the average time lag is roughly 5 years. So if you see, these are the years. The purple line is the average time lag it takes for us to pass. So it ranges from 4 to 8 years before we will pass a drug which has been passed there. Usually by the time you pass it, the patent may have already lapsed. And the yellow line is the number of drugs the DCGI has released each year. So in 2007 and 8, it released as many as 250 drugs, but in 2001 and 2, it released as little as 25 drugs. So you can see how variable the picture is. The named patient program, the Drug Controller of India or the DCGI has the final word on your application. The license and customs exemption can take place if it is for personal and for life-saving medication. Do realize it is not the authority of the physician or the institute to do it. We are just pushing their form forward. We have no right to transact it. The physician role is restricted only to recommendation. Even hospitals and institutes cannot interfere in this. And these are the forms which are needed to be submitted if you wish to apply. Not to miss that the government charges a 22% service tax or a customs duty on it with an additional 12% GST. So the price you get it at is an additional 33% over the original price. And these are the government charges, but you can ask for custom duty exemption if it's on a personal one-to-one basis. And the last drug for today is fenfluramine. Fenfluramine is a derivative of amphetamine. In 1963, it was introduced in France as an appetite suppressant. In 1973, it was approved by the USA and it's used as an anti-obesity medication. In 1990, the first report of causing pulmonary hypertension and dyspnea came out, and in 1997 and 1998, it got banned in the US and subsequently banned in India as well. It was in 2020 that it was approved again for medicinal use in the United States with an indication only for Dravet syndrome. So it's released again in 2020. It's a serotonin-releasing disruptive vesicular storage of the neurotransmitter, treats seizures with Dravet older than 2 years. The initial dose is 0.1, maximum is 0.35 if it's without stiripentone. If it's with stiripentone and clobazam, you have to adjust the dosage. It's an oral preparation. It's very well tolerated, it's very effective, and it had no valvular heart disease, pulmonary hypertension, or other cardiac abnormalities noted in the study that came through. Advantages, it's the treatment for Dravet and Lennox-Gastaut today. We don't know what it will be used for tomorrow. And absence of psychotropic. Disadvantages, it has a dose-dependent neurological side effects. The regular ones which are there with most, increased plasma levels of clobazam. So you require to reduce the dose of clobazam. It can be hepatotoxic if combined with valproate. These little things need to be kept in mind. And the last but not least, most important part in our country is the cost of these drugs. So while it's lovely to know all about these new drugs and their mechanisms of action and how good they are as far as tolerability goes, at the end of the day, these patients have to take them for periods of 2 years to lifelong. So the cost is a very important deciding factor. And here you have the top drugs are the ones which are not available in our country and are still very, very expensive. I put vigabatrin in as well because we still don't get vigabatrin and we need to import them. Everolimus we do get, but it's very expensive. And you can see the others range from 8 rupees to 120 rupees for the other newer anti-epileptics third generation. The second generation ones range from 5 to 6 rupees to 30 rupees, which is distinctly much better than the other ones. And the first generation range from 2 rupees to 5 rupees. So you can understand why we still prescribe so much of our first generation. They are as effective. They may not be as tolerable, but they get the job done in a large percent of the population who can't afford all these higher level drugs. So in conclusion, drug development has evolved over the decades. Developing a new anti-epileptic molecule is very expensive, laborious, and takes a very long time. The new methods today are trying to find an old molecule, revisiting and re-exploring its potential. Parent-sibling molecules, repurposed molecules. Newer AEDs are very effective with relatively less side effects, and thus, because they improve the quality of life, we consider them. Until they come on the Indian market, the cost is a huge deterrent. We lag the developed world by 5 to 8 years while launching new drugs. Genetic epilepsies will be addressed with focused trials in the coming years. The sad part is that none of our drugs are anti-epileptic by definition, and in spite of all the advances, 30% of patients still have refractory epilepsy. Thank you.
Thanks, Anita. That was a fantastic review. It was great listening. There are a few questions. Perhaps I could start with what Nitish is asking. You correctly mentioned that there is no right anti-epileptic drug. All that we have is anti-seizure drugs, aren't they? So Nitish is asking whether what would be the ideal anti-epileptic drug, or are we anywhere near to it? What extra qualities would you like to have in the best or the ideal anti-epileptic drug?
So I think the focus of drug development in epilepsy, from what I read, it was lovely reading so much when you have to talk on something, is the focus is going on to anti-epileptic drugs. So with the advent of genetics and understanding how the drug works and understanding how the gene works, I think people are focusing on how to prevent it or prevent the epileptogenesis rather than just be a seizure medication. To some extent, a Sabril or a vigabatrin is a drug to that effect. I mean, when the studies show you that those who were given preventive medicine versus those who were given after the treatment indicates and shows you that it's anti-epileptogenic nature to some extent. But why? Because it's working through the pathway and not just as a neurotransmitter related drug. So I think with time, difficult to say how many we'll get, but the model they're working with is understanding of the epilepsy so that we can produce better anti-epileptic drugs. Nothing in the market as yet. So when I reviewed everything, eslicarb to some extent has an anti-epileptogenic effect. I don't know why it's not used so much in pediatrics. Myself, I don't use it. But when I reviewed it, I was surprised how effective it could be. And it doesn't have the side effects of epileptogenesis that carbamazepine and oxcarb has. Vigabatrin works through the mTOR, so that would be a little anti-epileptogenic. Other than that, none that I can think of.
Thanks, Anita. There are a few questions on brivaracetam. One of the questions was about how good is it in relation to levetiracetam, and the second question was in seizure in trauma prophylaxis, whether we use levetiracetam, could we use brivaracetam?
So basically, as I told you, brivaracetam came out overnight by 20 companies. It was there with one company all these years. It came out overnight. It was unbelievable. And while I made the presentation, and IV came out the day I made the presentation, and by now syrup is already in the market. So we now have syrup, IV, and tablet all available 25, 50, 75, 100, every strength you can ask for. So there's something great about, I mean, there's some positivity that comes out of this aspect. I think we don't have enough experience. I'll be honest. I've started using it now that syrup has come and everything, but it'll be some time before we have enough personal experience to be able to tell you whether it works in neurotrauma, neuroprotection. Now that IV is there, yes, you may use it, but honestly, levetiracetam was pretty effective in the acute scenario of status and that. So we would maybe try brivaracetam, but I gather it would be the same benefit, if not a little better. Side effects in status and trauma are not your priorities in the acute stage. So I think with time it has good potential, but it's cutting out its own parent. It's this or that.
Yeah, I agree with that. We've also been using brivaracetam for a few years now, but even though it was touted as levetiracetam's cousin without all the behavior side effects, in my experience, I haven't seen it. They still have the same problems what we see with levetiracetam. There's a question about the DGCI and brivaracetam can only be used above 14 years. The question was, can we use in India in less than 14, under 14 years?
If I'm not mistaken, the last brivaracetam studies, I think, is above 4 years. So I think we can now use it above 4 years, but first comes as an adjunct, as an add-on, and then will be the monotherapy down the line.
And there was a question about availability of vagobatrin. How could we get it regulated so that we don't have to import it anymore?
So I think that's one of the issues that AOCN is working on. The previous committee has tried really hard. We will continue to do it. At the moment, you can source it through this company, which does it for you, or you contact someone from the parent company, which is Sanofi, and they help you try and get it as well. And once the market and COVID is gone, you'll get it in the black market at half the price, even a little way faster.
Yeah, if I may ask one more question, what do you think about how these trials are held, or particularly about the lack of head-to-head trials, comparing the old versus new?
I think, I mean, I'm a little skeptical on this. I think economics, unfortunately, drives so much of our pharmaceutical business. I am not a proponent of it. I'm quite a critic of it. No one is going to do a head-to-head because it doesn't make financial sense to him. Which company is going to do it? He's not going to cut out his carbamazepine market because he wants you to give all of them.
Absolutely.
So it's unlikely that a company is going to do a real solid trial head-to-head on these.
That's true. Thanks, Anita. Fantastic talk. Thank you.
Thank you.
Right, I think it's time for Dr. Suhasini Sharma. So Dr. Suhasini Sharma, again, is someone who doesn't need any introduction. She's a pediatric neurologist, pediatrician at Lady Hardinge Medical College, New Delhi. And she's academically very prolific, and her special interests are in epilepsy. And I know she's been working on dietary therapies for the last 10, 15 years. And she was the recipient of the Sheila Wallace Award from the ICNA last year. Over to Dr. Suhasini Sharma for a talk. Thank you.
A very good afternoon to all of you. This session brings us to the end of the Child NeuroCon 2021. I am very thankful to the organizing committee for giving me this chance. And I'm sure after this absolute academic feast that you all had, you all now must be exhausted. So this is not going to be a very long session. I'll just touch upon the topic of SUDEP, or sudden unexpected death in epilepsy in children. So this is not a much talked about topic, but this is something we need to be aware of because it is being recognized as a problem. So I'll talk about what is the definition, the burden of the problem, pathophysiology, and can we do something to prevent it? And the big question, do we talk about it to the parents or not? So mortality in children with epilepsy is significantly higher than the general population, although most deaths in children with epilepsy are not related to seizures or epilepsy. The higher risk is explained by several factors. It's not just seizures or epilepsy, but they have comorbid conditions such as respiratory illnesses, malnutrition, systemic comorbidities, aspirations. So a lot of indirect fear factors, and as well as deaths presumably or demonstrably due to seizures. And SUDEP, or what is called the sudden unexpected death in epilepsy, has gained prominence as a cause of death in epilepsy in recent years. So what is SUDEP? As a definition, it is defined as a sudden, unexpected, witnessed or unwitnessed, non-traumatic, non-drowning death in a patient with epilepsy, with or without evidence of a seizure, and excluding documented status epilepticus, in which a post-mortem examination does not reveal a toxicological or an anatomical cause of death. So this is a very strict definition, and it requires a post-mortem examination to diagnose SUDEP, which obviously is not available in the majority of instances. So practically, SUDEP is classified as definite, probable, and possible SUDEP. So definite SUDEP is one a postmortem has been done and there is no evidence of a seizure, and a postmortem examination has not revealed the cause of death. It's actually an unexpected death. So probable SUDEP is the same as a definite SUDEP, but without autopsy. The victim should have died unexpectedly while in a reasonable state of health, during normal activities and in benign circumstances, without a known structural cause of death. Possible SUDEP is SUDEP cannot be ruled out, but a competing cause of death is present. If a death is witnessed, a cutoff of death within 1 hour from acute collapse is suggested. So these are the definitions which can be used in verbal autopsy, in population surveys. So we may not get a definitive SUDEP unless it is an autopsy is done, but probable and possible SUDEP are possible, and these are usually used. So the incidence of SUDEP in adults has been calculated to be 1.2 per 1,000 patient years. And in children, it has been reported to vary from 0.22 to 1.17 per 1,000 patient years in various studies, with a higher incidence in children with refractory epilepsy. 27 of the 237 patients with SUDEP were reported to be less than 16 years of age in the North American SUDEP registry. So about 1/3 of people who've had SUDEP have been children. And the very shocking part is that in 7 children, these was in children who had well-controlled epilepsy. So our understanding overall is that SUDEP usually occurs in children with refractory epilepsy, but it can very rarely happen even in children with well-controlled epilepsy. So the risk of developing SUDEP is not limited to patients with frequent or uncontrolled generalized tonic-clonic seizures, as is the usual understanding. So what are the risk factors for SUDEP? So presence of generalized tonic-clonic seizures and very frequent generalized tonic-clonic seizures is a definite risk factor. Nocturnal seizures. So this is again, most of the SUDEP usually occurs in sleep and during nighttime. And in fact, a lot of commonalities have been noticed between SUDEP and SIDS. But what we need to remember is SIDS usually occur in very young infants. So when they sleep prone and they cannot really turn over, whereas SUDEP is in older children, adolescents and adults. So some of the factors seem to be common, the cardiorespiratory issues. There seems to be some commonality between SUDEP and SIDS, but there are a lot of differences as well, and it's not exactly extrapolatable. The relative risk of SUDEP is 7.7 times higher in patients with onset of epilepsy between 0 to 15 years compared to onset after the age of 45 years. So young onset epilepsy going on for a long time with very frequent generalized tonic-clonic seizures, along with developmental delay, which is usually a frequent comorbidity in children with refractory epilepsy. So children with uncontrolled seizures, And SUDEP has been shown to increase with duration and severity of seizures with a 15-fold risk if to children or adults who have more than 50 GTCS per year, nocturnal seizures, and the occurrence of a GTCS as well as a prolonged tonic state, which leads to a post-symptomatic has higher risk of idiopathic epilepsy. Also be noted that patients with Dravet syndrome are also at a high risk of death. So, having understood the risk factors, who are the patients at risk? We need to identify these patients and then see if we can do something to prevent SUDEP. And the last of course, I'll talk about how to talk to families and patients about it. So certain checklists have been developed. There is a SUDEP and seizure safety checklist. There's a SUDEP 7's inventory. There have been work to look for certain genetic markers and certain EG markers. So the SUDEP and seizure safety checklist, this was a case control study of SUDEP versus non-SUDEP, and they identified certain risk factors which had a higher odds ratio for having SUDEP. So this included one of the very high risk factors was prone position, because what happens is many of these patients have been found in prone position. Now what is understood is it's not the sleeping in prone position which causes SUDEP, but usually a person will have a generalized tonic-clonic seizure during sleeping, and there is an ictal turning to the prone position and a prolonged tonic posturing, after which there is apnea and then there is a seizure. So it is an ictal turning to the prone position and not really sleeping in a prone position, which is understood to cause SUDEP. Unclear treatment history, increasing seizure frequency, compliance issues in adults, alcohol problems at therapeutic AD levels, lack of night surveillance, duration of epilepsy more than 15 years, early onset epilepsy, frequent AD changes, intellectual disability. So all these risk factors that we discussed, this checklist has been developed. And another inventory which has been developed is a SUDEP 7 inventory. So this is 7 points, again talking about the same risk factors, more than 3 tonic-clonic seizures, or basically having frequent seizures, duration of epilepsy more than 30 years, which is more for, of course, for adult mental delay or intellectual disability. So basically, these authors used a surrogate risk marker for SUDEP, which was the heart rate variability. So they have studied heart rate variability, and they found that the SUDEP 7 score was inversely and significantly associated with heart rate variability. So these are certain surrogate markers in the genetic aspects. This was an exome-based analysis of cardiac arrhythmia, respiratory control, and epilepsy genes in SUDEP. So what the authors did was exome sequencing of 61 SUDEP cases, and they looked for all these genes: epilepsy genes, cardiac arrhythmia genes, and respiratory control genes. They found that 4 patients had a long QT syndrome. So there can be overlaps with cardiac arrhythmia genes also. 15% had candidate pathogenic variants in dominant cardiac arrhythmia genes. The significant genes which were related, which achieved some significance, was DEPDC5 and KCNH2. Another useful marker EG-wise is something called post-ictal generalized EG suppression, which has been seen to be associated with SUDEP. So this is usually seen after a generalized tonic-clonic seizure. It's basically a generalized complete suppression which is seen after a generalized tonic-clonic seizure. What has been noted is that in the Mortimer study and study of SUDEP in epilepsy monitoring units, that the post-ictal generalized seizures, more than 15, the suppression occurring for more than 50 seconds has led to increased risk of SUDEP. And in a pediatric study, it was noted that children with this marker, post-ictal generalized EG suppression, had higher SUDEP 7 scores compared to children without this PGES. So increased risk of post-ictal generalized EG suppression in children has been seen in sleep. So like I said, most SUDEP occurs in sleep. Shorter duration of the clonic phase, a symmetric tonic extension posturing, and a terminal burst suppression after the seizures. So all these risk factors have been noted for children who had post-ictal generalized EG suppression. So what is the pathophysiology? What is thought is that there is a brainstem dysfunction and a cardiorespiratory dysfunction. So there's a spread of the seizure activity to the amygdala, which leads to a midbrain or medullary inhibition, which leads to apnea and respiratory dysfunction. which is precipitated by prone positioning, intrinsic pulmonary issues, sleep apnea, which some of these patients may have, and the medullary pathology also leads to loss of arousal mechanisms, which leads to hypoxia, even cardiac dysfunction, autonomic dysfunction, and all these mechanisms of autonomic, cardiac, respiratory, ultimately, and loss of arousal leads to SUDEP. So basically, again, this diagrams also show the same thing, that there is a spread of the seizure discharge to the brain amygdala, then brainstem, and endogenous mechanisms involved in seizure termination are not functioning very well. Ultimately, there's going to be ictal compromise and hypoxemia. So peri-ictal prone position is, or post-ictal prone position is a definite risk factor. No supervision is a risk factor, impending of ascending arousal projections, ultimately leading to a combination of central and obstructive apnea and cardiac dysfunction. So can we prevent it in some ways? So some of the ways seem preventable. One is that, of course, we need to, the refractory epilepsy is one big risk factor. So we need to make it, reduce the refractoriness of the epilepsy by reducing the occurrence of DTCS by timely referral for pre-surgical evaluation, advice on anti-epileptic drug compliance. Even ketogenic diet, of course, is a useful entity, not only for refractory epilepsy, but there is experimental evidence in KCN2 null mice that SUDEP, the ketogenic diet can also somehow prevent SUDEP as well. Enhancing the ability to detect cardiorespiratory distress through clinical observation and seizure, respiratory and heart rate monitoring devices. Preventing airway obstruction through nocturnal supervision and safety pillows. Reducing central hypoventilation through physical stimulation and enhancing serotonergic mechanisms of respiratory regulation. So SSRIs, selective serotonin reuptake inhibitors, may have some role. And adenosine also plays a role. So reducing the adenosine and endogenous opioid-induced brain and brainstem depression can also play a role. So we'll talk a little bit about all these ways in which we can potentially prevent SUDEP. So, but before doing that, one has to understand that there's really not much evidence for any of these modalities, because SUDEP itself is a very rare outcome. So to demonstrate a 6-month duration of an intervention which reduces the incidence of SUDEP by 50%, will require a sample size of 12,000 patients. So there are major feasibility issues with doing any trial to prevent SUDEP. So alternatives that are used are surrogate endpoints like emergency room attendance, injuries, post-seizure apneas, heart rate variability, and population-based interventions in well-defined communities which have pre-existing validated SUDEP registries. So one of the most important ways to prevent SUDEP is effective epilepsy treatment. So appropriate anti-epileptic or anti-seizure medication treatment, timely pre-surgical referral, surgery in surgical candidates. So it is an effective seizure treatment, but whether surgery itself is preventive for SUDEP is not known. But what is known is that failed surgical candidates are actually at a higher risk for SUDEP. And patient education is very important. Education on drug compliance, lifestyle measures, avoiding sleep deprivation, stress and excessive alcohol, and care plans for seizure clusters, home management of seizures, GI illnesses, advice regarding contraceptive pills in pregnancy for adolescents. So we all, this test, as I talked about, is mostly the nocturnal seizure ending up in a post-ictal generalized suppression and post-ictal prone turning, which is leading to the seizure. So can a seizure detection device help? So seizure detection devices, of course, have been shown to be effective in detecting the generalized tonic-clonic seizure. However, they may be marketed in such a way as to suggest a preventive effect against SUDEP, but there is no evidence for this. And a lot of extensive clinical investigation is needed, whether seizure detecting devices actually help to prevent SUDEP. So one modality which has been found to be protective is nocturnal supervision. It was found to be protective in one case control study. And combined with seizure detecting devices, it may enable more effective seizure detection, but evidence to prevent SUDEP actually is lacking. So there are, of course, quality of life issues which does not really matter in children, especially in a cultural milieu like India, because co-sleeping is really very common. And in fact, a child sleeping alone would be a rarity and not a common occurrence. So this is possibly the norm in India. So nocturnal supervision, we don't actually have to advise, it's usually always there. So what the person sleeping with a child may help is in turning the patient from prone to recovery position. This may reverse the respiratory compromise, but more effective resuscitation, maybe stimulation definitely may be needed. So coming again to the prone position, What has been seen is that 70% of were found in position, association between prone position and especially in patients younger than 40 years of age. Like I said, it's likely due to an ictal turning to prone position associated with impaired arousal mechanisms. So of course, we do maybe a doubtful benefit because it is usually during the seizure that they turn. So turning the patient from prone to a lateral recovery position and stimulating the patient may help. So at least this should be told to the parents that if you find the child having a seizure and becoming prone after the seizure, please turn the child to a recovery position and stimulate the child. There's also some thoughts about safety pillows, because these may reduce the contribution of prone position to post-ictal cardiorespiratory distress and patient can breathe through them. There are no studies available to document the efficacy of these. Sadly, even in epilepsy monitoring units where the patient is in a very supposedly in a very safe environment with all monitoring going on, there have been deaths. So this is definitely a thing we must prevent at all costs. So patients should be having a systematic monitoring of ECG and SpO2 with appropriate alarms, organization of emergency codes, and the epilepsy monitoring unit staff should be trained to quickly identify ictal and post-ictal cardiorespiratory distress and start CPR. Post-ictal oxygen therapy is also is important because evidence from a mouse model of SUDEP that this may be helpful. Certain drugs, there's some work going on the drugs. Basically, one is the SSRIs, the selective serotonin reuptake inhibitors. How they work is what is presumed is that serotonin neurons in the raphe nuclei of the brainstem sense rising carbon dioxide and low pH. Thereby, they stimulate breathing and arousals. So abnormalities of the serotonergic neurons in the brainstem has been reported in SIDS and also in the mouse model of SUDEP. So what is postulated is that SSRIs may decrease the risk of potential apnea, and fluoxetine has been shown to prevent the occurrence of fatal apnea in mouse models. There's one retrospective study. It was seen that patients with epilepsy who were receiving an SSRI for a comorbid anxiety or depression or some other problem, those patients who were receiving SSRIs, their post-ictal hypoxemia was significantly less frequent than in those who were not. So there are 2 RCTs in progress to document this, but results are not yet available. So another mechanism is the opioid and the adenosine receptors. So what is postulated is that the post-ictal apnea could partly derive from a seizure-induced massive release of endogenous opioids and adenosine. Animal studies suggest that such seizure-related release of endogenous opioid peptides will help to terminate seizures, but it may also lead to apnea. So in patients with epilepsy, functional imaging studies have confirmed that seizures induce release of endogenous opioids, and naloxone, which is an opioid antagonist, may potentially reduce the occurrence of post-ictal apnea, and an epilepsy trial, which is the RCT, is in progress for post-ictal naloxone. And the adenosine antagonist, caffeine is an adenosine antagonist. It may help, but it is a proconvulsant, so it's not clinically very useful in this situation. So the Cochrane review suggested that there was a very low quality evidence for preventative effect for nocturnal supervision against SUDEP, and further research is required to identify the effectiveness of current interventions. For example, seizure detection devices, safety pillows, SSRIs, early surgical evaluation, educational programs, opiate and adenosine antagonists in preventing SUDEP in people with epilepsy. So in future, we may have ambulatory SUDEP prevention devices. They may be pacing, cardiac or respiratory, they may be phrenic nerve stimulation. But as of now, these are just work going on, and this may be the future that we can actually prevent a SUDEP happening. Now coming to the last part of the presentation, parental counseling and disclosure. So when we as doctors talk to parents about epilepsy, we try and tell them that the child can lead a normal life as far as possible, and we generally try to make them comfortable with the diagnosis and not to increase their anxiety. So the thought that if we tell them that your child may die, doctors often worry that this will really increase the parental anxiety and stress, and they may really make the child's very overprotective about the child. So many physicians feel that imparting knowledge about SUDEP may increase the parental anxiety and stress levels, especially considering the complication is quite rare. With the run-of-the-mill epilepsy, why tell the parents? However, it is also known that many parents are worried that their child would die when they witness the child having a seizure for the first time. So this worry is already there in their mind. They may not bring it out, but it is there in their mind. And the information that we tell them that this actual risk is very low may actually, in fact, be very reassuring. So disclosure of SUDEP risk to all people with epilepsy has been endorsed by multiple neurological societies, including a joint task force of the AAN and the American Epilepsy Society. And in India, the joint consensus document on parental counseling by Association of Child Neurology and Indian Epilepsy Society has also encouraged a gentle mention of SUDEP during the parental counseling process. So is there any evidence of this? In a study from Canada, parents generally expressed a preference for receiving routine SUDEP counseling at the time of diagnosis of epilepsy. And in a study from Malaysia, wherein 32% of the participants were of Indian origin, 70% of the parents felt that receiving SUDEP information was positive and it did not really impact their own functioning. In a UK study, 74% of pediatric neurologists conveyed the SUDEP information only to a select group of patients only whom they thought were at high risk. However, in contrast, 94% of the parents expected the physician to talk to them about SUDEP. And the preventive strategies can be discussed during the counseling, which gives them a sense of control over this. So we did a study in the Indian setting. There was no pediatric data available. And this is a study which we've done in the last 1.5 years. This was a single group pre and post intervention study, wherein the patients were given a SUDEP counseling. This was actually children who've been followed up at least for 3 months so that they were comfortable with the epilepsy diagnosis. This is not at the time of the first visit. So after 3 months of the diagnosis, at least they were enrolled in the study and they received the disclosure and the means to prevent it and everything, all the counseling regarding SUDEP at baseline. And there was a questionnaire assessing their childcare behavior practices in relation to epilepsy. And this DAS-21 score is a score to assess the parents' depression, anxiety, and stress score at baseline and at 1 month follow-up. So we included parents with at least a minimal education level of class 5. So out of 120 children enrolled, nocturnal seizures were present in 30% of the children, and only 5 parents had a prior knowledge of SUDEP. So what we found after 1 month of SUDEP counseling on epilepsy-related childcare practices was that there was definitely better compliance with anti-epileptic drug with fixed timings and less missed doses. Parents had stressed on better lifestyle practices like adequate sleep and exercise. And many of them, they did not have a seizure action plan in place, but they made a seizure action plan. They found out which is the hospital nearest to them, and they had the rescue medications at home, which was not there at baseline. And this was also a significantly increased that they were providing information about epilepsy to family members in school with provision of emergency contact numbers as well. And fortunately, there was no effect on parental depression, anxiety, and stress levels. So when we took their feedback on the disclosure and counseling, 95% or 96% of parents said that yes, it should be told to them. And the timing when they said is, like they said, when they were comfortable with the diagnosis. They did not want it at the first visit. They were grappling with too many things at that time. When they're a little comfortable, it's usually on the 3rd or 4th visit that this topic can be broached, and it needs time. Written information in the leaflet is not the best way to do it. So we did a combination of a short video which they were given, a leaflet, and after that a face-to-face session to address all their queries and doubts. So to summarize, SUDEP is a rare but important complication of epilepsy. And what as physicians we need to do is to identify patients at risk, patients with generalized tonic-clonic seizures, nocturnal seizures, uncontrolled epilepsy, comorbid developmental delay, and intellectual disability. And ictal EEG in these patients may help us to look for the post-ictal generalized EEG suppression, which is an important biomarker for SUDEP. Regarding discussion with families, disclosure is recommended with the low risk explained and strategies to prevent SUDEP explained. But this disclosure should not be at the first visit. It should not be just a leaflet or the space. It has to be done when the family is comfortable with the diagnosis, and even after the educational material, a face-to-face discussion to resolve their doubts and worries is definitely needed. So early surgical referral for refractory epilepsy children, appropriate anti-epileptic drug therapy stressing on compliance, lifestyle factors, of course, avoiding sleep deprivation, stress, alcohol, anti-epileptic drug advice during intercurrent illnesses, concurrent drug and OCP intake. So to prevent SUDEP, we should train caregivers in home management of seizures, and nocturnal supervision in our scenario is definitely culturally acceptable. We advise back to sleep safety. But of course, not just back to sleep, but if the child turns prone during the seizure, the child should be made put in recovery position and stimulated. Safety pillows may help. Intranasal midazolam, turning prone to recovery position, stimulating the patient, and even a BLS training life support can be given to willing caregivers of high-risk patients. So seizure monitoring devices may be discussed with an emphasis that we don't have evidence that they actually prevent seizures. SUDEP. So with that, I'll end my session and thank you very much for a patient hearing. Thank you.
Thank you, Dr. Suhasini. Excellent talk on a topic which still remains very controversial. As you know, even in the UK, even the both the NICE guidelines and the Scottish guidelines say that you have to approach it in a uniform way. Still, individually, colleagues and everyone differ on whether to address the issue with parents or not. Yeah. So there are a couple of questions. There was one question which I thought was interesting. What about the risk of SUDEP in insular low-grade gliomas?
Yeah, I also saw the question, but I don't have any, I couldn't find any literature on this. I've been checking even now. I couldn't find any specific literature on this aspect of
Yeah, because refractory epilepsy is associated, isn't it? So
yes,
yeah,
it is.
it's a good
So
question.
specifically with insular gliomas, I could not find any particular association. Yes. See?
And there are also questions about childhood epilepsy with centrotemporal spikes and CSWS and ESIS, and whether SUDEP is an issue there.
Yes. I'll take that. Basically, there have 3 children have been reported. Then the North American SUDEP registry, out of 187 patients, they found that 3 with SUDEP, 3 of them had 187 patients with Rolandic epilepsy, 3 had SUDEP, and out of these 3, 1 of them had only infrequent seizures, but 2 of them had difficult to control seizures, more than 30 seizures, and 1 had very frequent generalized tonic-clonic seizures. So yes, it is still our practice that with few seizures in Becks, we don't normally recommend, and we discuss it with parents. In India, of course, even with 1-2 seizures, most pediatric neurologists would tend to start the anti-seizure medications in children with Becks. The anxiety is usually quite high in parents here. But if the parents choose not to start, but this just has to be explained that if there are very frequent seizures, or the child has frequent generalized tonic-clonic seizures, then there is a rare definitely risk of SUDEP, which needs to be explained. And we have said that it does. Ideally, SUDEP should be explained to all parents of all children with epilepsy, except perhaps ones with pure absence seizures, typical absence. They are the ones who haven't been reported to have SUDEP. But Becks, definitely it's rare, and treatment should be discussed with the parents that if they have frequent generalized tonic-clonic and frequent seizures, especially nocturnal seizures, it is definitely better to start them on anti-seizure medication.
Is there any national guidance or advice on these seizure alarms, etc.? Or somebody was asking about what would be your recommendation?
Yes, they were asking. So basically, seizure alarms are definitely available in the market, and so people, they may be marketed in this, in the way that this may help to prevent SUDEP, but there is actually no evidence at all. They definitely, and there can be false positives even detecting seizures. So they can actually increase a lot of anxiety, and so we don't have an answer whether they prevent SUDEP or not. In fact, in the Cochrane review that I mentioned, the authors had approached many of these seizure alarm manufacturing companies and asked them to do they have any post-marketing surveillance data on whether it has reduced SUDEP or what is the prevalence of incidence of SUDEP in people who are using, but they did not get any answers. So we have to, if the parents choose to use a seizure detection device, we have to tell them that there is no evidence that it has been known to prevent SUDEP. Yes, they may be able to pick up seizures in time and treat, and as a corollary, they may prevent SUDEP, but as of now, we don't know the answer to that.
I think Rajesh had a question. I don't know whether you've seen it.
I have to see it.
That was the last one.
Okay. ECG routine epilepsy. Yes. I think it's a good, easily doable thing. Is written that whether we should do ECG in all patients with epilepsy. So at least I think in the ones with high risk, it's definitely worth doing if they have all the risk factors that I mentioned, that frequent generalized tonic-clonic seizures, refractory epilepsy, comorbid intellectual disability, developmental delay, maybe a family history of heart disease. It's worth doing, and even as of now, there is no recommendation for doing an ECG in all children with epilepsy. But if they seem to be at risk, then it may be a good idea to do it, because some of the genes were actually cardiac arrhythmia genes. Yes, and those are preventable causes of SUDEP.
That's true. I mean, it's always routinely done now with the ECG. So yeah. Good. Thanks very much, Dr. Suhasini. Thank you. Thank you.
Thank you. Thank you, Dr. Biju.
Thank you.
Rajagopal sir, any comments on this topic? Dr. Rajagopal, am I audible? Any comments, sir? Final session of the day. This session is a much awaited talk on cerebral palsy by Dr. Biju Hamid, which was postponed on day 1. The topic is management of dyskinetic and dystonic CP. Chairing the session are Dr. Riaz, Associate Professor and Consultant Endocrinologist, Government Medical College, Trivandrum. He is also the Executive Board Member of Central IAP, and Dr. Kalpana D, Senior Consultant and Pediatric Neurologist, KIMS Trivandrum. She is also the former Additional Professor of Pediatric Neurology, Government Medical College, Trivandrum, Kerala. She has publications on national and international journals and is a reviewer of various Indian journals. She is a certified Indian faculty of the PET program by the BPNA. She was the president of IAP Neurology Chapter 2018-20. Her areas of interest are neuromuscular disorders, pediatric epilepsy, and neurodevelopmental disorders. Over to you, ma'am. Over to Dr. Riaz.
Hello, welcome everybody to the much awaited session by Dr. Biju Hamid. Actually, we were all expecting him to join us 2 days prior to this, but he was not able to join because of his clinical responsibilities. And I'm very happy and proud to present before you Dr. Biju Hamid, who is actually the man behind this conference, who coordinated everything about the conference, working in unison with our Mini Madam and Bennett sir, and inviting all the guests and finalizing the scientific program. He's an expert in complex movement disorders, management of dystonia, and has several years of expertise in management of children suffering from cognitive, neurological, and psychological sequelae. And he is the editor of the Journal of ICNA, and he's a good friend of all of us here. And actually, we miss him here. We all thought that he will be here with us organizing this conference. Because of COVID, he could not. So over to you, Dr. Biju Hamid, for a talk on management of dystonic CP. Over to you, sir.
Thank you. Shall I share my screen? Thanks very much, Dr. Riaz, for that kind invitation and introduction. So I'll try and make this very short, because I know you're all probably exhausted, as Dr. Suhasini said, from 2.5 days of intense academics. So the idea for this talk is to give an overview of a type of cerebral palsy, the dyskinetic cerebral palsy, and to introduce the concept of spastic dystonia, and to see to discuss what evidence is out there for the pharmacological and neurosurgical interventions in this type. So we have to start with cerebral palsy definition. And to borrow Michael Chevel's from McGill's words, you have to know cerebral palsy. If you know cerebral palsy, then you know all of pediatric neurology. And even now, there is a huge controversy on what is the ideal definition of cerebral palsy. Perhaps the one which is most accepted is the one from 2007 by Rosenbaum, that cerebral palsy describes a group of permanent disorder of development of movement and posture, which causes activity limitation, which are attributed to non-progressive disturbances that occurred in the developing fetal or infant brain. We are all quite familiar with this definition. But it's also important to note that these motor disorders are not on its own. They are often accompanied by disturbances of sensation, perception, cognition, communication, and behavior, by epilepsy, and by secondary musculoskeletal problems. So 2 to 3 per 1,000 live births in high-income countries. And when it comes to classifying cerebral palsy, there are different ways. You can talk about the topographical classification into unilateral, bilateral. You can talk about the motor deficit in terms of spastic, dyskinetic, ataxic, but that doesn't really tell you about the functional classification, about the function or the activity or the participation or how severely the child is affected. So we need functional classifications as well. So, but there is this concept of a type of cerebral palsy, the dyskinetic cerebral palsy, which has been said to be the one associated with abnormal postures or movements associated with either dystonia or chorioathetosis. And by dystonia, what do you mean? It is abnormal posture, involuntary twisting and repetitive movements due to sustained or intermittent muscle contraction. While chorioathetosis, on the other hand, is characterized by hyperkinetic movements and fluctuating muscle tone. Chorea would be rapid, involuntary, jerky, often fragmented movements, while athetosis is more writhing, uncontrolled movements or contorting movements. So the surveillance of cerebral palsy in Europe have suggested this classification dichotomy, depending on the topography into bilateral, unilateral, into the motor characteristics, into dyskinetic, dystonic, which is dystonic and chorioathetotic, or ataxic. And of course, we have the functional classification system. So along with the functional classification system, the topographical and the motor type classification, you constitute the international language to describe children with cerebral palsy. So when someone tells you that he's a GMFCS5 or GMFCS4, you have a mental picture in you. But what about dyskinetic CP? And if you look at the descriptive studies of cerebral palsy, the majority of children are said to be spastic, or spasticity seems to be the major thing. And most studies talk about anywhere from 10 to 15% of the cerebral palsy children being dyskinetic cerebral palsy. Now, if you look at the population-based data, so if you look at the surveillance of cerebral palsy in Europe data, they report a rate of 14.4, but similar reports from Sweden. But in Australia, the cohort, the surveys suggest that the incidence of dyskinetic CP is 5.9. Now, therein lies the problem. The problem is in identifying dyskinetic cerebral palsy and how you predominant motor types are designated. When do you designate something as a dystonic CP or a dyskinetic CP? Therein lies the problem. So there is a huge inconsistency in the identification and the reporting. And it is quite important that we do that because the prognosis is different in these children. And in fact, the impact on the function is also hugely different when you compare it with spasticity. For example, so that would be, this would be a typical dyskinetic or dystonic cerebral palsy, where there is uncontrolled writhing movements. In that video, you can see the asymmetric tonic neck reflex. In the sitting posture, the child is having difficulty trying to reach out to an object. And again, here, when you are trying to perform an action, you see the uncontrolled writhing movements, which are the chorioathetoid movements. So this is not spasticity. This is dyskinetic CP with predominantly chorioathetoid movements. And here it demonstrates the dystonic movements. So the classic thinking was, of course, if it is a dyskinetic CP and if you have dystonia, then surely the basal ganglia and the striatum has to be involved. And you could say that depending on the level of involvement, you could have three situations where you could have mild involvement of the basal ganglia and the thalamus, where it would be dyskinetic cerebral palsy, or you could have moderate involvement of the basal ganglia and also the cortical and the subcortical structures, where it would be spastic cerebral palsy with a dyskinetic element. Or you could have a situation where it is the basal ganglia and the thalamus are quite severely involved along with the cortical and subcortical lesions. Then you would argue that this is predominantly spasticity rather than dystonia. So the traditional thinking used to be, depending on the severity of involvement of the basal ganglia, you could argue that this child might be expected to be more dystonic than spastic or more spastic than dystonic. But in actual fact, we don't see that, because in actual fact, what we see is the involvement of the basal ganglia on neuroimaging does not correlate with what you actually see in the child. So the pathophysiology is evident because we all know about how the basal ganglia circuits work. And we think that this is a problem between the direct and the indirect pathways of the basal ganglia. We know the direct pathway is excitatory, works from the striatum to the globus pallidus interna to the thalamus, while the indirect pathway is inhibitory, working via the globus pallidus externa to the subthalamic nucleus and to back to the thalamus. So the direct pathway is excitatory and the indirect pathway inhibits unwanted movements. And when there is an imbalance between the direct and the indirect pathways, then you have co-contraction and you have uncontrolled movements. There is no breaking of the involuntary movements. That used to be the pathophysiology. So the loss of inhibition, and of course, there is always a somatosensory feedback as well, and the impaired basal ganglia plasticity, sorry about the typo, which causes the dystonia or the dyskinesia. So athetosis, let's have a look at the athetosis. So athetosis is described as a slow, continuous, involuntary writhing movements, which prevents maintenance of a stable posture. So the boy in this video knows that what he has to do, he has to put the blocks in the box, but he is unable to do that because of the writhing, uncontrollable movements. And as you can see, there is also a lot of overflow of movements. When he tries to do something, there is overflow into his head and neck muscles. So this would be a classic athetoid or chorioathetoid cerebral palsy. In case of this little girl, she, again, these are all ex-prems, 28, 32 weekers who have now survived and then have got a diagnosis of cerebral palsy. So here, there is involuntary alteration in the muscle activation patterns. When trying to perform a voluntary movement, trying to take something from the tray, she is unable to coordinate the movements. So this is dystonia, a typically patterned, twisting, tremulous movements. And the tremor in this case can be quite confusing to diagnose. And it's often initiated or worsened by voluntary action, and there is overflow muscle activation. So this is a typical dystonic cerebral palsy. This child hasn't got any primary dystonia. This is a cerebral palsy, ex preterm, but has predominantly dystonia. Now, in this, I think I got the video wrong. Sorry. Okay. Now let's look at. So we now know that there is a type called dyskinetic cerebral palsy, where the basal ganglia is involved. You could have athetosis or you could have dystonia. But what about in this case? So this is a boy who is an ex-prem of 28 weeks, and his MRI scan shows typical hallmarks of periventricular white matter signal changes in the parietal regions. There is mild reduction of the white matter volume. The thalami are small in volume. But he is a GMFCS5. But what you see here is there is also the dystonic movements that we have been talking about. But the MRI doesn't show. The MRI shows a normal basal ganglia, but you don't see this in this boy. You see a dystonic pattern, the same dystonia which we've been describing in the last few slides. So that brings us to the question of what is a mixed cerebral palsy or dystonia which is associated with spasticity. And therein lies the other major problem, because the way spasticity has been defined, as we all have learned in our medical school days, is about the velocity-dependent stretch response of a muscle, which is manifested as a catch when you try to move the muscle quickly. So the implicit assumption is that the catch is caused by hyperactive stretch reflexes. And that used to be the standing definition for spasticity, that hyperactive stretch reflexes is the central component. However, research in the last 20, 30 years have documented that hyperactive stretch reflexes do not cause functional problems and do not show a clear relationship to the main clinical problems experienced by patients and clinicians. Even the scissoring posture, which we saw beautifully in Professor Kunju's slides earlier, the equinovarus foot posturing, the toe walking, they are not dependent on an increase in velocity-dependent stretch reflexes. And they are all abolished by sleep. And what does sleep do? Sleep switches off the co-contraction of the muscles. And we know that the degree of spasticity in the lower extremities do not really correlate well with aspects of gait function. So what is the problem? You explain spasticity, but the spasticity doesn't seem to explain the difficulties with the scissoring posture or the equinovarus foot posturing or the toe walking. And that brings us to the issue of spastic dystonia. And this is not a new concept. In fact, Denny Brown, who used to be at Queen Square, but then moved to Boston, and he and colleague reported in 1966 an observation in studies on non-human primates who had lesions to the motor cortex. So what Denny Brown observed was sustained muscle activity in monkeys with lesions restricted to motor cortex. But what's interesting was, even when the dorsal roots were severed in the spinal cord, the involuntary muscle activity persisted. So there was a cortical lesion, there was involuntary muscle activity, but even when the spinal input was interrupted, still the muscle activity persisted. So that clearly suggests that this must be a central mechanism. So spasticity could be enhanced excitability of velocity-dependent responses to a phasic stretch at rest. But spastic dystonia is a tonic, chronic, involuntary muscle contraction in the absence of any stretch or any voluntary command. And that's what we see in actual clinical practice. In actual clinical practice, whenever you see these children with spasticity, children who had cortical lesions, who had upper motor neuron lesions, they also have involuntary muscle contraction, which is unrelated to the hyperactive stretch reflex. And there are several proposed mechanisms for it. It could still be changes in the plasticity of the basal ganglia, because we know like basal ganglia doesn't work on its own. It's all part of a huge network. if the spinal cord column, if the pyramidal tract is interrupted, then you might, there might be other aberrant networks involving the pathways in the brainstem, for example. So all this might be the reason for this. The exact mechanism we still don't know. So it's always been very difficult to tease out like which is spasticity and which is dystonia. But the hypertonia assessment tool from colleagues in Ontario, which they published in 2010, is a very, very useful tool which can be utilized to reliably differentiate between the pediatric hypertonia subtypes. It's a very simple tool, a 7-item clinical assessment, which you can use to differentiate dystonia, spasticity, and rigidity. A videotape review is not necessary, and it has been shown to have good clinical utility. So that is a useful tool to differentiate between the three dystonia, spasticity, and rigidity. And of course, you have the various dystonia rating scales as well. But not all scales actually address the dystonia and particularly chorioathetosis. The dyskinesia impairment scale is one which does address both dystonia and chorioathetosis and discriminate between the proximal and distal aspects of dystonia. There are also kinematic dystonia measures where you can capture the joint position, usually videography, and then using computer imaging and computer analysis, you can find out whether it is high spasticity, low dystonia, or low spasticity, high dystonia, or high spasticity, high dystonia. So those are all useful measures. But the focus has always been on, of course, we have to manage the spasticity. Of course, we have to manage the dyskinesia. But we now know, and from around the last millennium, we know that that is the wrong approach. The approach should always be focused on the international classification of functioning, disability, and health. And the focus should not be on just the alleviation of spasticity and dyskinesis. So that has changed, and people have now routinely started using outcome measures. A good one, for example, is the Canadian Occupational Performance Measure, a 10-point scale on how well an activity is being performed, and additionally, how satisfied the patient or the caregiver is with that performance. There are also other scales. It doesn't matter which scale you use as long as the practitioner is comfortable with it. But the goal is, the focus should not be on the alleviation of the spasticity or the dyskinesia, but on the overall functioning, disability, and health. And because we know that just by reducing the dystonia does not necessarily translate to enhanced function or participation. And in fact, when you compare dystonia and chorioathetosis, the dystonia actually has a greater negative impact, although you might intuitively think that chorioathetosis has got the maximum impact on function, but often it is the dystonia which has got the maximum negative impact. So the effectiveness of interventions should be judged using meaningful outcome measures, which actually reflect our goals and expectations of the individual patients. So there are several different goals which we can use in dyskinetic cerebral palsy. But what about the pharmacological and other interventions for these children? And therein lies the problem again, because we all are after evidence-based medicine. And unfortunately, when it comes to this, there isn't any evidence. Of course, we have lots of drugs. We have baclofen, gabapentin, clonidine, anticholinergic drugs, the anti-dopaminergic drugs, and levodopa. And what is the evidence? There isn't any evidence. In 2018, this systematic review came out from Darcy Fellings, and they couldn't find any study on baclofen, any study on diazepam, any study on clonidine or gabapentin. And when they looked at the other medications like trihexyphenidyl, there was ineffective for dystonia, possibly ineffective for motor function, inadequate data for pain, possibly ineffective for care. Botulinum toxin, inadequate data, inadequate data, inadequate data. ITB, possibly effective for dystonia, inadequate motor function. So even in 2018, systematic reviews did not give us the evidence of what to use and when to use. So the group then, what they did was they just updated the systematic review again, and it was published just a couple of weeks ago, where they tried to introduce more studies and see whether there was any evidence. And the answer is there is still no evidence. There is still no evidence for trihexyphenidyl in dystonia, in goal achievement, in motor function, in ease of caregiving, in quality of life. No. Where there is some benefit is in clonidine, for example. There was one single uncontrolled retrospective case series, which was from Guys and St. Thomas's, from Evelina, from JP Lin and colleagues. And this was a very single uncontrolled retrospective case series, which was done at Evelina. And the reporting was on subjective carer-reported impressions. And they studied 24 children. And in fact, only 14 of them were actually cerebral palsy, had a diagnosis of cerebral palsy. And they said, okay, clonidine might improve dystonia, achievement of individualized goals, pain, etc. And the JP Lin's group at Evelina are quite in favor of clonidine. And the same way, we at Great Ormond Street are also in favor of clonidine for dystonia. But the important point is, there isn't any hard evidence out there. The one study which the systematic review has pointed out is this particular study, but this is a single uncontrolled retrospective case series. But we all use clonidine because we know that when it comes to trihexyphenidyl versus clonidine versus gabapentin, clonidine seems to be the preferable option along with gabapentin. Gabapentin, there was no studies for gabapentin at all in the systematic review. But again, individual practice, we all use gabapentin, and we use quite high doses of it, much higher doses than what you would normally use for pain, for neuropathic pain. When it comes to anti-dopaminergic drugs, tetrabenazine is not used. There is no evidence that it works, but anecdotally, and in our practice as well, because it has got a very short half-life for about 16 to 24 hours, and it is a reversible depleter of monoamines, it might be useful in the intensive care settings when children who've had a surgery and who are recovering, etc., when there is dystonic storms and chorioathetosis. Baclofen, again, with oral baclofen, there isn't any evidence. In fact, there are no studies. Benzodiazepines, no studies. And this was the only one study with tetrabenazine, an Italian group who looked at 23 children with dyskinetic CP treated with tetrabenazine and found a significant clinical improvement. And that was the only study. Anticholinergic drugs, of course, we tend to use it because trihexyphenidyl block the action of acetylcholine, but the side effects are quite intense, particularly the hallucination, the confusion, the drowsiness, the dry mouth, blurred vision, the affection of sleep, urinary retention, etc. Levodopa, it has not shown to be effective. We know it is effective in dopa-responsive dystonia, and I agree it is good practice to have them on levodopa when in doubt, because it's very important to not to miss a treatable condition. But when it comes to dyskinetic cerebral palsy, when it comes to dystonia associated with cerebral palsy, we still sometimes use it, but there is no evidence. There is one randomized control trial from Hila Ben-Passi's group from Israel, who said that levodopa may result in little to no difference in motor function compared with individuals receiving levodopa. So there goes again, no evidence for that either. Now, Botox, there is one randomized crossover trial and 4 non-randomized studies looking at Botox, which has shown improved achievement of individualized goals, ease of caregiving, but no result or difference in quality of life compared with children not receiving Botox. So Botox, when it compared to the baclofen, compared to gabapentin, compared to clonidine and the others, Botox, at least there is a little more evidence when it comes to Botox. But the important thing is the evidence that we have is for short term. There is no long-term evidence, no long-term RCTs, no evidence of long-term positive changes. Baclofen, we know, works at the postsynaptic GABA receptor. It is useful for spasticity as a muscle relaxant. But again, the problem is the narrow therapeutic window for adverse effects and sedation, the loss of truncal tone. And of course, we all know that it is very difficult to cross the blood-brain barrier. But then we can surmount that by using intrathecal baclofen, where it will provide 1,000 times the CSF concentration. But again, there is adverse effects still is the major problem, particularly with infection and CSF leaks. And the adverse effects tend to be slightly, the children with dystonic cerebral palsies tend to be slightly at higher risk, particularly most likely because of the movements and which can cause then CSF leaks, etc. So in the systematic review, the intrathecal baclofen, they showed that it might reduce the pain, but to be honest, they didn't find any result in little or no difference to the motor function. They feel it may improve achievement of individualized goals, but again, there is no long-term evidence. Deep brain stimulation. So deep brain stimulation, as you know, implantation of electrodes into specific areas of the brain, usually the globus pallidus or subthalamic nucleus, and then it's attached to a neurostimulator. There is anecdotal evidence that it will result in improvements in dystonia, goal achievement, motor function, pain, and quality of life, but limited evidence and only a small number of studies. In the systematic review, which was published 2 weeks ago, they found very low certainty. It may improve dystonia, may improve motor function, may improve pain, may improve quality of life, but has got an increased risk of adverse events. So the problem is, of all the things that we have in our armamentarium, like the pharmacology, the medications, and the neurosurgical interventions, it seems the neurosurgical interventions seem to have a slight edge in terms of what might be effective in dystonia. And one particular thing about the deep brain stimulation is, we know that we are dealing with secondary dystonias in these children. And when JP Lin and team and Evelina looked at the 294 children who had, who were there in their cohort who had primary and secondary dystonia, they found that the secondary dystonia children fared badly. But we all know that the DBS works fantastically well for primary dystonias, but secondary dystonias probably not that much. But there might be other reasons for it, because secondary dystonia presents quite late, and secondary dystonias, these children have never had a chance to have a normal motor development because they had the problem right from day one. While, as we know, primary dystonias often have a period of normal development before they develop their issues. So that might be the reason. So to summarize what we have discussed so far, there is no evidence for any pharmacological intervention. There seems to be some evidence for Botox, for intrathecal baclofen, and for deep brain stimulation, but there is no long-term studies, and there is no evidence for oral baclofen, benzodiazepines, gabapentin, or medical cannabis also, which was also looked in the last review. So what we really need is studies with larger sample size. And it's surprising that, given that the topic is cerebral palsy, and still we are nowhere near a proper evidence base for this. And perhaps it's because, our focus has always been on managing the spasticity, managing the dyskinesia, while the actual focus should be on achievement of individualized goals. And there might be a role for, NF1 trial, single case design. And, these children are extremely complex, and providing treatment and care for these children are extremely challenging. And we have to rely on our own expertise and expertise of our colleagues while we are waiting for more and more further evidence to come. But the most important thing is, children, there is never, in my experience, there's never such thing as an isolated spasticity. Whenever you come across spasticity, there is always an element of dystonia in it. And that's extremely important because it's all individualized. You take two children with periventricular leukomalacia, no two children are the same. The MRI might look PVL, the basal ganglia might be normal, but one child will have quite marked dystonia, while the other one won't have quite marked dystonia. The reason why I particularly mention spastic diplegias is because selective dorsal rhizotomy is a treatment for spastic diplegia. And going back to Denny Brown's work with monkeys, when the dorsal roots were severed, there still was uncontrolled involuntary movements. So this exactly the same thing we see with our children who undergo SDR, selective dorsal rhizotomy for spastic diplegia. They they come back with quite bad dystonia often, even when, pre-surgery, everything looked okay because the MRI looked fine, basal ganglia was uninvolved. Probably the spasticity was probably controlling the dystonia to some extent. And you take the spasticity away by SDR and the dystonia gets unmasked. So it is extremely important for the clinician who see cerebral palsy children that not everything that looks like spasticity is spasticity. There is always an element of dystonia, and unless we do the right treatment, it won't work. Spasticity treatment won't work for dystonia. Dystonia treatment won't work for spasticity. So going back to our child with chorioathetosis, for him, perhaps Botox injections to his upper limb would be the best way forward, because that would then help him improve his function and thereby improve his quality of life. For example, his goal would be to try and be able to use his hand to put something in a basket. And if we then give him Botox injections and then bring him back and ask him, like, how well can you do that? And that would be the indication to see whether our intervention has worked. What about, so this girl, this is again a dyskinetic cerebral palsy. So she can't control her movements. What would you do in that case? Spasticity treatment won't work in this case. What might work is anti-dystonia treatment. Perhaps we could try clonidine, perhaps we could try gabapentin, but we don't know. What will you use in our girl with the dystonic movements in the upper limbs? Now, so this particular lady, she has quite dystonic movements. She's cerebral palsy, but she's cognitively quite good. So she would be a good candidate for deep brain stimulation. And in fact, that's exactly what she had. She underwent deep brain stimulation. What about this boy who was periventricular leukomalacia, but he has got a mixed picture, spastic dystonic cerebral palsy? He would benefit from Botox injections to his upper limbs. He might benefit from Botox injections to his adductors, for example. He might benefit from some muscle relaxant, maybe baclofen, or even anti-dystonia medication. So it is complicated. There is no evidence that we can rely on. We have to rely on our expertise, but the real take-home message is, children with dyskinetic cerebral palsy tend to have more severe motor impairment compared to those children with spastic cerebral palsy, because this is what is affecting their function more. And spastic dystonia remains underdiagnosed. Combined presence of spasticity and dystonia makes treatment and medical interventions very challenging. So, and the treatment and the prognosis differs. There is no established gold standard, and there are very few interventions which are aimed specifically towards children with dyskinetic CP. We have the hypertonia assessment tool. We have to be particularly careful in children with spastic diplegia. Spasticity is harder to quantify. Too much focus on spasticity as a phenomenon at the expense of other forms. And when we set goals and expectations, they should be realistic and attainable to result in a better satisfaction. The dyskinesia toolkit for clinicians, which is available on the web, is an excellent resource which anybody can use in normal clinical practice. The AACP-DM has prepared a care pathway in 2016, but the systematic review, which I was mentioning, which got published in the last 2 weeks, eventually the idea is to come out with a revised care pathway to manage these children with dystonia. So at the moment, when faced with these children in our clinics, we don't have any evidence to go by. We have to rely on our own expertise and the expertise of our colleagues while we wait further evidence. But we always have to be thinking about the goals, functional goals, and also not just carried away by the focus on pure spasticity or pure dyskinesia. That is the one take-home message. Thank you.
Thank you, Dr. Biju, for that very simplified discussion on a very difficult topic. And still the how do we help these children? The challenge is still on. There are a few questions. I wish Kalpana Madam to take over and lead the discussion.
Thank you, Dr. Biju, for a very nice talk. And there are many questions in the chat box. First question that is mentioned is, can you mention the quantitative tools which you have already mentioned, but tell me something more regarding the these tools to assess the dystonia in children so that the studies may be better.
It is very, the kinematic measurements are there, but we don't use it in normal clinical practice. But I think it is easily doable. But there are difficulties because it involves videography of these movements, which are mainly two movements. One is tapping on the other hand, and the other is reaching out to an object. And as we all know, it might be difficult to get a child to do this, in all situations. But if we can, in cognitively okay children, well, that's what they do. So it's actually, you look at the speed with which the child is reaching out to the object, and in spasticity, the speed is less, while in dystonia, actually the speed is fast. They try and reach the object quicker because of the rapid movement. But when you reach the object and when you hold on to the object, they are unable to hold it there, so it moves around. So that is why, like the picture, which I didn't, I had to quickly change the slide because of time. But you look at the trajectory of the movement and you calculate the slope. You measure the slope using software, and then you also look at the pathway, like where you hold. And depending on which is more predominant, you can say like dystonia is more predominant or spasticity is more predominant. It's not rocket science, but I don't think it has come into everyday clinical practice. But although it would be quite useful if somebody can come up with a quantitative evidence saying like, oh, okay, so we did this test and we know that this child is more dystonic than spastic. That would be fantastic. But I don't think we are anywhere near that. We have to really rely on our clinical acumen for that, which is why, they say that in order to know pediatric neurology, you need to know cerebral palsy.
Okay, the next question is by Dr. Nitish Shora. He has mentioned that how we can manage spastic diplegia with crouch gait, because many times baclofen and Botox may worsen the condition.
Excellent question, Nitish. I know we always have this query as well. Now, there are lots of children who had SDR at Great Ormond Street who come back to us and are having Botox injections. And in fact, I know about one child in Europe who had SDR, who continues to have Botox, and then who had intrathecal baclofen as well. They had everything. You might argue that, so perhaps you were wrong in when you selected when you did your patient selection. But that's not because you do it in good faith and you wouldn't expect the dystonia to come out, but it does, because it is an entity. It is there. People have not really addressed it, but it is there, which is why with the spastic diplegias, it's very, very tricky, particularly the dystonia in the upper limbs following selective dorsal rhizotomy. And the reason why I say that is important is in children with spastic diplegia, we know that the arms are less affected. And when the dystonia affects the upper limb more, that is having a huge impact on their quality of life and function, which is a very important point. We just have to be aware. And sometimes, we take away the spasticity and then we have to continue managing, the sequelae, unfortunately. And then sometimes, orthopedic procedures as well. So the whole lot, it is difficult. Spastic diplegias are a very, very definite, interesting entity.
The next question is regarding the child with severe dystonia, but has minimum periventricular white matter loss and minimal or no involvement of the basal ganglia. So in these cases, we always tend to hunt for any underlying cause. what would be your approach in this case? And
that's a good question. I am sure like you would have listened to Dr. Kalpana's talk as well. And so always worry about your CP mimics. Always worry about your hereditary spastic paraplegias, which you might not find the gene, but it might still be there. So always look for CP mimics. But once you have excluded all the CP mimics, still if you are faced with this child, which MRI looks okay, have got a little bit of trigonal scarring, but not really like, well-defined PVL, the basal ganglia looks normal. We've had this query as well. We had this dilemma, but when we go back with hindsight and look at the scans, we often see that the thalami are small in volume. And we wonder whether like, does it mean anything that the thalami are small in volume? The whole white matter is small in volume, particularly in these preterms. So maybe the thalami are small in volume because of that. But small thalami, does it really affect the architecture? Does it really affect the thalamocorticostriatal circuits? We don't know. Because with our current imaging, we can't really say that there is, we can't really show an objective evidence for the dystonia. But it is there. It is for true. The hypothesis, and the hypothesis at least like we claim, is that it is to do with the corticostriatothalamo circuits, and it might be the thalamic architecture which is affected. So much so that when we see a child with PVL and when we see the thalami small in volume, we always keep in our mind that like there is a potential chance that like we would be dealing with superimposed dystonia.
The next question is by Dr. Mahesh Kamte, and he has mentioned that is the use of this orthosis, whether it will worsen the dystonia?
That's a good point. Thanks, Mahesh. Now, exactly. Again, it's all to do with quality, and if you have a child with quite stiff tendo Achilles, and you put them on an ankle foot orthosis, and then you come back to clinic and find that like, the foot is inverting all the time. And then that it is a problem because it's affecting the stamina, it's affecting the duration that he can walk, it is affecting his quality of life. But sometimes we can address it in a different way. For example, if the foot is inverting all the time, suggesting that the tibialis posterior muscle is active, then we can do focal Botox injections to the tibialis posterior muscle. And one of the goals would then be, okay, improve stamina. Second is improve splint tolerance. And then when they come back to clinic and say like, how was your splint tolerance? How long are you able to wear it now? And that would be the goal. And if that's achieved, then that's well and good. If not, don't use orthosis.
The next is a question based on your personal experience. That is a child with dystonia. How will you approach considering the best oral anti-dystonia medication in your practice based on the age of the child, the severity, the underlying pathology, and because DBS and all is still out of reach of many of us?
It depends. So the three medications which we use are, one is gabapentin, second is trihexyphenidyl, and the third is clonidine. We don't use anything else. We don't use tizanidine. We don't use tetrabenazine. Now, it's like in epilepsy, you tend to use, the saying is like you start on one drug, increase it to the maximum and see whether it works. And then if not, add another one. People used to do the same approach in dystonia, but it normally doesn't work like that, because the baclofen, for example, or trihexyphenidyl, for example, have got a very low threshold for adverse effects. So if you start on a small dose, and we always start on a very small dose and slowly build it up, and you might get a phone call within 2 days saying that like, the child is not sleeping. So then we know that trihexyphenidyl is a problem. Then there is not much point in persevering with it. Although some colleagues do suggest that perhaps if you persevere for a few days, like that might get better. But more often than not, it isn't. Once you know that it is not working, then you get rid of it and then try something else, gabapentin. And you should not shy away from using two medications at the same time. You could use gabapentin along with trihexyphenidyl. And one particular point about the gabapentin is you should not be afraid to use quite high doses. We used to use up to 90 milligrams per kilo per day, but after concerns that when the children are on other sedating medications, you have a respiratory depression problem. So at the moment, we don't tend to go above 60 milligrams per kilo per day. Clonidine, we often reserve last. The reason is clonidine tends to work better when there are more hyperkinetic movements. And also, as you know, the issue with clonidine is the sleepiness and also the potential issues with blood pressure dropping. And when we do start clonidine, we always bring them in for a blood pressure trial to see after a couple of doses of clonidine. And if it works, then continue. But personally, I prefer gabapentin over trihexyphenidyl because the anticholinergic side effects, and if you know any adults with Parkinson's or who are on anticholinergic drugs, and you can ask them, like, how horrible it feels to be on an anticholinergic, and it's not nice for these children who can't really feedback to us, which affects their sleep and everything. So personally, I like gabapentin, and then we tend to go for clonidine. But there are colleagues who sometimes use trihexy. Sometimes it works, but there is also this risk of adverse effects. Everywhere, like the main problem with these medications are the adverse effects. So on one hand, the adverse effects, the other hand, there is no evidence. But we are in a very tight situation.
So the next question is on hyperkinetic movement disorders in cerebral palsy. Here, can we use the dopa blockers like the antipsychotics? Are you using it like that?
We can, but there is no evidence. And with the hyperkinetic movements, one thing to note is the choreoathetoid movements, they do not impact upon the quality of life. It can be quite bizarre to see. It can be quite distressing to see with all the flailing arms and legs. But in terms of the quality of life and function, what studies have shown is that it's often the dystonia which is worse than the actual dyskinesia. But yes, you can use medications, and tetrabenazine particularly, if the chorea is the predominant problem, then tetrabenazine is good, because the anti-chorea efficacy of tetrabenazine is due to dopamine depletion. But the risk of depression, for example, is mediated by serotonin and the norepinephrine depletion. And you also get sedation, which is by histamine depletion, for example. So the reversible depleter of monoamines, they don't just work on dopamine, they also work on serotonin, they work on norepinephrine, they work on histamine. So we have problems with that as well. But we use tetrabenazine usually in the intensive care setting, particularly children who've been on the cardiac bypass, and then when they are coming out, they often have the pump chorea, and tetrabenazine sometimes work very well for that. But more often we use clonidine. If that doesn't work, then you go for tetrabenazine for the hyperkinetic movements. This is in the context of cerebral palsy, not like normal chorea. Yeah.
And this is the final question. It's the dictum that in all children with spasticity, especially lower limb spasticity and dystonia, a trial of L-DOPA should be given, like at least for 3 months. So if we are very clear that the diagnosis is not L-DOPA, DOPA responsive dystonia, then should we use it? Because 3 months is a comparatively long time. So that the dystonia, if it is not coming down, then what is the point in doing it?
Now, that's a very important point, that the point is you should not use it for a short time. If you are planning to use it, you should use it for a good period before you write it off. Because you never know whether you are dealing with a dopa responsive dystonia, and that dopa responsive dystonia, as we all know, is the greatest masquerader. In fact, there was a poster as well which says like the masquerader. So we always use it, but when you use it, don't have a half-hearted approach. Use it for a couple of weeks and then stop it. Use it for a good dose, good 2 months, 3 months, and then write it off. But particularly when you are faced with children with cervical dystonia, you should always use it. It's quite we always use it. We always give a trial of levodopa, because yes, side effects can be a bit debilitating, but often they tolerate generally, and you should use it for a good period of time before you write it off. But absolutely right, you should always think about treatable conditions and other mimics. Absolutely.
Thank you, Hamid, for an excellent talk as well as a very interactive session. And over to Dr. Riaz for the concluding session.
Thank you, Madam. As Madam commented, it was a very excellent discussion. So many questions had come up. And may I add one point, because counseling also is very important in managing these children, because we know that our armamentarium is not enough to treat these children fully. So being empathetic to the parents and as Dr. Biju had discussed, make some targets which are achievable, which are realistic. And that should be the way forward, and we should give all the supports to the parents.
That's a very important point, Dr. Riaz, because I have parents who have children with massive spastic dystonic GMFCS5 children who are not on any medication. The reason is when you speak to the parents, they will say that yes, he is moving all the time. He hits his head on his headrest all the time. He thrashes about. His legs have to be tied up. His hands have to be tied up. But I can see light on his face. He is awake. Before, when you were drugging him up with trihexy and gabapentin, yes, he didn't move, but my son was not there. That's an important point. I would rather have him awake and thrashing than completely drugged up with no movements whatsoever. It's an important point.
Thank you, sir. And I think this is the concluding session. Over to the anchor for taking us forward to the valedictory function. Thank you.
Thank you, sir. That was a wonderful session. To conclude, there are certain moments when human contrived words fail to express the feelings. I am in one such moment. After 3 consecutive days of intense brainstorming sessions of the 11th annual conference of AOCN, we have successfully reached the flag end of the conference. As the time is 2 p.m. Indian Standard Time and many hungry stomachs are waiting, we are moving on to a short and precise valedictory function. I am honored to invite Dr. Bennett Salem and Dr. P.A. Muhammad Gun for the welcome address.
I request our Organizing Secretary General, Dr. Bennett, to welcome the gathering.
Good afternoon and greetings from Trivandrum. Respected Muhammad Gunju sir, our organizing chairman, AOCN President Dr. Anita Hegde, AOCN President-elect Dr. Shefali Gulati, ICNA PDA Editor Dr. Biju Hamid, IAP National Executive Board Member Dr. Riaz, IAP Secretary Dr. Praveen KS, Scientific Convener of AOCN Dr. Kalpana, KIMS Deputy Superintendent Dr. Pramila Joji, our own souvenir committee members, especially Dr. Bindusha, Dr. Prashant, Dr. Amit, my own colleague, Dr. Mini, all the faculties and chairs who participated with the full cooperation for the conference. We had 3 days of hectic days and we did hopefully well. And always the participation were more than 200. And thank you all. And it only because of our members and our delegates, we could succeed in this conference. I welcome you all for the valedictory function and thank you very much. Over to Kunju sir.
I think it was a nice welcome just from Dr. Bennett. And I think I'll keep my words at the end so that our dignitaries, Dr. Anita, Shafali, all can say their words. Okay, to the next person. Bennett, continue the session.
To talk about the souvenir, I invite with much reverence Dr. Kalpana and team, constituted by Dr. Bindusha, Dr. Prashant KS, and Dr. Amit Kumar. Over to Dr. Kalpana.
Good afternoon. It is I'm just sitting here on behalf of our souvenir committee. Actually, I didn't do anything. I was just supervising, and all the people, Dr. Bindusha, Dr. Prashant, and Dr. Amit did everything. And the 250-page souvenir is ready on the day of conference itself. So I invite Dr. Prashant to say something on the souvenir, which has come out so beautifully.
Thank you, madam. A very good afternoon to all of you. It has been a privilege as well as an honor for all of us in the souvenir team to be associated with the organizing committee. With the help and cooperation of all the faculty and the entire organizing team, we could actually come up with a 250-page souvenir early on time. To speak more about the souvenir, I would like to invite Bindusha madam as well as Amit to share a few words. Over to Bindusha madam.
Good afternoon. Actually, it is a privilege to work in this international conference. I would like to thank the organizing team, especially Kunju sir, Bennett sir, and also Mini, to give us an opportunity to bring out this souvenir of this international conference. It was a very good experience. And also, I would like to thank my team, especially Dr. Amit and Dr. Prashant, who did most of the work. Actually, even the whole layout of the souvenir designing, everything was actually done by Amit and Prashant. Thank you. It was a very good experience working with them. Thank you.
Amit, if you...
Yeah, good afternoon, everyone. At the outset, let me thank the organizing team for giving me this opportunity and entitling a role of this humongous task of making the souvenir. And I again thank Kunju sir, Santosh sir, Mini madam, Bennett sir, Biju Hamid sir, Praveen sir, and the entire team behind the conference. I thank the IAP Thiruvananthapuram, AOCN, ICNA for giving me this opportunity. And I'm glad to note that the conference was a grand success. And coming to the souvenir creation, I'm greatly indebted to the team of Kalpana madam, Bindusha madam, and Prasant sir, who guided me in each and every steps of the editing process. And I'm really happy that we as a team had the perfect sync and could release this 250-page souvenir on time. Thank you so much.
Next, I invite Dr. Anita Hedde, the current AOCN president, for the release of e-souvenir.
Good afternoon, everybody again. It is with great honor and pride that I would like to release the e-souvenir of the AOCN 2021 conference held in Trivandrum. I think we can go on from here. Thank you.
Yes, Dr. Amit, you'll be sharing the.
Yes, sir, we are sharing, sir.
Hold on for a couple of seconds. We are having a technical problem here.
Okay, I think I must welcome Dr. Shefali, our incoming president. Welcome, Dr. Shefali. By the time they are releasing the souvenir, because I'm happy that the great academician, Dr. Shefali, is taking over as the president after 2 years, and now she will be the president-elect, working with Dr. Anita.
So should I speak right now before we'll have the video on first?
I think they're trying to. Trying to release the.
Yeah, I think I'll just wait. I'll just wait. Yeah, it'll come. Yeah, it'll come.
May I request Mini Madam and Bennett sir also to switch on their videos. Without them, the picture doesn't look full.
Okay, so that was a fantastic effort from Dr. Bindusha and the team. I congratulate, because this is a mammoth souvenir, because more than 250 pages, all the abstracts and others are completely included. And all of you can have the presentations as well as the abstracts from the ICNA Child NeuroCon website as well as the AOCN website. So it is my privilege to welcome Dr. Shefali Guladi, the professor and in charge of Pediatric Neurology Division of All India Institute of Medical Sciences. Currently, she is the president of Indian Academy of Pediatrics Neurology chapter. So a rare honor for a person like Dr. Shefali Guladi to be at the helm of two organizations. So immediately when she gets out of IAP neurology chapter, so that means she can do a lot, because she can plan in advance. First, she can do her activities in the pediatric IAP chapter, then it can be continued through the AOCN. So I welcome Dr. Shefali.
Thank you, sir. Thank you for the kind words. And in addition to this, I also have the responsibility of the INSAR Global Senior Leader for India 2021 to 23. So it's a lot of added responsibility. Good afternoon, respected Professor MKC, sir, Professor Kunju, Dr. Anayata, Dr. Bennett, Dr. Mini, Dr. Biju, esteemed faculty and dear friends. As we look forward to building a new normal after the COVID-19 pandemic, which has created havoc globally and still continues to be a challenge, we have had an amazing feast for over the last 3 days, for which I would like to thank the whole team led by Professor Kunju, Dr. Bennett, Dr. Mini, and Dr. Biju. Pediatric neurology in India is still in its infancy and has been advancing rapidly over the last few years. Association of Child Neurology was envisioned and conceptualized by Professor Veena Kalra, my mentor, in May 2002. And I was lucky to be a founder member, along with Professor Pratibha Singhi, Professor Satinder Raneja, Professor Vivek Talukdar, Dr. Rekha Mithil, and Dr. Tarun Dua. In the last 19 years, AOCN has come a long way with expanding membership and has played a vital role in development of child neurology in India. I take much pride in being the part of the team which started the first DM pediatric neurology program in South Asia in 2004. And we have had 41 alumni and 25 national and international trainees from across the globe, including USA, UK, Kenya, Sweden, and the neighboring SAARC countries. The curriculum we had developed in 2004 has been the guiding curriculum for all pediatric neurology courses till now across India. Thereafter, PGI started DM in 2011, and they have had 13 alumni. MCI recognized DM in 3 institutes in 2019. All these trained professionals, along with many seniors who had been working for years on focused and specialized work of pediatric neurology, have been disseminating child neurology not only in India, but also in the SAARC region. I thank the preceding EB team led by Dr. Rekha, Dr. Suhasini, Dr. Jayashankar Kaushik for the excellent work accomplished despite the pandemic. I'm happy to be the part of the new team and would be working towards achieving the goals shared by Dr. Anayata and Dr. Kavita in the inaugural session this morning to the best of my capacity. My vision for the AOCN is for it to be the premier society for pediatric neurologists in India and globally, promoting the highest quality patient-centered care for children with neurological disorders and neurodiversity, and supporting the professionals' development of each of its members. I remain deeply committed to the development of clinical academic medicine in child neurology in India. The association would focus on the trinity of clinical care, academics, and research. It will promote advocacy, evidence-based medicine for both families and professionals, provide members with platforms for improved networking, communication, and mentoring opportunities to help advance their career goals, lead and guide how we adapt and respond to the evolving challenges in post-COVID era, develop and maintain an efficient world-class training system to foster the future generation of child neurologists in India, facilitate the capacity building of research institutions for education, research, and international cooperation, and develop networks for the same. I have been successful in forging a number of collaborations with prestigious universities and associations, both nationally and internationally. I hope to take these collaborations to all the members of the AOCN. I'm extremely grateful to your support to help me take the legacy of my mentor, Professor Veena Kalra, forward. Looking forward to meet you all in Ahmedabad, hopefully in person and not virtually, so as to enable us to enjoy the famed Gujarati hospitality. Please stay safe. God bless. Thank you so much.
Now it is, thank you, Dr. Shefali, for your kind vision and the nice words. Now I think it is a time for Dr. Biju to declare the results as well as say his feelings about the conference.
Thanks very much, Kunju sir. It's been a great play. It's been an experience like no other, because I remember when it started and we could see how the program developed, and now we are at the end of it. And looking back, it is indeed a proud moment. And I don't think this would have been possible if it was not for the IAP team and one person in particular, which is Mini. and I can't like thank her enough for the support that she has given to this Congress. And I don't think it would have happened without her this way. I'm absolutely certain. So hats off to you, Minnie. Particularly the couple of things which I was particularly interested. I wanted to mention that the scientific rigor with which you approached the program, which is excellent and has to be commended. And I think that you have set the standard for how things should be held. And also, you have gone out of the way to make sure that every little thing is attended to. All the WhatsApp messages and emails that we have exchanged and everything, it just shows that how sincerely you were on the job. Absolutely. So thank you very much for that. And I think we should continue to keep this collaboration going. Now, I have been given this enviable task of announcing the winners. Now, I don't think we have a winner yet for the posters, but we do have winners for the platform presentations. And I think Dr. Mini has suggested that we might be able to announce the poster winner at the workshop, which is coming soon. So the way the presentations were judged were on the originality and creativity of the presentation, the organization, which is the logical presentation of the ideas, of course, the oral diction and the delivery, and of course, knowledge of the material and familiarity of the subject matter. And it was indeed a difficult task to select the one or two from among the 10 which were presented on the first day by the residents. And I think these the residents have to be commended, because this happened right in the COVID period, and when the abstract announcements had gone out, and they were all busy with their COVID duties. And it is a huge ask to meet these deadlines, to collect the data, which they were already doing, but then to like put everything together, prepare the abstract in a good way and submit it to the Congress. And we all have done that, and we know how difficult it is. And when you are in the COVID duty and other things, and it is a huge ask, but they did do it. And that shows like the quality of the presentations stands testimony to that fact. So the first day were the presentations from the residents, and the judges have selected 3 presentations from the first day. Let me just make sure that I say the right one. 1 second, I just have the numbers here. So so there were 3 prizes, I was told, first, second, and the third. The third prize goes to Brahmini Korai, who is doing her DNB pediatrics at PD Hinduja National Hospital, who did the excellent talk on predicting the seizure risk in epilepsy patients who have been seizure-free and who are now off anti-epileptic drugs. And the second prize goes to a second-year postgraduate student from Lady Harding, who talked on effect of counseling regarding SUDEP, and that's Dr. Sneha Kumari. And the best presentation from among the residents, which was unanimously selected by the judges, was a senior resident from PGI, Chandana Bhagwat, who did an excellent presentation on the utility of GMA in predicting neurodevelopmental outcomes of late preterm and late preterm infants exposed to severe hyperbilirubinemia in the neonatal period. So those were the 3 from the residents section, and congratulations to all 3 of you. They were all good. They were all good. But these 3 were marked out as the best top 3. Now, the second day, so those were presentations from the practitioners, and there were again excellent presentations, very relevant presentations, and there were 2 which were particularly, well, 3 which were particularly good, but I was told that there's only 1 prize. Am I right, Dr. Mini? But I think I have to mention all 3, and perhaps
No, they will have a cash prize for the first one, and
from AOCN for the second and third. Dr. Rekha Mittal had agreed, and hopefully NHI madam now has taken over, will consent to that, to give a certificate of appreciation using the AOCN letterhead to those who won the second and third prize for the paper presentations for the consultants.
Absolutely.
So the best presentation, again, like based on the criteria that we have selected, and based on the judging points, I think the best presentation goes to Dr. Kavita Srivastava from Bharati Vidyapeeth, and we all know Kavita, who did the epidemiological survey of epilepsy in rural suburbs, and identifying a significant treatment gap. That was an excellent presentation. The other 2 presentations which are commentable are, one is from Renu Sudha from PGI on the efficacy and safety of levetiracetam versus phenytoin. And that presentation was particularly good for its scientific rigor. That was a good one. And there was another presentation which is highly commentable, which is the one by Dia Susan Jose, an occupational therapist at Sri Chitra, for her presentation on autism spectrum disorders, the barriers experienced by caregivers in implementing home intervention program. Thank you.
The results will be declared during the master class by Kunya sir.
Okay, I think now we have just completed our official initial part of our valedictory function. Now it is going to be the most important part. I think we have Dr. Pramila Joji here. She is the person who has done an excellent supportive act for our conference. I request Dr. Pramila to address the attendees.
Very good afternoon, Kunju sir and team. I'm really sorry I was not there. I really missed the excellent conference from the enthusiasm which is there on the face of my postgraduates. I know till now they are all bright as ever, and it is a good show. Kunju sir, whenever there is Kunju sir and Kalpana madam, Mini madam and the team, you can expect wonders. Really proud to have all my team members doing excellent job nationally and internationally. And really wishing you all success in the future endeavors also. And Kunju sir, again, hats off to you, your vigor in academics. I don't know, you're always like a first year PG student when it comes to academics. Always enthusiastic. Bennett sir and the rest of the team. Dr. Biju, I heard the last part of your talk, and the rest of the team, it was excellent. And congrats to their team. Please hosted it. Thank you very much.
I think thank you, Pramila. I just because being in Kerala, I'll just show a few shots of Kerala, because I am in Alapi now, where just staying in a hotel for another conference. Neurological Society of India Kerala chapter is having the conference. So for the international faculty and for Biju to remind of Alapi, I'll just show the view from my hotel. One second, that's all. Okay. So thank you.
Thank you, Kunju sir.
Okay. Now it is the turn of others. Can Bennett take over and introduce others who are in line?
Also, also Kunju sir, there are, I have to, if I may, like couple of seconds, there are few other,
definitely.
There are a few other people who I have to particularly mention. I think it would be a failure if I don't do that. And one is Bennett sir, because he has rung me several times during the arrangements, and the way he has approached it was quite masterclass. And absolutely, he was quite he was always very polite and apologetic, which he shouldn't be, because when I joined Toronto Medical College, we had the combined social. We were the incoming batch, and Bennett Sars was the outgoing batch, and we had a combined social at the time. And it was a great opportunity to meet again, and this way. And I'm sure, I've made lots of new friends. So I have to particularly commend Dr. Bennett sir. Thank you very much, Bennett sir, for that. The other two people are, one is the one person who has been working behind the scenes, and I don't think he's one of the unsung heroes here, who is Dr. Deepak. It's very important. And also Praveen, who helped me with the technical settings, etc. So that's very important. And also Dr. Mohan, who we don't actually realize how important the propaganda is, and I think the way he carried out the social media things, and I think that's his forte, and then he did it very, very well. And again, that shows the number of registrations we had. So the whole IAP team was fantastic, but I have to mention a few names, and I think otherwise it would be a miss. Thank you.
Okay, I request Dr. Praveen. Praveen, are you there? Praveen, to address the.
Sir, he's duty, so he left because one call was there. And
okay. Now
his connection is not there.
Okay. Now Riaz, are you there?
Yes.
Yes, sir.
Okay. Please address.
Sir, like always, when something is organized by Kunju sir, it will be great that we know from the beginning. And this time, actually, we all remember the Kovalam conference, which Kunju sir and Dr. Biju together organized, and we always supporting. And we all thought about a similar event, actually a face-to-face event itself. And we decided that it will be led by our Bennett sir and Mini Madam, and we will have a blast. But apart from that physical meeting, we all had all the other things about the conference, because it was like a something actually happening live. We all felt that feeling. And I think we have made an excellent digital material. And with that souvenir, there is also a pediatric neurology textbook, which you all had made. So hats off to the team. Again, as everyone was telling, the Bennett sir and the Mini Madam duo had clicked. I think a great salute to both of you. Thank you. Thank you.
So shall we go for vote of thanks?
Yes. I think we'll. I request Dr. Mini to say the conclusional remarks.
So, distinguished faculty, dear delegates. Finally, we have reached the end of the 3-day-long academic fiesta, Child NEUROCON 2021. Now it's the occasion for Thanksgiving to all those who worked in front and those who toil behind the scene to make this virtual congress a great success, with over 1,500 registration and an audience strength of 300 plus at any time during the webinar. This is a matter of great pride for all of us in the organizing team and shows the phenomenal success of this venture despite not being a physical meeting. As the organizing secretaries on this of the conference, I and Bennett sir take this opportunity to thank the AOCN officials for giving us the opportunity to host this conference from Trivandrum and blessing us with all support and guidance from time to time. We express our sincere gratitude to the International Child Neurology Association for arranging the logistics of the platform for this meeting and meticulously executing the event in a flawless manner and providing us with the platform as well as the website created by Dr. Biju. We are deeply obliged to our overseas friend and valued colleague, Dr. Biju Hamid, for his untiring effort from day one of planning to this time. On this occasion, we thank his better half and children for sparing his valuable time and energy in pursuit of this conference over the last 3 months. The success of any conference depends upon its scientific content. The highlight of this conference was the very informative and the lucid presentations by the distinguished faculty who had vast experience in the topics which they were dealing with. We sincerely thank the entire gamut of our esteemed faculty, national as well as international, for sharing their wisdom with the delegates and making the conference a grand success. We appreciate the enthusiastic participation of the residents and the practitioners for the paper and e-poster sessions and thank each one of them for being part of this Congress meaningfully. We are grateful to the judges who have taken pains to go through the abstracts critically and evaluate them in a platform presentation. Thanks are due to the chairpersons and moderators for steering the sessions diligently, adhering to the time management. The organizing secretaries, as organizing secretaries, we are deeply indebted to Kunju sir, the organizing chairman of the conference and our teacher for his valuable guidance and inputs from time to time. The team IAP Trivandrum led by our teacher, Santosh Kumar sir, provided immense support for the organization of this congress. We are greatly indebted to all the members of team IAP Trivandrum who supported us with manpower and their ideas how to go about this congress. We also take this opportunity to thank the state IAP officials under the leadership of Jayaraman sir, the neurology chapter of IAP under the leadership of Rajagopalan sir, the NEBM Dr. Riaz for the involvement and support. Our sincere thanks to Dr. M.I. Sahadullah, the CMD of KIMS Health, for providing excellent ambience and assistance to conduct the scientific sessions in a hassle-free manner. Words are not enough to thank Dr. Premila and her team of residents of KIMS Health and the IT team for the manpower and the technical support they rendered through the days of Congress, which actually helped in the hassle-free conductance of this Congress. Last but not the least, we take this opportunity to thank each one of our team members for their sincere involvement and excellent teamwork for making this Congress a grand success. Thank you all. Jai Hind.
So it is time to sign off. I'm very happy that there is no technical problems and we were able to continue the program in a very, very successful manner, because on the day one, we thought that there may be problems with the connectivity and other things. Anyway, because of the ardent support of Biju and the KIMS team, again, I think KIMS the technical team, the IT team has done an excellent job by providing their support, being with us continuously. So I take this opportunity to thank them, because already Minnie has emotionally thanked everybody in the fullest extent. And I thank the AOCN once again for providing us allowing us to do the conference in Trivandrum. And ICNA headed by Jovim Hurst, the secretary Pratibha. Pratibha Singh, I was trying to contact her now also. I couldn't get her. she is the secretary, and again, she is going to be the incoming, she is the incoming president of International Child Neurology Association. So we are, Indians are making strides in pediatric neurology all over world. And we are happy that Anita, who is the IGNA Executive Board member, is our president also. I think I have to thank Praveen. Praveen also, I was trying to contact him now also, but somehow he is not there. But again, he is the silent warrior, because we must say that he has conquered this program in a very, very successful manner, because again, his technical know-how has helped Trivandrum, helping Trivandrum IAP, and now this conference, his technical support has gone beyond boundaries. That is it. So I thank all. And again, as mentioned, Dr. CB also has to be mentioned here. Then Amit and his team, Prashant is there. I think Prashant also must have spoken a few words. Again, he is the one, our souvenir person. So we have a team. They all do their work excellently, guided by Dr. Yas, Dr. Santosh, and others. So thank you again. Bindusha is our permanent, I think now she has become the permanent souvenir editor. So all of you can see her hand in the souvenir. Again, we are into AOCN is going in the hands, Anita, and then with the support of Shafali, I think the next conference also going to be a very good success. But we are not completing our program now. We will be asking all of you to log in again next Sunday, that is on April 18th by 1:30 till 7. We'll be having our program. So all of you, please mark the calendar. You set your alarm and join on next Sunday, that is April 18th, at least by 1:30. Thank you.
So one last word to the pre-conference workshop, which was the idea, master brain behind was Bennett sir. Thanks to him for conducting that in an excellent manner with the support of NIMS, Spectra, Medicity, under the guidance of MKC sir, and also thanks to Dr. Mary Ipe and Dr. Maya Thomas who are about to conduct the master class. So thanks.
Actually, we want to see one group photo with the PGs who are there. Actually, I wanted them to speak a few words, since already the vote of thank is being delivered. It will be superfluous for them to speak, but I would like our esteemed president, Dr. Anita and Shefali, to see our PGs who have done an excellent job there. Please come to the camera, students. All of you, please come to say hello to your teachers. And you must be taking a pediatric neurology names or PGI or other centers. They are all very excellent students. And KIMS has a 100% pass in DNB every year. That is by Dr. Pramila's mentoring. Okay, I think now I think I think none of you had your lunch, isn't it? Because already it is 2:30. And okay, so shall we say? Okay, Arati also has come there.
Looks like Kunju sir had his lunch and he's relaxing.
Yes, definitely.
Look,
I had my
Kunju
lunch,
sir,
that
I
is
thought
why
you
I'm
will be
relaxing.
sending, I thought you'd be sending food by parcel, because I heard in Kerala for all the weddings, the food was being sent home as packages. So I thought maybe you'll send it to the faculty,
Yes,
right?
yes, actually,
Can be arranged by Zomato.
Actually, this
Dr.
August,
Naida should have happened, right?
Yes, correct. Actually, this August, my daughter's marriage was conducted, and for all, I packed and sent lunch to them. So I think let us see. We'll celebrate in some way. We will celebrate in some way. Okay. Okay.
Thank you. Thank you very much, everybody.
Thank you.
Amazing program.
Okay.
Bye.
Okay.
Bye. Bye.
Okay.
Bye. Thank you. Thanks.
Okay. Thank you, Biju, once again.
Thank you.
We log in continuously. Okay. 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 Okay, then. It's time to say goodbye.
Goodbye, sir.
Goodbye.
Biju's looking post duty. He's looking post duty. You're looking post duty. Not he's looking
he
post
has
duty.
aided at
He's
least,
not slept. He's not slept.
No, slept for the last 2 weeks.
Nobody ate. No,
At
so many
least,
days.
at least
Yeah,
for 2 weeks. I didn't sleep only for a day, but
Sir,
other days I was sleeping.
Sir, but you're sitting in LEP. Sir, you're sitting in LEP. So bad, I love that backwaters area. So it's so bad. And my residents are down with COVID. My residents are down with COVID. So it's really unfortunate situation.
Yes. Actually, I took the courage of traveling. Okay.
Sir, you are going on showing this to make us feel jealous. But you stay safe. You stay safe. You stay safe. Yeah.
You can see that.
Thank you. Thanks. Thanks, Dr. Mini.
Yes.
Dr. Mini.
Okay. Bye.
No, sir, you should not show photo. One should be sitting. One should be sitting in the boat, not seeing through the Zoom, right?
Okay.
Sitting in one, having a home food.
Maybe after some
Thanks,
time.
sir. Thanks for everything.
We will be having the monsoon summit in Cochin. So maybe for that you can come. Okay.
Okay.
Thank you.
Thank you, sir. Thank you. Thank you, Dr.
Thank
Mini.
you.
Thank you very much.
Thank you.